Hello.
Dr.
Hello.
Fatima,
All
good
right. Good
morning.
morning,
I can hear you
everybody.
loud and clear.
All right. Thank you. I'm just able to hear now. You are welcome again today to another, is this scintillating, I would say, or motivating lectures. I hope we all enjoyed yesterday's session. We're opening this morning again for another round of educative lecture. I'll be handing over to Dr. Olalere to present the speakers. Sorry, I'm Dr. Fatima Abibadeyemi. Yeah, thank you. Dr. Olalere, over to you, please.
Dr. Fatima, my
Yes,
name is Dr.
please.
Olalere. I think maybe we could just go ahead and I'll start introducing our first speaker, Assistant Professor Jessica Opono Anane, who is going to be talking to us about adenomyosis, the management dilemma in minimal access surgery. If she's available or if her presentation is available, maybe we can just move ahead to introducing her before the presentation. Okay. All right. So Prof is available. So maybe we should just go ahead and you could go ahead and introduce her, Dr. Halim Fatima, while we wait for Dr. Halim. Thank you.
All right. I don't know if Dr. Abayomi has I don't have itinerary with me. I should have said you are a doctor from so please. I don't have all those ones with me.
That is okay.
Good morning.
All right. Okay, Dr. Larry has come on board. Thank you for coming on board. Thank you. Yeah. Go ahead, please. Okay, Doctor, that was what I was going to say. Dr. Ajayi. Sir,
yes.
Sir, you can go on as well.
Okay. Good morning. Good
Thank
morning.
You, sir.
Yes. Good morning. So today it's where you're welcome to academic session 4 of the AGIS conference, and we have an interesting topic before us: adenomyosis. And today we are going to bridge geographical divides to tackle the complexities of adenomyosis. We know that adenomyosis brings pain and uncertainty, and it affects relationships, careers, and overall well-being of women who suffer from this condition. And we hope to shed some light on this condition today, and we've gathered very reputable scholars to do that. And the first speaker, who is going to be talking about adenomyosis, the management dilemma in minimal access surgery, it's no other than Professor Jessica Opoku Anane. She's a minimally invasive gynecological surgeon at Rutgers Health Robert Wood Johnson Medical School in New Jersey. She's a specialist in uterine fibroids, endometriosis, and advanced gynecological surgeries. She performs laparoscopic, robotic procedures, and she trained at Johns Hopkins, Harvard, and George Washington University. She's really, and more importantly, she's a sister. She's just from our next door. So, so it's my pleasure to invite Jessica. Please, Jessica, you have the podium. Thank you so much for being part of this.
Good morning, everyone from New Jersey. Here it is 3 a.m., so I apologize if you see my mother in the background with my baby, because she doesn't understand what is going on right about now. So I'm going to talk to you about adenomyosis. Let me share my slides. Okay. I think you can see my slides.
Yes, we can.
Let's take this here. All right. So as an agenda, what we're going to talk about today, I'll give a little bit of background about adenomyosis, although I think most of the people on this call are aware. We'll talk about the definitive management, some fertility-sparing options, the outcomes that we can anticipate with the different surgical procedures, and then talk a little bit about concurrent endometriosis, which is so common with adenomyosis. So this is my background, and we talked about that. In terms of adenomyosis, it's invasion of an endometrial stromal and epithelial cells into the muscular wall of the uterus. The major issue is that it's difficult to surgically excise given its unclear planes and its often diffuse nature. So unlike a myomectomy where the fibroid has a nice capsule around it, the adenomyosis often there is no capsule. It's hard to distinguish between the layers and therefore hard to resect. Resection is often a little bit more bloody, and in addition to the planes being difficult to find, and then it can often be hard to put the defect back together because of this situation. It is associated with dysmenorrhea, chronic pelvic pain, and abnormal uterine bleeding. And additionally, increasing literature shows negative fertility outcomes, including infertility and miscarriage, as well as adverse pregnancy outcomes, such as preeclampsia, intrauterine growth restriction, low birth weight, and placental abnormalities. The management of adenomyosis is really dependent on how much adenomyosis is present. It's whether it's a localized lesion or more diffuse, as well as the fertility desires of the patient. If the patient no longer desires fertility and has completed their family, a hysterectomy is the obvious solution because it provides a definitive treatment outcome. And there is actually less morbidity associated with hysterectomy than with the fertility sparing procedures, surgical procedures. In terms of fertility sparing procedures, if there is a localized lesion, we can do an adenomyoma. And for this presentation, I'm focusing on the procedures that we're more commonly going to do by minimal access surgery. So the most common being adenomyomectomy, and that's because we're so comfortable and familiar with, or we're more comfortable and familiar with laparoscopic myomectomy than we are with some of the other fertility sparing procedures for adenomyoma. However, if the lesion is more diffuse, there are other procedures that can be performed, non-excisional techniques like uterine artery ligation, high frequency focused ultrasounds, or hysteroscopic procedures. Those procedures are, besides the hysteroscopic procedure, the HIFU and the uterine artery ligation may not be ideal in those who are desiring to get pregnant, although there is early literature suggesting that it might be okay as well. And then there are cytoreductive surgery. I practice in the United States and also in Ghana. Most of the time, the procedures that we are performing are wedge procedures or adenomyomectomy procedures, but there are other prescribed procedures like the triple flap, the transverse H, push technique. Most of those times, those are performed as open procedures. In terms of hysterectomy, it's the gold standard. It allows both for pathologic diagnosis as well as what we say definitive treatment, but even with a hysterectomy, only 88% have improvement in their bleeding and their chronic pelvic pain, and it's probably because of concomitant or concurrent endometriosis that's present at the time of hysterectomy for adenomyosis, and I will talk a little bit about that later on in the presentation. So I suggest that the route of surgery for hysterectomy for adenomyosis should always be laparoscopic, robotic, and open, and we should avoid doing a vaginal hysterectomy for adenomyosis, given that the rates of endometriosis are quite high with adenomyosis. In terms of fertility sparing options, the goal is to remove the bulk of adenomyosis, to preserve the endometrial cavity, to be able to put the uterus back together in a way that decreases the risk of uterine rupture, and to preserve the function of the ovaries and the fallopian tubes. Again, I mentioned that there's multiple fertility sparing options, laparoscopically or robotically. The procedures mostly performed are wedge procedures or adenomyomectomies, but even these studies are limited. The most data available is for laparoscopic adenomyomectomy, but this case series is only about 102 patients. It's the largest case series. From that, 31% of patients achieved a clinical pregnancy. There were no uterine ruptures and 2 accretas. And another smaller study of 32 patients, 51% of the patients achieved a clinical pregnancy, 41% a live birth, and there was 1 uterine rupture. If we look at wedge resection, those numbers, those studies are even smaller, but 72% clinical pregnancy and 50% live birth. When we look at some of the other procedures more commonly done in an open technique, although the double flap procedure has been described as a laparoscopic procedure as well, the live birth rates are very variable between in the 30s to the 70s, and most of them report no ruptures, but I think that might be reporting biases. There's so few studies that are reporting these techniques. In terms of adenomyomectomy, it's the gold standard for localized lesions. Again, usually done laparoscopically, robotically, or open. These lesions can be quite extensive. This is a lesion that I took out 2 years ago. And if you can, generally, for the adenomyomas, oftentimes they are involving the posterior cul-de-sac. It requires dissection of that full posterior cul-de-sac first to release the lesion before you can identify it well. As you can see, for this, the whole back wall of the uterus is involved with this adenomyoma, and so the repair is often the challenge to put it back together. I try to repair these at least in 3 layers, but oftentimes the tissue is not very good. So we do worry about the risk of rupture in our group. We're looking at the rates of accreta subsequently after these procedures because they can be quite extensive. Fertility, pregnancy outcomes, however, are very variable. In terms of delivery rates, they range anywhere from the 20s to the 70 percentile. And uterine ruptures are ranging anywhere from 0 to 12%. If we look at just prospective studies only, the rates of live pregnancy rates get a little bit better, approaching closer to 75%, 50 to 75%, and there have been no reported uterine ruptures. If we look at instead dysmenorrhea, chronic pelvic pain, and abnormal uterine bleeding, most patients do respond to adenomyomectomy. About 50% of patients will have some improvement in their pain and bleeding. So the procedures do work. They can just be challenging to complete well. There's also hysteroscopic resection, which can be done. I use personally a bipolar resectoscope in order to resect my hysteroscopic adenomyosis. Other people have described other techniques using hysteroscopic scissors or a needlepoint. This is what the lesions look like hysteroscopically. The only issue is that a lot of times we're not able to see it hysteroscopically, but if you can, and it's localized, it can be a quite simple procedure. The biggest risk are the risk of uterine rupture, and oftentimes I would do this procedure under ultrasound guidance to make sure that I am not at risk for perforation. The last procedure I want to mention is just pre-sectionorectomy, which I think is underutilized. I use this for my patients who desire future fertility with midline pelvic or back pain that I presume is from their adenomyosis, so specifically for uterine pain. There are larger studies for pre-sectionorectomy, and including a recent meta-analysis that was described for endometriosis. But when we look at for adenomyosis, the studies are much smaller. This study, out of 655 patients with chronic pelvic pain, they identified 42 patients with adenomyosis, and 50% of patients had significant improvement in their pain, meaning that they no longer required pain medications or had no or mild pain after pre-sectionorectomy, and there were very, very minimal complications, about 0.5%, with laceration of the middle sacral vein being the one that we worry about the most, but was thankfully very uncommon. 0.6% required further surgery, and there was 1 injury to the internal iliac artery. So pre-sectionorectomy, we pick these for people that have midline pain who are not too obese, because I'll show a video to explain why, because it makes the procedure a little bit more complicated. And we try to avoid it in people who have a baseline history of chronic constipation or urinary retention for historic reasons for the urinary retention. But we do see an increasing risk of postoperative constipation, about 74% of patients after the procedure. So I try to avoid it in those with constipation or with urinary retention. And I was unable to embed this video, so I'll just show it this way. So this is the pre-sacral
It is important to note that the middle sacral artery lies against the periosteum, and tissue elevation helps avoid injuring it during this process. Gentle traction allows for opening of the plane between the superior hypogastric plexus and the underlying tissue.
at the level of the
As
sacral
the plexus has
promontory.
reflected cephalad, monopolar energy is used to sever its remaining attachments to the underlying tissue. Once a 2 to 3 centimeter segment of the plexus has been dissected, it is then desiccated and transected just below the aortic bifurcation.
So the major issues with the pre-sacralectomy here is the sacral promontory. You elevate the peritoneum right at that level. You make a midline incision through the peritoneum and open it up. Then you're dissecting the presacral nerves along with the surrounding fatty tissue to try to remove the nerves that supply the uterus and some part of the vagina. The bifurcation of the aorta is here, so the internal, the common internal iliac is here. The ureter is over here. The other ureter is over here, and you're dissecting within this space here. The biggest risk is injury to the middle sacral vein that's underlying, but that's relatively uncommon as long as you are clear of what your anatomy looks like. And then you resect these nerves. This procedure, I think, is underutilized because many patients do desire to have future fertility, but have a significant amount of pain. Alternatively, and if you have a center who's able to do it, in the US, at least we do a hypogastric nerve block with our pain service doctors to also address midline pain. And finally, in terms of comorbidities to endometriosis, I just want to emphasize that endometriosis is found in up to 80% of patients with adenomyosis, and oftentimes these patients are more likely to have advanced stage 4 rectal sigmoid endometriosis. So this is one of my patients with adenomyosis, and you can see she had quite extensive, she also had multiple C-sections, but she had quite extensive endometriosis in addition to her adenomyosis. This is why I don't believe in vaginal hysterectomies for adenomyosis, and also just anticipation of either if you can get good imaging to know that there might be more advanced disease, a really good preoperative exam, and then just having the right surgeons available to be able to dissect out the ureter or to do your bowel adhesiolysis if you may not feel comfortable doing so. In terms of the endometriosis, what I like to show is this picture of the biliary posterior cul-de-sac, because this is commonly what I see with my my patients with the really big adenomyoma nodules. I usually do a standardized approach to the obliterated cul-de-sac. I won't go into it too much because I know we have the topics about endometriosis coming back, but try to normalize the anatomy before dissecting the rectovaginal septum by taking down the left rectal reflection, lateralizing my ureters, dissecting out my pararectal and paravesicular spaces. I temporarily occlude the uterine arteries with laparoscopic clips to help with the hemostasis and the visualization. And then I dissect out my rectovaginal space. I just like to emphasize that this, both for the posterior adenomyomas and for rectovaginal disease, there's often an implant in this rectovaginal septum that gets split in half. And it's really important to take both half of those, of the nodule, both shaving it off the back of the uterus if you can, which is what we normally can see on the imaging as the adenomyoma, but then also removing what's left on the side of the rectum. So in conclusion, there are various options for the surgical management of adenomyosis. The problem is that the data regarding the fertility, the symptom outcomes, and the best technique, as well as the complication rates are promising, but very limited. It's really important to treat coexisting endometriosis, and further research is needed about to guide us about the best surgical techniques. Thank you.
Yeah, thank you so very much, Jessica. Yeah, you've taken 20 minutes, so I can summarize what you said in a few minutes, and then we still have time before the next speaker comes on. Yes, I think one striking thing is this 40 to 80% of patients who have adenomyosis also have endometriosis. And that really and truly is one thing I want all of us to keep at the back of our mind when we see patients with adenomyosis. You started by telling us you define adenomyosis and the difficulty that you can encounter surgically when you have patients with adenomyosis. And you told us, that the surgical method that you use depends on whether the adenomyosis is diffuse or focal, and then the fertility aspiration of the patient in question. Minimal access surgery, the dream for the surgeon is adenomyomectomy still. Yeah. Yeah, but for the diffuse, you talked about the cytoreductive surgery and the non-excisional methods, but that hysterectomy, yes, is still the definitive treatment, but we should avoid as much as possible vaginal hysterectomy because of the concomitant occurrence of endometriosis. And you went on to tell us about so many of these fertility sparing options, wedge resection, double or triple flap, H incision, and so on. Well, you also told us that in the series on adenomyomectomy that about 50% of patients have improvements in bleeding and the symptoms after the surgery, and that you, for hysteroscopic resection, you prefer the bipolar, and you spoke again about pre-sacral neurectomy that is underutilized. You took us through 655 patients with chronic pelvic pain, and 42 of them had adenomyosis. And you recommended it for patients who have midline pain, who are not too obese. We should avoid also in patients who have pre-surgical history of constipation and urinary retention. So thank you so very much for all that you have brought to have. You have highlighted in this beautiful lecture. And we'll be waiting for the question and answers. Yeah, I think the number of people who are joining have improved now. And so thank you once again. And I'm going to be inviting the second. Please let us, if you can, if everybody behaves like this, the first speaker, and we have five minutes, so we'll have enough time for questions because I guess this is going to generate a lot of questions. Okay. So the next speaker is going to be talking to us about the management of endometriosis-related infertility, and is Dr. Victor Ajayi. Dr. Victor Ajayi is a consultant gynecologist and assistant director at Nordica Fertility Center, Lagos. He trained at the ABU Zaria and specializing, now he is the specialist in endometriosis, PCOS, and endoscopy. Dr. Ajayi is a fellow of the National Postgraduate Medical College of Nigeria and a member of Sogon. He has attended advanced courses in India, Dubai, and the USA. He previously worked at ABU and International Clinics, Kano. So thank you so much, Dr. Ajayi. Are you? Yeah, okay.
I'm here,
So
thank you.
We have the podium.
Okay, good morning, everyone from this part of the world. I hope we're all doing well. So I'll just share my slides. Okay. Okay. I hope you can see my slides now.
Oh, yes, we can. Yes, we can.
Okay. I'll be speaking to us this morning about the management of endometriosis-related infertility. I'll introduce the topic, and then we'll talk about the relationship between endometriosis and infertility, and then the management of endometriosis-related infertility. We look at other considerations, and then we will conclude. My name is Dr. Victor Ajayi, consultant gynecologist, fertility specialist with interest in endometriosis. I'm also the assistant director and head of clinicals at Nordica Fertility Center, Lagos, Nigeria. Predominantly, endometriosis is found in women of reproductive age group. 1 in 10 of such women will have endometriosis. It does not respect any ethnic or social groups. It's found in all ethnic and social groups. Typically, the diagnosis of endometriosis is delayed. Sometimes, an average of 6 to 9 years or even more. Either the patient is told it's normal, it will go away when you start having children, or it's something in the head, or just symptomatic management goes on. But this is dangerous because the disease is progressive, and the more it progresses, the more impact it has on fertility. Also, when the disease is that progressed, it can also have a negative impact on the successful outcome of fertility treatments. Sometimes we see that the first diagnosis of endometriosis is in the fertility clinic. Several studies have shown many women, are first diagnosed at the fertility presentation, For some time, we have tried to push for a paradigm shift in the diagnosis of endometriosis because we used to say that the gold standard is laparoscopy, but clinical diagnosis, imaging techniques are now available to, increase the diagnosis of endometriosis, 70–80% clinical and imaging. Because in Africa, laparoscopy is not so common, and then the learning curve to laparoscopy can be a challenge. Is there a relationship between endometriosis and infertility? That answer is yes. We know that about 30–40% of women with infertility would have endometriosis. And on the flip side, 40–50%, about half of the women with endometriosis will also have infertility. As we said that women with endometriosis may be up to 6 to 8 times more predisposed to infertility. As I stated earlier, many studies have shown that there's some, a lot of women going through assisted reproductive treatments have endometriosis. We did a study some years ago at Nordica, and we looked at all the infertile women who had laparoscopy with us, and about 15% of them, had endometriosis, which was the third commonest finding. Now, we also know that several studies have also reported that the chance of pregnancy, if you compare a woman with endometriosis versus a woman without endometriosis, is significantly reduced. It can be as low as 2% per month for a woman with endometriosis versus up to 20% for a woman with no endometriosis. So clearly there's a relationship. How does endometriosis cause infertility? For all cases, we do not have a direct causal relationship in all cases, but there's some postulations, suggestions, some of them mechanical, where you have distorted pelvic anatomy. This can affect, follicogenesis, oocyte quality can be affected, tubal affectation, embryo transport. A lot of things can be affected due to inflammation, peritoneal inflammation, which is chronic. Even the sperm oocyte interaction is affected. Sperm function and motility is also affected. And then the endometrium is not spared. Progesterone receptor insensitivity can be a problem for implantation. Also, if I may step back a bit to even talk about painful sexual intercourse in cases of deep infiltrating endometriosis, that can affect sexual intercourse and also contribute to infertility. Surgery itself can also reduce ovarian reserve, so that can also affect chance of pregnancy. Of course, there are other chronic systemic inflammation which may affect other organs of the body. So I'll talk briefly about the endometriosis fertility index, which is tries to determine the chance of post-operative pregnancy. It's scored between 0 and 10, and it looks at patient factors like age, duration of fertility, history of prior pregnancy, and then surgical factors. So there's a score between 0 and 10. The higher the score, the better the chance of conceiving after timed intercourse. But the lower the score, you may be suggesting assisted reproductive treatments. Women with endometriosis management, but one must warn that the longer you wait, you could have issues with the disease progressing, like I mentioned earlier, and worsening the prognosis in terms of fertility. So it's best to avoid delays, and we must make hay while the sun shines for women with endometriosis. Medical treatment. Several studies in the past and even more recently, ESHRE has in their guidelines have suggested that medical treatment or to help for conception has not been shown to be effective. Even pre-IVF treatment may not be so effective. Potentially might just delay conceptions and might be better to go straight to assisted reproductive technology. This meta-analysis also tried to say that laparoscopy alone looked at several interventions versus placebo, and found that laparoscopy alone or GnRH agonists alone could improve the odds of pregnancy. But in the same breath, we said that more randomized control trials are needed to be able to prove this or otherwise. Now, again, still talking about medical treatment, there's insufficient evidence to recommend prolonged administration of combined oral contraceptive pills or progestogens as a pre-treatment to ART. There's no enough evidence to suggest that this will increase live birth rates. And also the extended administration of GnRH agonists prior to ART to improve live birth rates is not recommended because the benefit is uncertain. Now, for surgical treatment, it is believed that for stage 1, 2, there could be some improvement in live birth rates after surgery. But for latter stages, stage 3 and 4, more advanced stages, surgery only significant for symptoms of pain in particular, but its contribution to improvement in live birth rates is not proven. So the operative laparoscopy could be offered as a treatment option for endometriosis-associated infertility in stage 1 and 2, as it improves rate of ongoing pregnancy. So for early stages, we could do that. The operative laparoscopy in endometrioma-associated infertility may increase the chance of natural pregnancy. Also, no data from comparative studies exist. There's also no compelling evidence that operative laparoscopy for deep infiltrating endometriosis improves fertility. But of course, for symptomatic treatment, this can be offered. Now, still talking about surgical treatment, this is AG, so we're going to say a little bit more about surgical treatment. When there's an endometrioma, should you touch or not? So there's some recommendations. Look at the size of the endometrioma, 4 cm or larger, you may consider operating. This may help to confirm the diagnosis, reduce the risk of infection, and it may also improve the access to follicles at egg collection. May also possibly improve ovarian response. And cystectomy is preferred to drainage and coagulation because recurrence will be less when cystectomy is done and the pseudocapsule is removed. Again, still talking about surgical treatment. Studies in the past, this one, 2011 by Somigliana, showed a reduction in ovarian responsiveness in up to 50% of the women who had operations on their ovaries for endometriomas. Premature ovarian failure was also demonstrated in this other study by Osaka et al. In 2006, where the patient had surgery for bilateral endometriomas. Also in this study by Benaglia, this report 2010 of 93 women who had IVF after operation of this time monolateral endometrioma. There was absence of follicular growth in about 12 cases. So clinicians are not recommended to routinely perform surgery for endometriomas prior to ART to improve live birth rates, as current evidence shows no benefit, and surgery is likely to have a negative impact on ovarian reserve. Still talking about endometriomas, when should you operate, when should you avoid surgery? So when the woman is asymptomatic, she's an older woman, because already the ovarian reserve may have been compromised due to age. So there are other factors which result in diminished ovarian reserve. You should avoid surgery. Of course, bilateral endometriomas should be avoided. Surgery should be avoided. Or she has had prior such surgery in the past. It's better to proceed to IVF straight on. Still emphasizing the surgical treatment for and against. So when you can consider operating, if there's good ovarian reserve, fallopian tubes are healthy, there's the male factor, there's no male factor, or the sperm parameters are good. Young woman, late 20s, early 30s, no previous surgeries. If the lesion is growing rapidly and larger than 5 centimeters. So these are some of the considerations in considering operation. But sometimes damned you are, if you do, damned if you don't. So you have cases where, you know, in this case, if you operate, are there risks of surgery for endometriomas? There could be bleeding, pain, infection, visceral injury, because the impact on ovarian reserve, which is a concern to us, those of us in fertility treatment, premature ovarian failure. It could be incomplete surgery and disease recurrence. And then I also mentioned the issue of the learning curve for laparoscopy. It's not easy to do. Not all surgeons can, you know, easily do surgery for endometriosis. So that could be a challenge. Potential delay in you know, resorting to assisted reproductive treatments. But again, if you do not operate, there could be acceleration in disease progression, contamination of follicular fluid, follicular fluid contamination, pregnancy-related complications when there's pregnancy in the setting of large endometriomas. Infection of the endometrioma, this can happen sometimes during egg collection if you inadvertently go into the endometrioma. And also increased requirement of GnRH medications. Undiagnosed occult malignancy, you know, can happen, chemical peritonitis, risk of cycle cancellation. These are some of the things that can happen when you do not operate for endometriomas, and of course, challenging oocyte retrievals. Also, just emphasizing that this systematic review and meta-analysis concluded that operative laparoscopy, it may improve our overall pain levels, but may have little or no difference in respect of fertility-related outcomes. Yes, so talking about assisted reproduction, yes, early stages may benefit from you know, stimulated intrauterine insemination, where tubal function is still okay. So this can be offered to such women. But IVF mostly is the, you may call the gold standard or the most effective treatment in cases of endometriosis, especially the late stage, advanced stage 3 and 4, or where there's male factor in association to the endometriosis or other treatments have failed. ICSI has significantly improved the fertilization rates and then subsequently implantation and pregnancy rates, despite the setting of reduced number of oocytes retrieved typically for women with endometriosis. So assisted reproductive therapy, this time IVF, can improve outcomes, pregnancy outcomes, or also pregnancy in women with endometriosis. And it's a very efficacious treatment. Studies in the past have also reported that. What is the best protocol for this, for IVF? Several protocols have been you know, recommended, you know, but the long protocol, the agonist protocol, the GnRH antagonist protocol, there's been no difference shown in these two protocols. So practitioners will decide what is best for their client when they individualize the patient. IVF success rates, are they impacted by endometriosis? And how does that happen? The success rates are affected. Typically, women with endometriosis may have reduced oocyte yield and quality of the eggs, implantation problems because of the progesterone receptor insensitivity we spoke about earlier. So success rate may be lower in women with endometriosis compared to those without endometriosis, especially in the late or advanced stage of the disease. This study also concluded that the presence of severe endometriosis is associated with poor implantation and clinical pregnancy rates in women undergoing IVF treatment. But nonetheless, IVF is the treatment of choice in most cases of endometriosis. But typically, we see them in the advanced stages, stage 3 and 4, where tubal function is already compromised. So the other considerations, yes, because of the fact that they have reduced ovarian response or oocyte yield, one may consider multiple cycles to try to pull enough eggs or embryos for their treatment. And then, you may consider freezing all the embryos and delaying the transfer. Some have suggested that using GnRH agonist pre-treatment may improve implantation rates, though this is debatable. Then because of the progesterone receptor insensitivity, they may also need additional luteal support after embryo transfer. This picture, I'm sure most of us in fertility treatment are familiar with this, where you have endometrioma just sitting, between you and the follicles, and there'll be difficult access to the follicles. And we always try to preach to avoid going through endometrioma because of risk of infection. Pelvic abscesses can happen. And there will be flare-ups, during the stimulation process and after a collection. So symptoms of pain and all that could be a problem for the patient. It's not been shown that IVF increases the risk of cancer in women with endometriosis. What of the risk of progression of the disease or recurrence of the disease? This also has not been proven. In this report, 2009 by Benaglia, showed that after pre-IVF and post-IVF, there was no significant increase in size of endometriomas or new cases of endometrioma. So women with endometriosis can be reassured regarding the safety of ART, since the recurrence rates are not increased compared to those women not undergoing ART. Other considerations, basically in IUI, the risk of recurrence is higher compared to IVF. Because for IVF, it's pre-ovulatory follicles that are aspirated compared to IUI. Other considerations, we see that some of these women present late, age-wise, coupled with the endometriosis. Sometimes, so it's like the double jeopardy, and ovarian reserve is reduced in both ends. So sometimes you may have to consider recipient cycles. Other considerations in pregnancy, symptoms may abate because there are no periods, but there could be adverse effects in pregnancy. Ectopic pregnancy rates could go up to 30–40%, basically because they have tubal compromise. Preterm birth, small gestational age babies. Some of these problems are due to increased prostaglandin cytokines, and also the fact that most times you find endometriosis coexisting with adenomyosis. There could be hemorrhagic complications, hemoperitoneum, spontaneous rupture of vessels, perforation of uterovarian vessels in pregnancy, deserialization of endometriotic deposits, and postpartum hemorrhage. Miscarriages also can occur. Delivery has to be well planned, as additions in advanced cases may make cesarean delivery difficult. I recall one of our patients who was warned not to try to conceive again because she had a very difficult delivery in the US. So the other considerations as we begin to try to round up is that it's the early diagnosis is key. An intervention, in good time can prevent progression of disease and infertility in the end. You could consider fertility preservation in a young woman who is yet to want to start a family for several reasons. So if you preserve her fertility, gestation, even in endometriosis, can happen, even if this disease has progressed over time. Of course, pain relief is very important. Sometimes this is ignored, but it's very important to cater and not focus on just getting her pregnant, but to look at other things like pain relief. Quality of life, I must also say that is very important. Mental health issues associated with endometriosis should not, infertility treatment should not detract from, looking at all these things. And of course, it has to be a multidisciplinary approach. Not just the fertility specialists, the general gynecologist, embryologist, of course, nurses, pain specialists, and of course, counselors and mental health professionals will help in the management of this patient. This just tries to summarize what we've discussed, the management of endometriosis-related associated infertility. So basically, the patient has to be individualized. You have to consider multidisciplinary approach, and then see what, surgery basically for pain might not improve IVF success rates, except or chance of pregnancy, except in the early stages. Medical treatment has not been shown to be effective in terms of fertility outcomes. But assisted reproductive techniques are helpful, can help to improve chance of conception. And there are some emerging treatment strategies. As I round up, I'll just share some experience we have from Nordica. We did this study between 2003 and 2014 on 61 of our clients who had endometriosis. The mean age was 34 years, and most of them had primary infertility. Also, the preferred protocol was antagonist protocol compared to the long protocol. Mean FSH was 8.8. And we realized that the number of ampoules of gonadotropins they used was significantly higher than a similar study that looked at tubal factor fertility treatment. The number of eggs retrieved was relatively low, about 5 eggs with four M2s. Fertilization rates somewhat lower than expected, about 54%. We realized that pregnancy rates were better for women in stage 1 and 2 compared to those with in stage 3 and 4. Cancellation rates was about 10%. Also, we've had cases where we had, not just the fertility problem, but this woman also had hemothorax, and we had to co-manage with the chest surgeons. So I will conclude by saying endometriosis is a major cause of infertility. The best treatment protocol for endometriosis-related infertility, just like its etiology, which we still don't know 100%, is not fully understood. The best treatment protocol is not fully understood, but IVF in particular has proven to be an effective treatment, but expectant medical and surgical treatments less so in terms of fertility, but definitely more randomized control trials will definitely be needed to fully understand this enigma of the condition and the best approach for the management of endometriosis-related infertility. I thank you very much for listening.
Yes, thank you so much, Victor. Yes, I'll just take 1 minute to summarize what you said because we need to go to the next speaker. But I think you successfully tried to avoid the rot of surgeons in fertility management of endometriosis by managing the two sides. Yeah, but of course, you told us that IVF really probably is the major player in infertility management of patients with endometriosis. But you went on to tell us some of the problems that we could envisage even when we're doing IVF with these patients and some of the controversies that are involved, and also the complications that could even happen in pregnancy. So thank you so very much. That was a beautiful one. So I will hand over to Dr. Olale to introduce Dr. Njoku, the last speaker in this session.
Oh, thank you very much. So our next speaker is Dr. Amarachukwu Njoku. He's a consultant obstetrician and gynecologist, specializing in high-intensive focused ultrasound for treating uterine fibroid and adenomyosis, with over 3 years experience in non-invasive, minimal invasive treatments. He's a fellow of West African College of Surgeons and a member of several professional societies. A passionate advocate for women's reproductive health, Dr. Njoku enjoys traveling and playing chess. He's happily married with children. So please go ahead and let us have your lecture, sir.
Thank you very much, everyone. Thank you. Let me share my slides.
Okay, sir.
So I'm talking about the role of HIFU in the management of adenomyosis. I'm going to talk about the etiopathogenesis, the clinical features, then treatment options, including HIFU treatments. Okay, this is my background. The etiology and pathogenesis of adenomyosis is uncertain. Several theories have been put forward, including microtrauma of the endometrial myometrial junction, the of the metaplasia of stem cells, the retrograde menstruation, and also epigenesis of the epigenesis. All right. The commonest severe dysmenorrhea, that's painful menstrual menses, heavy menstrual bleeding. The previous speaker has talked about infertility. It can also cause pelvic pain, sometimes chronic pelvic pain. Some people also might have enlarged uterus. It's global to uterine nodular, and also some have them previous speaker that talked about IVF and infertility and adenomyosis. So I will just go to the treatment options. This is a picture of adenomyosis. We have the focal and the diffuse adenomyosis. So this is a picture of the focal adenomyosis. These are some of our pictures. This is an MRI picture. This is a T2 weighted image of the pelvis. You can see from this picture the uterus and is globular, then is focal. The adenomyosis is on the anterior uterine wall. You can follow my cursor. That's the anterior uterine wall is thicker than the posterior uterine wall from the cursor. And you can see this area. That's where the focal adenomyosis is. Also, the next picture we have this fundal focal adenomyosis. Then this is a picture of adenomyosis coexisting with the uterine fibroid and the posterior uterine fibroid. For diffuse adenomyosis, the first picture here is a diffuse is a cystic type of adenomyosis. You can see both the anterior uterine wall, the fundal and the posterior uterine wall are all enlarged and a cystic in nature. Then the other picture is also anyway. Posterior uterine wall take. The first speaker I've talked about the surgical method, that's fertility sparing, uterine sparing surgeries, where you talk about the wage resections and the head resection and the removal of the prosthetic removal of the adenomyosis. Then the gold standard being the hysterectomy. So, and also there is the non. Can you hear now?
Yes.
Apologies, there was a glitch in network. Okay, I'm talking about the medical treatment of adenomyosis. Some drugs used can affect the menstrual cycle and ovulatory cycle, like the oral contraceptive pills, gonadotropin releasing hormone analogs. These options sometimes are used for temporary basis for symptom relief, but they can also affect conception. So I talked about the conservative surgical techniques, the wage resection and the head resection, hysterectomy being the gold standard, and the HIFU treatments. So this image of some of the fertility uterine sparing resections. The first image here is the wage resection. You can see there's a wage resection of the myometrium and the head resection. So from our experience, some of our clients that come with a history of wage resections on MRI, their uterus are usually disfigured. So these are some of the image we have from my cursor. You can see the anterior, there's a notch on the anterior uterine wall.
Sorry, Dr. Njoku, I'm sorry to interrupt you. We're not seeing the images. Yeah, we're not seeing the images. Slide is not shared.
Can you see the slide now?
International speakers.
Yes, yeah.
Okay.
All right. Okay. So yeah, this image shows some of the our images of clients with the previous history of like from here, there's a notch on the anterior uterine wall, and also here a notch. This is a previous history of wage resection. So HIFU is simply high intensity focused ultrasound. It's a non-invasive thermal ablation of the technique, and it's usually involved using a extracorporeal transducer, that a concave transducer to project uterine sound, not radiation sound, on the target tissue. Here is adenomyosis, and it causes ablation of, it causes coagulative necrosis of the target tissue at temperature of 65 degrees Celsius. So this is a study that was done 2 years ago in China. About 776 clients where we are recruited on 2 arms, HIFU and adenomyosis. And it concluded that the reason why women choose HIFU is that younger age, 31 to 40 years, fertility desire, symptoms like dysmenorrhea, menorrhagia. Yeah, that's why women choose HIFU over hysterectomy. Experience in HIFU treatment center. We have done 522 HIFU treatments so far, and 13% of them were for adenomyosis. For adenomyosis only, we have done 3.5%, and for adenomyosis coexisting with uterine fibroid, we have done 9.5%, which is 49 treatments. Most of our clients are for adenomyosis, 79%, as compared to 21% for focal adenomyosis. This is a picture showing for clients with adenomyosis, the average age is 39.8 years. Parity, we see more of them in nulliparous women, 0.5%. Commonest symptoms are heavy menstrual bleeding, 79%, dysmenorrhea, 85.5%. 35.5% of them had infertility. People that have done previous myomectomy or wedge dissection are 27.4%. So this is showing the T1 contrast enhancement image before and after. You can see before HIFU, there was a enhancement of the anterior adenomyosis, and post HIFU, you can see only the diffuse anterior adenomyosis that was ablated, and you can see it doesn't take in the contrast. The same image here. So this is some of our image we have before and after HIFU, showing how the adenomyosis were ablated and sparing every other tissue, including the myometrium. This is a posterior diffuse adenomyosis pre and post HIFU. These are another fundal diffuse adenomyosis pre-HIFU. You can see that it takes in the contrast, and post-HIFU, you can see the adenomyosis tissues were ablated, sparing the myometrium. The same image here, this is a picture of a fundal focal adenomyosis with the posterior uterine fibroid. The T1 contrast image. This pre-HIFU and post-HIFU, you can see how the adenomyosis were ablated with the posterior uterine fibroid. The same picture here, the fundal adenomyosis and the posterior uterine fibroid, pre-HIFU, post-HIFU. The uterine fibroid ablated, and the fundal adenomyosis was ablated. The same picture here, a posterior diffuse adenomyosis with an anterior small uterine fibroid, pre-HIFU. Is a T1 contrast image. Post-HIFU, the posterior diffuse adenomyosis were ablated, and the anterior uterine fibroid was ablated. Now, for our clients, we follow them up post-HIFU. We have a system of quality of life where we measure their symptoms, including all other parameters. The commonest symptoms we have is severe smenorrhea and heavy menstrual bleeding. So 3 months, 6 months, 9 months, and 12 months, we follow them up, and we have a set of criteria where we ask questions on the frequency of these symptoms and how they have improved over time. We have a scoring system. Now, it has shown that over time, these two symptoms have improved post-HIFU, and their p-value is quite significant. And the adjacent graph shows that. So there is a improvement in these symptoms, heavy menstrual bleeding and dysmenorrhea, post-HIFU. So we concluded by saying that HIFU is an option in treatment of adenomyosis, especially for women who want to preserve their uterus. Thank you very much.
Yes, thank you so much, Dr. Njoku. This session is supposed to end at 10:25 and questions for 10 minutes. So I'm sure we're on time and we have ample time for questions. Dr. Olalere, is there anything you want to summarize, Dr. Njoku?
Thank you, sir. Let me quickly use the little things I was able to pick from there. The network was so bad in my area, was just taking me in and out of the program. In and out of the, yeah. Thank you, Ms. Dr. Njoku. You told us that you gave us the mild pathogenesis of the endometriosis and adenomyosis as a disease of many etiology, and you talked about HIFU as being a non-invasive local ablative procedure that spared the other adjacent structures, and made us realize that it has been very impactful and useful procedure that has helped the patient that prefers to have a non-surgical management of the adenomyosis. Okay. Thank you, sir.
Yes, thank you. Yes, some of the things also that you mentioned with for it was very good with diffuse adenomyosis as well as focal. And what I want us to do is to marry all what we heard this morning together. And that's probably the basis of what our discussions will look like. Okay. I don't know, I've not seen any questions, but I think I'll start with some questions. I have a question for Jessica. I know I'm sorry to take you out of bed. I know it's still very early in the morning in New Jersey. Yeah, I was just wondering if about 80% of patients with adenomyosis also have endometriosis, okay? Are we really treating them with, let's say, adenomyomectomy, okay? If we don't touch the endometriosis as well. Is it not just a quality of life issue that we're thinking about, the improvement in the symptoms, and probably majority of them will still need, for fertility, they still need maybe IVF? Is it correct if I say that?
That's very correct. So we don't always remove the adenomyomas for fertility alone, as was mentioned, but for most of the time, the patients have symptoms. But when I do those surgeries for the adenomyomectomy, I always remove the endometriosis at the same time, because the patients that tend to come back, they come back with endometriosis that was untreated, or their symptoms, even with the best adenomyomectomy, many patients will only have 50% improvement in pain. So if you can remove the endometriosis too, to decrease and get their pain even better, I prefer that you do both of those.
Thank you. I see Dr. Alabi's hand is up, so
yeah, the question is for good morning, Dr. Ajayi. So the question is for any of the speakers, because endometriosis seems to, I think we tend to somehow divert into endometriosis and fertility. But meanwhile, endometriosis is a bigger picture in terms of pain. My question is around a journal article that came out in July this year that shows, I think it's a group in America that confirmed that the incidence of ovarian cancer in severe endometriosis or endometrioma is 4 times the background risk. So the question is, now, from the fertility speaker who says, oh, don't remove endometrioma, and stuff like that, I just wonder, how should we not be thinking about this from the onset when we see this patient? So our focus is not entirely fertility, and it's a bit broader than what we're seeing. That's just my question. I think I'm just coming from the oncology kind of angle. Thank you.
I would say that yes, I think we've known that the recent article came out, but we've known for a while that the risk of ovarian cancer was higher in patients with ovarian endometriomas, but that still relative list is still less than 1% of the patients. And it's increasing with the size of the endometrioma. So for most of my patients, we do a lot more imaging in the United States. So we will see patients with endometriomas that are 1 centimeter, many patients. We don't necessarily take all of those patients to surgery for the cancer risk alone. But I agree with you that the pain associated with endometriosis is undertreated. I can speak of Ghana. I don't know Nigeria, but Ghana for sure. Many patients are not being treated for their pain associated with endometriosis. And I think there's more of a focus on fertility, but pain should also be treated. So for patients who have pain associated with endometriomas, I do treat them.
I think Ghana is not any different from Nigeria. We're the same, where our patients are extremely undertreated. I think just going back to the cancer risk as well. Yes, we all know from the endometrioma, but it's not only endometrioma I'm talking about. I'm talking about the severe endometriosis as well.
The deep.
So, the deep endometriosis. So I just feel that I think our view of endometriosis needs to be slightly different from how because I think honestly, maybe because of the bias we have in Africa, we tend to concentrate more on fertility, but it's a lot bigger than that. I think it's a lot like Dr. Ajayi said. I think there's a lot of, I think we should maybe change the dynamics a bit and start thinking about quality of life as a big issue as well. Okay, many thank you. Thank you.
Yes, sorry, I just want to emphasize, I do believe the endometriosis is extremely undertreated in Ghana, West Africa, altogether. Every African country I've been all over, East, West, South. Endometriosis is extremely undertreated. I'm surprised by how, and I think it's probably because of the access to laparoscopy. But
I think
should be doing much more.
Right, Dr. Jai, sorry, just bear with me. I think one of the basis of, I think ages is very, very, we know that, and one of the reasons why we focus a lot on endometriosis is that we have almost like an endometriosis project which Dr. Ajayi is running in ages, and we sincerely hope that we will work with the rest of West Africa in creating awareness, also thinking about bringing the multidisciplinary approach into endometriosis treatment. I think that's very important. So I think it's good to know that we have a daughter that we sincerely hope that you will work with us as time goes on in introducing the multidisciplinary approach in treating endometriosis in West Africa.
Even further, I've been taking pictures of everybody's names because I'd like to have more involvement with AAGL. So I lead their global health committee, and they have been actively looking for sites within West Africa in particular to collaborate with. And I would love
Dr. Ajayi, your man.
Yeah.
All right. Thank you very much.
Thank you. Yeah, I see. Before Lamidru, I see Hans. Hans is I know what. I have an idea. Hans.
I wanted to just thank Dr. Alabi for that, and that's really the emphasis that we should not just focus on fertility and forget other things that are there. And this risk of malignancy is true, and that's why it should always be at the back of our minds when we're treating endometriosis, especially endometrioma. So size, larger ones, and that's the benefit. When I talked about touch or not touch. The larger the endometrioma, you may want to operate, because one of the things it helps you to do is this cancer risk. Of course, tumor markers, though they are not specific, these are things that to look at. Yes, so it's something that I thank you for bringing that up. We should, like I said in the presentation, look at the client holistically and not just focus on fertility. And it has to be a multidisciplinary approach.
Yes, Hans, can we have your comments, and then I have mine?
Yeah, well, the aspect of oncology is always very important and should not be forgotten. But in this case, in endometriosis, particularly in ovarian endometriosis, as what you mentioned, 4 times the risk of the normal population is, at least from European standard, by far too high. So we have a factor 1.2 or even less than that. And that was a very controlled study. But what the previous speaker probably also had in mind, maybe the figures or the percentages for West Africa are different from Europe or from Northern America. So in order to answer that question and give a good advice, you need to have your own data, and that is not easy in order to find out, because the lag time is pretty large. And before you don't have these data, please be very careful in producing anxiety and fear in women by saying you have an increased risk of ovarian cancer, which might lead to getting ovaries removed. And of course, since there is always a lag time, if you are really afraid that a woman might develop ovarian cancer because of endometriosis, first allow her to have children and respect ovarian reserve. And afterwards, you can still, if you regard the risk of ovarian cancer as increased, you can still remove the ovaries.
Yeah. Well, thank you very much. Yeah.
Okay. That's what I was going to say, that look, a woman has a window for reproduction. Okay. And that window we should respect. You already know some of the risks. So follow her up with some of this. But this surgery that we were doing at a time, I have a friend who had done 13 surgeries and she had no child. You know? Yeah. So I think we need to balance these two things together. Whilst the woman wants to have a child, incessant surgery will definitely deplete our ovarian reserve. And therefore, we need to balance this whilst we're looking at this 1% maybe chance of developing ovarian cancer, which is not negligible, but we need to balance everything together. That's what I also I want to say.
And Dr. Jai, I totally agree with you. Totally. I think the main thing is not to operate unnecessarily, but at the same time, I think follow-up and imaging is very important. And I think it just maybe, so I think like Hans said, I think you don't want to scare people. And unfortunately for us, we don't even have data coming out of West Africa. So until we start getting the data, I mean, for all you know, our women might not even be prone to risk of cancer at all. But unfortunately now we extrapolate a lot. So my comment is not to increase surgical risk. I'm just saying that for the whole of this program, I think it's important that we think about that as well, especially with the big endometrioma, to stratify them, look for how the MDT about them, and then make decisions. That's only my view about it. Thank you.
Yes. Jessica wants to say something?
Yes, sorry, I think I gave the wrong impression. I think you should increase surgery. There's underutilization of laparoscopy for endometriosis. Every time I go to Ghana, I go there and I see all these women suffering who are and honestly,
yeah,
do not want to do medical management with contraception as much as in the Western world. And we definitely don't do them. So I think the goal should be to get increased comfort level with the surgeries, because the women are getting undertreated. I do want to emphasize that. What I meant to say is deep infiltrative endometriosis, even in the United States, many people are not comfortable with it, and the complications, the risk of complications are higher. So for deep endometriosis, I'm not sure it makes sense to go do a whole bunch of that type of surgery when the risk of malignancy is less than 1% and for deep endometriosis. For ovarian endometriomas, the risk is a little bit higher. People feel a little bit more comfortable. We should be doing that. But I don't want to give the suggestion that we shouldn't be doing surgeries. We need to do more surgeries. It's not utilized enough.
Thank you. Bola, I see your hand up.
Yeah, thank you very much, Dr. Opoku-Anana. I really enjoyed your talk. I enjoyed the talks of other contributors during this session. I have three related questions to Dr. Opoku-Anana. One, what do you think about the concept that endometriosis is actually a permanent disease that is not curable? Number two, what do you normally use for pain relief, pain management? Is it one medication or a combination of, for those that surgery is not helped? I think the third question is, do you have an opinion about the new link between endometriosis and reduced perception, that is low pain threshold, and the relationship to celiac disease, where women, who have a condition like celiac disease tend to have so much pain, even when they have very little endometriosis. You can't treat them. They keep coming back even after they pass surgery. Thank you.
Okay, let me see if I remember all the questions. The first question, yes, I believe there's no cure for endometriosis. I know I'm an excision surgeon, and there's a lot of discussion about full surgical excision. All of the research shows that the more you remove, the more likely a woman is to have pain relief and decrease the recurrence rate, but there's never been any study to show that there is a cure, either medical or surgical, for endometriosis. I think the reason why we don't have a cure is because we don't know enough about the disease, and all our treatment options are geared towards our reproductive hormones. But there are newer things on the that are being studied that are working more with the immune system and genetics, and I think that that's probably going to be hopefully lead us towards a cure or improved treatment in the future. The second question was about I forgot the
Pain
second.
management.
Oh, pain management. Yes, pain management. So hormonal suppression, hormonal contraceptions, GnRH agonists, antagonists, danazol. Actually, danazol given rectally or vaginally, so you have less side effects. All of those, I use all of them. Outside of that, I really do, I run a comprehensive endometriosis center, so we do multidisciplinary approaches, other people have mentioned. We do everything from pain medication like low-dose antidepressants such as Cymbalta or TCAs, amitriptyline, nortriptyline, which can help with the neuropathic pain, muscle relaxants for in treatment of things like pelvic floor dysfunction, which are common for endometriosis patients. And then if you have access to doing simple blocks that most gynecologists can do in the office, like pudendal nerve blocks, trigger point injections in the vaginal walls. I don't know if Botox is available, but those type of things that can also be helpful for pelvic pain. And then there's other simple things like TENS units. You can buy those online that are really cheap, that can sometimes be helpful for pelvic pain as well. But in general, patients need a multidisciplinary approach that's addressing their hormone suppression for the endometriosis or surgery, and then addressing some type of medication for nerve pain and treatment of the pelvic floor.
Yeah, thank you. There's Eziamaka Ezekweli. Please, can you ask your question?
Good morning, everyone, and thank you all the presenters for your lectures. They were awesome. But my question goes to Professor Jessica. So I have a practical question or a clinical question, let's put it that way. So I have this lady that is nulliparous. She's 38 years old, and she has this endometrioma that is 8.4 cm by 10.2 cm. And a volume of 1,170 mils. So, okay, so she's her endometrioma is quite large, and I'm just wondering, is this a case for laparoscopy with this large size endometrioma?
I would do that laparoscopically, but if you do not do that normally, I would say do it open. Obviously, you have to do whatever is safe for the patients and what you feel comfortable doing. The laparoscopic approach is better because I'm always thinking about the next surgery also. If you do an open surgery now, she's at high risk for recurrence with the 8-centimeter endometrioma. You risk making more scar tissue with the laparotomy and more complications for the next surgery, making it more difficult. So we approach endometriosis laparoscopically, no matter the stage, no matter how big the endometrioma, and for deep endometriosis. That being said, even in the United States, 99% of gynecologists would not do that laparoscopically. So I don't think you do what you have is within your skill sets, unless you have somebody to refer to or whatever is safe for the patient.
Okay. Thank you. I'll keep in touch.
Yes. Sorry.
Go on, please.
The comment about the celiac disease, that's a good point. The endometriosis has been associated with all autoimmune disorders. It's because it's very much an inflammatory disorder. So we've seen that connection between comorbidities for many autoimmune diseases and other things like celiac disease, malignancies, and some forms of cardiovascular disease as well, all related to inflammation. I forgot to answer that question.
Thank you. Thank you.
Thank you. Yeah. So I see there's some things in the chat room. Abdulkarim, Professor Jessica, how will you manage a teenager diagnosed with endometriosis? Will you prefer medical treatment at first or surgery?
I'm a surgeon, but I actually prefer medical treatment for everybody. I think there are consequences to doing multiple surgeries. So I try to delay the first surgery if I can. But if the patient is not responding to medical treatment, then I will do surgery, even in teenagers.
Great. Yes. Well, I don't see any more questions, but I just like to.
Can I ask another question?
Please do. Please do. We still have time.
Okay, so Dr. Jessica, there's a few papers coming up as well. They're comparing surgical approach to a common drug called Dynogest. I don't know whether you have that experience.
We don't have Dynogest in the United States, but I have plenty of patients who are on it from Europe, mostly, and Canada. Yes.
I think it's showing that a significant improvement in,
I prefer it. If we had it, I would use it. I agree with it, but it's just the availability.
Okay, all right, thank you.
Dr. Lalere also has a hand up. Do you want to ask a question? You have a comment? Or is it a legacy hand?
I dropped some comments and some questions in the chat.
Okay. Okay. I'll read them.
But I can ask them.
Okay. Hans, you still have your hands up.
Yeah, if there's still time, I'd like to comment on Dynogest. It's a common drug. We use it a lot in Germany, and we also have used it for many years. So it's also a safe drug. However, a lot of women suffer from depression, so that's a no-go, and we have to switch on. And there's a new drug called Rieco, which is Relugolux GnRH antagonist plus norethistosтерone and estradiol or estrogen. So that seems to be the new generation of drugs. However, it shows that in some cases, tumors like bowel tumors might shrink, but as soon as you stop Dynogest, they will be back and will be bigger. And even in some cases, despite application of Dynogest, it still grows. And you will probably know also the study from Paris, whereby Charles Chaperon, where you showed that with gestodins in adolescents, the disease continues, and even there is a higher risk of deep infiltrating endometriosis than without Dynogest. And one other comment concerning pain management. Everything was absolutely perfect what you said, but I would like to highlight in really severe therapy-resistant pain, everything has been tried, nothing works, particularly if it's pelvic pain. What we do is we apply electrodes with 8 poles so that we perform neuromodulation of pain, and that is we position these electrodes between or around the sacral nerves in the pelvis, and that is fantastic. We do it together with neurosurgeons, which I think is the best and safest way to do so.
I'm not sure that there's, I think actually somebody brought up a question about central sensitization. I'm not sure about the availability of those procedures. It's the only reason why I bring it up. We also do other type of things like hypogastric nerve blocks, ilioinguinal nerve blocks. I've also done neuromodulation as well at my other prior institution. I've seen mixed results with the neuromodulation, but some patients have had extensive improvement in their pain.
Yes, thank you so very much. Dr. Lalere's question, how soon after HIFU should we advise patients with adenomyosis to do IVF? I think that would be the last question. Dr. Njoku, do you want to take that?
Okay. Yeah, after HIFU, we advise them to wait for at least 6 months before starting fertility treatment.
Okay. Thank you so very much. I think this has been a very stimulating session. thank you for all the speakers and all the contributors. I just want to leave you that one of the reasons why probably surgery is underutilized in West Africa is expertise. And we should please be careful in just dabbling into surgery that we're not comfortable with. On that note, I say thank you to everybody, and I'll hand over to the moderator of the next session, who happens to be Dr. Olajuwon Alabi. Thank you so much.
Okay, thank you so much.
Thank you.
Okay, thank you so much, Dr. Agai. I think you should probably be leading this session, but I've been given. I think there's a bit of a challenge. My co-moderator is unwell, who's the LOC, just coughing. I wonder whether I can have the privilege of asking my senior brother, Dr. Ola, to co-moderate this session with me. I see that he has no tie on, so I think he's with us totally today. Dr. Ola?
Well, I can't. It's just I wasn't prepared for this. I don't know the.
No, it's okay. I think I'll be the main moderator. I think it's just my second moderator is in theater. The last one is So I think I just need the support. So okay, well, thank you. So let me so this session is a continuum of the endometriosis, and I have some high-powered speaker from diaspora. The first speaker is Uche Menakaya, who is from Australia. The second speaker is Professor Hans Steinberg. And then the third speaker is Dr. Joseph Nyangi from Kenya. And the fourth speaker is Abhishek Chandawaka. So can I just confirm that Dr. Menakaya is here before I read his profile? Dr. Uche Menakaya.
Yep, I'm here.
Okay, all right, sorry. So, yes, we can hear you, Uche. So I think I'm just going to quickly read his profile so we can start on time. Uche is, Dr. Menakaya is a consultant gynecologist who practices out of Australia, is an advanced laparoscopic surgeon and a sonologist. He has done a lot of work on endometriosis, especially with gynae scanning and with endometriosis. He's a global woman health specialist known for pioneering a single visit ultrasound-based gynecological care model in Canberra. He developed an award-winning ultrasound-based endometriosis staging system. Dr. Menakaya directs Gynae Specialist Group and leads capacity building initiative in Africa. He mentors through the World Endometriosis Society and affiliated with several prestigious medical organizations. Please give me I dutifully invite Dr. Menakaya to take over and start his talk. Welcome.
Thank you very much, Dr. Alabi, and thank you very much to everyone that is on the Zoom meeting today. I listened to the last session, and it was beautifully primed for me to lead into a multidisciplinary team care approach to endometriosis care. Some of the conversations there are already reflective of the need for an MDT approach for endometriosis. And the conversations around the cancer risks for endometriosis too is quite important. However, rather than rushing to surgeries, it's also important that that we remember that we have the tools that are now available to us to continue to monitor this patient over time. So you can keep scanning these patients every 6 months or every year to ensure that their endometrioma does not change in its appearance that will then initiate the thoughts that it might transition to cancer. So I think it's important to remember that in our multidisciplinary team care approach, we have to remember the role of imaging in making sure that these patients are identified early and managed as appropriately as possible. The second comment I want to make here as well is the fact that we should also remember that the presence of an endometrioma is often a tip of the iceberg when it comes to endometriosis. There are several other phenotypes of endometriosis. And it's important that, endometrioma occurring alone, is quite rare. So, so those are the comments I want to make before I, move into my presentation. I would like to see if I can now share my slides. So, how can I share this? Let's see. Can we all see my slides at all or not?
We can't see your face. We can see your face. We can't see your slide.
Right. What do we do? All right.
Are you able to share?
Yeah, I'm just trying to work that out in a minute.
I think.
Should not be this hard. Okay.
I think if
all right.
you
yeah, I got it now. I got it now.
Okay. All right. Cool.
Yeah, I knew it wasn't going to be this hard. Perfect. Beautiful. Can we all see it now?
Yes, we can. Yes.
All right. So let's get on with it now. So what I'm going to try and talk about here is sort of a background for endometriosis. I think that as an association that is involved in gynaecological surgeries, we're all aware about endometriosis. In particular, we're also all aware of the transitions and the paradigm shifts around endometriosis definition and what that implies to its management. I will look and see also the origins of the MDT approach to endometriosis and how it's been translocated, if you like, from MDTs for cancer onto MDTs for endometriosis. And of course, what are the evidences, around the use of endometriosis and whether does it have any value, in endometriosis at all? And then there are different types of MDTs, I know we're an endoscopic society, very focused on surgery, but clearly, MDT for endometriosis be much beyond that. And finally, I'll talk a bit of case reports and how our patients can have a defined pathway to accessing MDT services. So we know of this anyway, that historically, we have always defined endometriosis as the presence of endometrial tissue outside of the uterine cavity. It's a disease that has got multiple phenotypes, and as many speakers have spoken yesterday and today, it can present with infertility and the chronic pelvic pain, and in some patients, it can also be asymptomatic. Clearly, it does affect as much as nearly 180 million people globally, and some of the studies from Nigeria suggest that you have a high prevalence of endometriosis among those seeking infertility treatments. But there has been a paradigm shift in the way we look at endometriosis. We have moved from looking at endometriosis from a lesion. Now we are shifting our paradigm to considerations of the patient. We no longer think about endometriosis predominantly as the presence or absence of lesions, and we are beginning to emphasize the origins, the symptoms themselves, and their origins. So currently, the definition of endometriosis now is a condition that is a menstrual cycle dependent disease, is a chronic inflammatory disease that affects multiple systems and can commonly present with pelvic pain or infertility. Now, this new definition, if you like, for endometriosis makes it really well suited to a multidisciplinary team care approach. But it's important that we understand the origins of the MDT as well. MDTs, came about because of the need to reform the UK Cancer Service, in the 1970s or the early 80s, in order to reduce inequalities and improve clinical outcomes. One of the Kalman-Hines recommendations to the NHS in this regard was to introduce the use of multidisciplinary teams as a core model for managing chronic conditions. And thus, MDTs have become established as an essential part of NHS clinical care and service provisions. And that model also have been transposed, to endometriosis. So we have the ESHRI guideline, which has been, quite copiously quoted by one of the speakers previously, emphasizing the need for multidisciplinary centers with appropriate ability to offer multidisciplinary care or team approach to complex deep endometriosis patients. And one of the primary criteria for the British Society of Gynaecological Endoscopic Society is that for you to be accredited as a center to carry out complex endometriosis surgery, you must work in a multidisciplinary team that has a named colorectal surgeon and a nurse specialist in it. So the concepts that have been developed around the cancer care have now been transposed, to endometriosis care, and rightly so, because endometriosis is now known to be more of a chronic, systemic disease. This is an example of a patient who accessed the MDT system, if you like, in the NHS. A 30-year-old lady, nulliparous, who had been attending because of menorrhagia and who had been trying to conceive for 12 months without success. Now, how did she get into the MDT? She got into the MDT because she had multiple attendances, perhaps in the emergency department, with hemoglobin levels less than 8, which is assumed to be due to multiple fibroids. This individual, which is assumed to be due to obvious heavy menstrual bleeding from multiple fibroids. This individual then had an ultrasound at the time of obviously multiple attendances in emergency that showed that she does have multiple intramural fibroids and the bilateral endometriomas and possible bilateral hematosalpinges as well. So that was our entry point into the MDT. The gynae team then saw her and then commenced the process for her to get into the system, to the MDT system. Now, there are a few things you need to remember here. First and foremost, she attended when she was 30 years old. She is a nulliparous, and typical to what you find in Africa, most of Africa, she attended because she was trying to conceive. You also look at when they had the MDT meeting as well, you can look at the content or the composition of that MDT meeting, gynecologists and radiologists meeting. So this may have been an MDT meeting to try and understand the complexity of the MRI imaging before they can now begin to plan appropriate treatment for her. So this shows you some of the issues with MDT, MDT approach to endometriosis care. When does the individual or the patient enter the system? And when she enters the system, what pathways are there for her to navigate the complex labyrinths, if you like, of endometriosis care? So is there really a role, even though it's recommended, is there a role for a multidisciplinary team care in management of deep infiltrating endometriosis conditions? And clearly, it does have significant value, for managing patients with endometriosis. In particular, it does help with higher quality decision-making, helps to reduce incidence of questionable practices, helps us to standardize our patients' care. More importantly, it provides us the opportunity to offer our patients a more holistic approach to patients' care, giving them access to a range of therapeutic options that are currently available, but more importantly, also in a timely manner. And in addition to all of this, it helps to promote coordinated efforts between specialists. So it's not surprising that certain countries around the world are beginning to embrace the concept of, multidisciplinary team approach to endometriosis care. Australia, I believe, is one of the first countries to have a national approach to endometriosis care by developing a national action plan for endometriosis. One of these actionable items is the fact that they need to define and establish centers of expertise for endometriosis management and chronic pelvic pain management. And those specialized centers that are established should become part of the care pathway, giving opportunities for GPs and emergency departments to send referrals to, for patients to have further screening, to be triaged appropriately, to be assessed, and more importantly, help them navigate, the journey on their endometriosis journey. So the membership of the MDT, how do we choose them? Obviously, I showed you a case report in the previous slide of a woman where the MDT was just around the radiologists and the gynecologists, but MDT for endometriosis is probably much broader than that. And I think that, broader than that, also inclusive of patient support groups as well. And it's important to remember also that greater multidisciplinarity is not necessarily associated with more effective decision-making and implementation of decisions as well. So even though you have all these things that can be part of an MDT program for endometriosis, the volume of the people involved or the membership or the volume of membership does not often translate to better or effective decision-making and implementation. But what is not, controversial is the fact that the patient support groups are a critical part of any MDT that we can develop, for example, in Africa. Because the patient support organizations help to increase awareness about endometriosis, they help to influence policy that drive research forward, and also to share their own experiences with their colleagues and serve as a sounding board for individuals who have been newly diagnosed with endometriosis, who are unsure how to navigate the labyrinth of services available for this condition. And, it's in Australia, for example, we talked about, in the last session, we talked about Dynogest. Dynogest was not available in Australia for many, many years until the patients themselves got involved and pressured the government, over 2 weeks to make it available in Australia. So they can be a powerful resource, for people that are working in the endometriosis sector. In addition to that, it's important to also, understand where the patients themselves are when it comes to the compositions of the MDT systems, as you can see here, they are very much in focus or very much in support of non-surgical members to be part of an MDT process in this survey of patients done in Norway by the Tina Tellum group. And in Australia, you do have, very functional and highly effective patient support groups. In this particular set of slides and communication amongst them, you can see here a patient who says that she's at the very beginning of her endometriosis journey, and she's feeling quite lost and helpless to navigate this in Canberra. And she had had an ultrasound after begging her doctor to help her investigate her pain further. And now she has that diagnosis and she's trying to work out where next to go. The key points here is the fact that she's at the beginning of her journey. And the second point here that I want us to remember is that she was begging her doctor to help her investigate her pain. So let's keep that at the back of our mind, because the next slides will show why I've highlighted this point. The second point here also is the fact that, people within this group are discussing their experiences with certain endometriosis intervention and trying to get advice from those that have experienced those sort of treatments in the past. And here, I want to read out this particular paragraph about a couple of patients who have had pelvic floor Botox for pelvic myalgia-related symptoms for endometriosis. And in terms of sharing the experiences on the WhatsApp on their group, they talked about the recovery being not as quite as bad as expected, but after a week of the treatment, they are now feeling pretty good. And they're also encouraging people to know that those services are now available through the public health system, and they're able to give the information to those individuals who may require, those treatments or interventions. But what is important here, like in the first case I showed you, the first case report I showed you, is how do patients access MDT? Unlike cancer, when a patient has cancer, they often get the preliminary adverse assessment done either through imaging or through biopsies, and then straight away that becomes their pathway to MDT. But for endometriosis, it's a little bit more complex than that. Endometriosis, as some of us have spoken about, we in Africa, for example, our endometriosis journey starts perhaps only when we want to get pregnant. We tend to ignore the many, many years of pelvic pain. So for women with endometriosis, there has to be a screening process to help them identify their risk for endometriosis. There has to be an intervention or a set of interventions that help them in the diagnosis and the treatment of endometriosis. And those interventions could be invasive or could be non-invasive as well. And whatever the interventions would be, they have to focus on the patient, whether they require surgical or even medical treatment, whether we need to look at their fertility desires versus the impact of their pain, or even the biopsychosocial impact the disease has on their quality of life. And again, I get back to the National Action Plan for Endometriosis from the Australian perspective. One of the actionable items that they were keen to introduce was the item to devise and promote a simple, standardized, and easily accessible tool that can precede or aid diagnosis of endometriosis. And this tool can be completed by the woman herself who has symptoms of endometriosis even prior to attending a GP appointment in order to encourage early action and intervention. Now remember that the whole difficulty we have endometriosis for such a long time is the delay in diagnosis, the 8 to 9 to 12 year delay in diagnosis. So strategies that help us reduce that delay in diagnosis, intervene early so that women would have less of the downstream effects like infertility that they meet later on in life. So there are a number of patient-based questionnaires now available that have been published and validated. And I'm just going to show you one here, and I hope that we're going to go through it together. I hope you can all see this. It is a Canberra Health Service, authorized by the ACT government. And here it talks about an online screening tool. Can you all see this?
No, I don't think we can see it. We can't see it. We can see your initial topics, your initial starting slide. That's all we can see.
Can we see it now?
No.
All right. Right. Okay.
I think you might want to, yeah. So if you maybe go on with and then come back to it later. Yeah.
So anyway, so the on my slideshow, I have the so if you can just copy this, copy the period impact and pain assessment online screening tool, Canberra Health Services here, put it on a browser, and then you can sort of see what I'm trying to show here. But essentially, it is a scoring system, has 5 questions that asks the individual, over the last 6 months, have you had regular severe period pain? Is a yes or no answer. The second question is, have you had any significant interference to your daily activities because of your period? Is a yes or no answer. Have you experienced bowel or bladder pain? Again, is a yes or no answer. And have you missed school or work because of your period? A yes or no answer. And have you felt that something is wrong with your periods? a yes or no answer. So those 5 questions, if you answer all of them, yes, it tells you, for example, if you answered all of it as yes, so you have 5 out of 5, and you click submit on the page. What it tells you is, it does sort of tell.
Uche,
Yeah.
sorry, can you, I don't know who, the person that's unmuting themselves, can you please let the moderator take charge, please? Uche,
Yes, tell me.
we're just seeing a blank slide. We can't see your slide at all. Maybe you need to reshare it.
Okay.
But I also need to mention that I know you started late. You started about 5 minutes late. So I'm going to add 5 minutes to your time. But if you can't see you're starting to share again.
All right.
Thank you.
All right, let's keep going. Now, where was I? Right. So this period impact or PIPA online screening tool that I was talking about, set of 5 questions, very simple. A little girl, who's having period pains with her mother can be in their bedroom and answer the questions. If you have a score out of 5, 4 to 5, 4 out of 5, or 5 out of 5, it recommends that you strongly see a doctor to then help you get investigated for endometriosis. If you have a score of 1, 2, or 3, there are different recommendations that they will give you to do. So that's an important part, of how women can access, begin the process of accessing the MDT process for endometriosis. Another thing that is also important, is that we need to understand the different contributors to pain in endometriosis. I know in the last session, people talked about, central sensitization. People talked about pelvic myalgia, and nociceptive contributors, psychological contributors, the mental health components of it, and of course, the inflammatory sources of it as well. Again, there is a nice YouTube video on the origins of pain in endometriosis, which you can get courtesy of the endozone.com.au group in Australia. That gives you a bit of a sense of how the pain processes endometriosis evolve. But what is important also is that as clinicians, we need to know when to operate and when not to operate for those our patients who come to us, see us for, pain related to endometriosis. And as you know, endometriosis is a very complex disease. For instance, we know that 30% of women with endometriosis will lack adequate response to hormonal therapy. And the theories that have been proposed for this is because of a reduced expression of progesterone receptors, or what we call progesterone resistance. And that has become sort of the concept along the pathophysiology of endometriosis, and also has been used to explain some of the refractoriness of therapy when it comes to persistent pelvic pain symptoms. So as clinicians, the question we ask ourselves, with patients coming to us over and over again, they've had surgery with us, you're confident you've cleared all the endometriosis lesions that are there, is there lack of response because of their progesterone resistance, or are we really overlooking some of the other pain contributors that do not usually respond to hormonal therapy, and therefore contributing to further delays their treatment and resulting in further laparoscopies? So you have patients that have had 11, 12 laparoscopies, and yet they still come down with pain. So let's look at this case history here. This is a patient who attended because she has got a chronic background history of chronic pelvic pain and vaginismus, a previous history of heavy bleeding, difficulty in inserting tampons. She has had, physiotherapy treatment and has been unable to even self-insert beyond the first size of a dilator, a vaginal dilator for physical therapy for her vaginismus. In addition to other things, she does have mental health issues, which are being addressed as well. So when she attended to us, to see us for assessment for endometriosis, we couldn't even do a transvaginal ultrasound scan because she has severe vaginismus. We offered a transrectal ultrasound scan, which she also declined. Obviously, it's a little bit different. But I did say we did recommend to her that why don't we treat your pelvic myalgia first and the vaginismus first, and then subsequently assess to see whether we can treat you, we can assess you properly with an ultrasound before surgery. At the time we saw her, she was also on a progesterone-only pill called Slinda or drospirenone. So fast forward, a couple of weeks later, she has had her pelvic floor Botox, and she's now able to use size 3 to size 4 pelvic dilators. The Slinda seemed to have been working for her because she'd been amenorrheic, and her pain symptoms and vaginal symptoms had improved. So for that patient, even though we scanned her, she had no hard markers for endometriosis. She was now responding quite well to medical treatment, and therefore we decided to consider medical treatment for her until things change. This is also another case of a patient with a long-standing history of chronic pelvic pain and dysmenorrhea. She was coming to us when she was 21. She has been using the oral contraceptive pill for about 6 years prior to attending. She had reported a history of non-cyclical pelvic pain, with the pain obviously was at periods. Ultimately, she had symptoms that was also suggestive of significant pelvic myalgia. In addition to that, she had markers for endometriosis. And because we noted her pelvic myalgia symptoms, we knew that if we go and do surgery for endometriosis for her, some of her pain related to pelvic myalgia would not go away. And so we decided to request her to see a pelvic floor physiotherapist to determine whether she needs additional treatment for pelvic myalgia. So she saw the pelvic floor physiotherapist, and the pelvic floor physiotherapist, confirmed our suspicion that she has significant pelvic myalgia, and concurred with our recommendation for her to have pelvic floor Botox and put in the nerve block as part of our surgical treatment. So because of our history, we're able to book her for a laparoscopic surgery with the extension of endometriosis, plus the pelvic floor treatment as well for her.
Uche, you need to round up now, please.
Yeah. So very quickly now, the MDT for endometriosis does not only include pain management. Of course, surgery is a key part of it, but even in surgery treatment as well, it's important that you have a proper assessment from the beginning, in terms of your treatment of these patients, to make sure they have the appropriate imaging, the appropriate teams available, you allocate the theater time appropriately, and even within your theater team as well, making sure that everybody is aware and of what to do, for those cases that last for 5-6 hours. And post-operatively, making sure that you have the, high dependency units available for airway management for these patients. And very quickly, I want to talk about this very interesting case here of a patient who had the laparoscopy. She was coming to us when she was about 30 years old. She had the laparoscopy when she was 19 in China, and was diagnosed with endometriosis at the time. She presented to our practice with an MRI report showing that she has multiple endometriomas within the left ovary, and what looked like some adhesions in the posterior compartment of her pelvis with a submucosal fibroid. Now, it's important that any imaging you do, the type of imaging is important. We can't talk about this enough. Knowledge and know-how is critical. We know that even for MRI, additional training is required. And for ultrasound, it is not routine gynecological ultrasound for endometriosis. So this is her report here. And you can see that her fibroid is a type 2 fibroid. So for this sort of surgeries, if you're going to go in and do a submucous fibroid for a hysteroscopy resection here, you'll see that it's going to be quite difficult, a 2-step procedure for you to do. In the second video on your right is an assessment of our posterior compartment, showing obliteration extending up to 2/3 of the pouch of Douglas, and ultimately showing you that she not only has bowel endometriosis, but she does have a multifocal bowel endometriosis affecting the rectum and the rectosigmoid bowel as well. So this knowledge obviously would influence how you manage her and the people you get involved in our MDT treatment.
All right, Uche, you need to conclude now.
So I'm concluding now.
So
the evidence, shows that clearly the trend for multidisciplinary team care approach for people with endometriosis is growing, and that even though it is, further consumer-driven clinical studies and outcome evaluation will need to be conducted to determine the effect on the quality of life of patients moving forward. How do you start an MDT for endometriosis? Look, the cancer MDTs are well established. The endometriosis MDTs are still growing as a concept, but it does require a highly motivated advanced laparoscopic surgeon to lead it. It can be a single site MDT. It could be multiple sites MDT, coordinating among themselves. So to conclude, MDT for endometriosis is an evolving but critical element in our management of endometriosis patients. There has to be a clear pathway for patients with endometriosis to access these MDTs, and those interventions are there, for patients to access, obviously depending on the provider's expertise. So thank you very much, everyone, for giving me the opportunity to share these slides with you. Thank you.
Okay, thank you very much, Uche. Thank you for that well-illustrated talk. I'm going to run very quickly to Professor, to introduce the next speaker who has been waiting. I think, let me just confirm that Professor Tinebag is still here, please.
Yeah, I'm here.
Okay, well, apologies. I know you've been waiting for a while.
No problem.
Let me just quickly introduce you and then we can start. Okay, so I think everybody knows Professor Hans is a well-known person in the endometriosis circle. Is a distinguished gynecologist with extensive international experience. He has held senior role at universities in Germany, including head of gynecology at Bielefeld and Gießen, and established training centers in Australia and Thailand. Professor Hans was past president of AGE. I think AGE is the Australian Gynae Endoscopy, and I presume DGRM is the German one. Received multiple honorary doctorates and won the Golden Scope Award. Currently, he serves as a medical director at Gateway Clinics Frankfurt and is a part-time professor of the University of Krakow. Welcome, and you can have the floor, Prof. Thank you very much.
Well, thank you very much for inviting me to join this this wonderful conference. I followed part of the presentations, and it is excellent to be part of it. So please confirm that you can see my screen and my first slide. And
we can see it, but you need to expand it.
Yeah, it will expand, but
we can see it.
My computer is probably not as new and not as quick. Now you should see it, and if you look at my back, you can see some wood. I'm talking to you from the Austrian Alps, so I'm high up and it's quite cold over here. So if you feel hot, please come and join me here. Now,
thank you.
The topic might sound a bit arrogant. It was not my choice, but I like to stand up to you. And the agenda is pretty clear. We have to talk about diagnosis. We have to talk, which is very important, about planning of surgery, then different types, adenomyosis, and a role model. Now, I might skip this. You have heard all of this, which is fine. Thank you very much for your nice introduction. And one of my key questions, of course, is who actually wants to become an endometriosis surgeon? Because endometriosis is, as you heard before, a complicated multidisciplinary disease, and patients usually had multiple surgeries and multiple exposures to other doctors, which means that patients usually are unhappy and complain about not getting help, which means the consultation takes longer in order to pacify these patients. Of course, making a very clear preoperative diagnosis is difficult because there are also so many differential diagnoses. And finally, surgery can be very difficult, and I'm saying so because of my experience, which is quite long-standing, and as you saw, over 40 years. Well, first of all, the anamnesis is extremely important, and whatever catamenial approach there is, bleeding or pain, you have to suspect that there is endometriosis. Also, you have to take into consideration family history, as it was mentioned before. There is a genetic background, and also if dysmenorrhea was the reason for prescribing oral contraceptives. Now, sorry, if you perform a normal inspection, please use a speculum that has two parts, so that you can also see the posterior fornix, where there are implants if there is endometriosis, and the vaginal exam should. That's what we recommend, which is also in the German guidelines. It should also have include a rectal exam. Can you see my cursor? Okay. Now, if in doubt, the question is whether one should use a lab test. And my conclusion is, forget about the conventional lab tests, CA12-5 and other. They are all not specific enough, and it has been mentioned before. Now, the only one that seems to be fairly specific is an mRNA-based test. It's the Zivic test. It has been produced in France, and there's a very nice publication by Bondi Fala. However, it is quite expensive, so that I'm very restrictive when in using it. But when you think it could be endometriosis, and the previous speaker had mentioned already, then of course imaging is absolutely important, because the finger, even if it is in the rectum, will only reach up to 8 to 10 centimeters, and you need to see the entire spectrum. MRI is wonderful, but it's quite costly, and you cannot control the quality of the radiologist and the precision of the diagnosis, and also the slide depends on the radiologist. Rectal endoscopic ultrasound is available, and it gives a circumferential picture, but is rarely done. So we stick with transvaginal ultrasound, which is our best tool. And you can see there are kissing endometriomas. There is bladder endometriosis, as you can nicely see here, a huge tumor in the bladder. So when the ultrasound is being performed, the bladder should always be half full or half empty, as you like. And here you have bowel endometriosis, a nicely circumscribed bowel, also as the previous speaker had shown. And this is adenomyosis with a thickened anterior wall, and with phenomena like these Indian hairdress or feather-like structure. Now, when doing the diagnosis, we recommend, forget about the ASRM test, but use the #NCIAN test, because it allows you to make even a preoperative assessment to fit in this. And if you like this, you can use the barcode here in order to download for free the test, because, and there is a very excellent presentation by Horace Roman from Bordeaux in France. He had found out that, you know, if you use the #NCIAN test, you have, for instance, in bowel surgery, you can quite simply calculate the operating time. So it goes from nearly 80 minutes if it's only a minor lesion, to more than 200 minutes, nearly 3 hours if it is a large lesion. And of course, very importantly, you have to see the severe complications according to Clavien-Dindot. They are increased here, and that is something that you need to talk to your patients about. You should not say, oh yeah, I'm operating you, I'm a fantastic surgeon, I have a lot of experience, but you need to also explain complications. Now, best of course is if the diagnosis and the surgery is in one hand, because then the surgeon knows best how to do. You know what I do, because I'm not such an excellent endometriosis ultrasonographer. I have a special person, and she is showing me the slides, and she is doing the ultrasound when I do the examination. But we have to make clear that the first surgery must be the last. so that the patient is not entering sort of a vicious circle of surgery after surgery, and this is not what we want. The gold standard, of course, is surgery, and it applies to peritoneum, ovarian endometrial bladder, bowel adenomyosis, and of course it is laparoscopy, as Dr. Jessica had mentioned before. I think she's absolutely right in many aspects. However, if it is a lung endometriosis, of course, we also advise the thoracic surgeon to use it laparoscopically, part of the diaphragm. The gynecologist can do, but if it is lung endometriosis, it should be a completely different discipline. And of course, if it's brain endometriosis, also the neurosurgeons should do it. If you have peritoneal endometriosis, I think excision is always better than coagulation, and also check for polyvisible implants, and that is the so-called thermocolor test, where you open a bipolar grasper with electricity put on and just slide across the peritoneum, and then you can see shining up of black spots, and of course then it is best to deperitonealize the entire area, because you will always miss part of these implants, and sometimes complete deperitonealization of the small pelvis is recommended. We touched the topic of ovarian endometrioma already, and just to give just a brief and quite raw decision tree. Yes is if the patient is younger than 35, no previous surgery, good ovarian reserve, secondary infertility, and unilateral endometrioma, then it is a clear decision for going for surgery. No is if she is already beyond 35 years, had previous ovarian surgery, compromising her ovarian reserve, primary infertility, and bilateral endometrioma, because you reduce the ovarian capacity so much that she might have major problems of becoming pregnant afterwards. However, if pregnancy is not a problem, then of course remove it. And if there are multiple endometrioma, perhaps even remove the ovary. Now, treating the endometrioma, of course, ovarian reserve is the main important aspect, and that's what I would like to talk to you about, how to overcome. So if you just open the cyst and use, for instance, argon plasma coagulation, then you have a very, very superficial coagulation of the endometrioma implants in the endometrioma, and that is fully sufficient, and that is best to restore fertility. Now, vaginal aspect always, and that's why I recommend to have two specula, because then you can see the endometrioma, you can see here the endometrioma, and you can feel it. And I mean, this is now in theater, but if you do it during examination, the patient will also tell you that it is painful where you are. And most important is that these nodules very often are diabolo-like nodules, because they are not only in the vagina, they're also in the rectovaginal space, and sometimes also infiltrating the rectum. And these are the ultra-low nodules, which is difficult. Now, how to deal with it? You might inject saline around it, then put a suture to it, and then mobilize it from the vagina. So in the end, that when you do the laparoscopic approach, then you have already the nodule has been mobilized, and it's easy to remove during laparoscopy. Bladder endometriosis very often is overlooked. Look at this laparoscopic site. There is this small implant here, which looks like a superficial implant, but when you look at in more detail, you see that there is a major implant in the bladder, and that has to be found out by laparoscopy, not by surgery. By the way, it looks funny because the patient complained about chronic cystitis, and he had seen this and taken a sample, and that's why she had been referred to us. Now, just looking at this, the problem is the ultra low rectum, because the incidence of complications is higher over there. Fortunately, the lower rectum is the majority of cases, and the rectosigmoid is about 10%. So we have 90% of this is in this area. There is appendix endometriosis and the other endometriosis. So what to do? And the type of lesion governs or dictates what you have to do, because there are three different ways. It's shaving, disexcision, and segmental resection. Segmental resection is the major surgery, but shaving is, in my view, only allowed if it is really superficial and you can sort of excise it and maybe apply a suture so that there's nothing left. Because I have seen quite a number of patients where so-called shaving was performed and people were afraid of opening the bowel, and then the recurrence came, and then she had previous surgery, so it was more difficult. Disexcision can easily be done. I'll show you some slides by a circular stapler. You remove the superior part so that there's little ovarian endometrioma tissue left, and then you can do the excision by a circular stapler. And if the tumor is too big, or if it is multilocular or even multifocal, then disc excision, segmental resection, of course, is recommended. Now, bowel surgery made easy. This is just to make it easier for others to do so. You see here this very nice slide with a circular stapler. And if the tumor has been resected, you apply a suture. This is the continuous of the bowel, and then you pull the two strings and then push it into the stapler, and we calculated there is about a volume of 10 mil, which will fit into a 33 millimeter circular stapler. Segmental resection, of course, is different because you have a large area where sometimes the bowel was glued together. That has to be resected. Minor edges can be left because that will be removed with the circular stapler and a purse string suture. And of course, this piece of segment can be removed through the rectum, and that you do not need to have a mini laparotomy in order to remove the tissue. And this is called the nose procedure. Here you can see the disc excision. This is the anal part. This is the anvil. And this area here where the big part of the tumor had been resected is being pulled down, and then it is approached so that this section is resected. This, of course, is the normal approach when a segment has been resected and you have the anvil and you have the thorn from the anal part. So the next topic, of course, is adenomyosis, and adenomyosis is often underdiagnosed and really needs a lot of attention, and that's why I would like to draw your attention to the MUSA criteria. Please download this publication. It's for free, and it shows you all the different signs of adenomyosis. And of course, as you can also see here, there are different forms of endometriosis: diffuse, focal, and adenomyoma. Diffuse is difficult to operate because, as you can see in the next slide, because you always have to leave a remnant so that there is a recurrence has to be shown. And you can see here what is the resection line. If you remove part of the endometrium, is no problem. But of course, you want to remove the glandular tissue. And now what we have done is we always want to preserve the uterus. And if there is a diffuse adenomyosis, what I do is a modification of the Osada technique. And finally, it looks like that. And this is a uterus which will withstand a pregnancy. And we have seen quite a number of pregnancies with a completely reformed uterus. And however, we plan a primary C-section because we do not trust that the uterus will tolerate. Now, when I'm asked about how to become an excellent endoscopic endometriosis surgeon, I would like to draw your attention to the following speaker, Joe Nyagi, who had invited me to perform surgery in his hospital, which was a country hospital. And he had very good equipment. So we did all sorts of surgery, including bowel surgery and bladder surgery. And meanwhile, he is an excellent and very quick learner. He is doing all the surgery that we did together. He is doing by himself. And I think this is a role model for how this can do if you have adequate tutoring or mentoring. And that's why I would like to conclude my presentation. And I hope we are well in time. Thank you very much for giving me the opportunity to talk to you. And what I would like to say is, you can do it. Just be learning, learning, learning. Thank you very much.
Thank you very much, Hans, Professor Hans. Thank you. Please just wait around for the question. We will go very quickly to the next speaker, who I believe is the person that you mentioned in your talk. Let me just see. Is Joseph here? Joseph Njagi?
Yes, I'm here.
Oh, okay, Joseph. Good to have you here. Joseph is a very well-established endometriosis surgeon in Kenya, operating out of Kenya. He is one of the pioneers of the PACE group, which is the Pan-African Endometriosis Society. And I think he operates in Kenya, which is very similar to Nigeria. I think one of the big issues sometimes with endometriosis surgery is that you look at the bowel part, you look at all that, and you're thinking, how do you bring all this together? But Joseph is a typical example of how this works in Nigeria. Work in Africa. He's an experienced obstetrician and gynecologist, minimal invasive surgeon, and endometriosis excision specialist. He's the director of Third Park Hospital in Nairobi and Maple Grove Gynaecological Center in Kerugoya. He founded Laparoscopy Machimani Trust and co-founded the Pan-African Society of Endometriosis. Dr. Nyagi is committed to enhancing care of endometriosis patients and advanced minimally invasive surgery in Africa. His work includes extensive training and speaking engagement at national and international conference. The floor is yours, Joseph.
Yeah, thank you so much, Dr. Alabi. And it's such an honor for me to be part of this Congress. I really feel part of this Congress now. This is my third time to be a speaker, and such a great honor to consider me and being part of this scientific Congress. I really humbled to speak after Professor Tinneberg, and I'm really honored that he could acknowledge the work that we've done, but I should say much credit should go towards the mentorship and his humility and his purpose to improve care, especially to developing country. And I would say I have been very humbled to have worked under his mentorship and his guidance. But me speaking right after him, I don't know if this was a coincidence, but it's such a humbling experience for me altogether. I was asked to speak about a topic that I feel, let me just clean my camera here. I was asked to speak about a topic. Can I get something to clean? I think that's much better. To speak about a topic that I feel it's a bit challenging, but which really deals so much with endometriosis, and for most of us who want to become endometriosis specialists, I think it's very important for us to have an understanding of anatomical challenges and how to unravel it. So I'll just go quickly to my presentation here. So my agenda, I'll just do it very briefly. I'll talk about a little bit of introduction, what we need to understand about preoperative assessment, and what are the anatomical challenges of deep endometriosis, where I'm just going to show a few, an image or thereabout to just give us a little bit of clarity what you're likely to encounter once you start on this journey for endometriosis. And then risk of restoring anatomy and how to unravel the anatomy, which I'll finish with a video, and I hope I'll have done. So again, thank you for the introduction. That's me. So when we're talking about deep endometriosis, basically we need to understand what this really means. And the definition of deep endometriosis is when we have invasion of endometriosis of more than 5 millimeters in the peritoneum. And we know that this can invade just about any structure in the pelvis and outside the pelvis, most commonly the bowel, the bladder, the ureter, and in some cases, we'll also find infiltration of the diaphragm, most common cases. So we know clearly that this can affect the pelvis, and once this happens, the anatomy and the function of vital organs can be compromised, which in most cases is going to affect the patient quality of life and fertility in most cases. So if we look at the image on the right, this is how a normal anatomy would look like. And once we have deep infiltrative endometriosis, then the anatomy gets distorted. And this is what we are likely to encounter. And the question we are trying to answer today is, you have distorted anatomy, how do you handle this? So when we now need to start on understanding the anatomy and the distorted anatomy, there are a few things which are mandatory for us to be able to familiarize ourselves with. I will not talk about imaging because I think this has been mentioned by Professor Tinneberg, and I'm really glad that there's a talk that will be discussed later on transvaginal ultrasound scan before minimal invasive surgery. But we know that transvaginal ultrasound scan is a very important tool in diagnosis and the management of endometriosis. Once you have deep endometriosis, it's imperative for you to have multidisciplinary team approach, because if you have bowel surgery, it's important to have a colorectal surgeon or a urologist. And this is important to address multifaceted nature of deep endometriosis, which we commonly see. And lastly, it's important to personalize the surgical plan. So the imaging and the patient presentation should be individualized to really meet the patient's desire. Is it fertility? Is it their quality of life? What exactly are you planning to do? Should you be operating in the first place? And if you're going to operate in the first place, what are you likely to accomplish? Now, once we put in the scope, this is what we're likely to find. We can find a small nodule that is infiltrated in the peritoneum. Then this might not be very difficult for the majority of us who are laparoscopic surgeons, can be able to excise this. But it's important for us to understand the anatomy and the level where this nodule is. This is the left pelvic wall, and the ureter could be crossing around here. What does that therefore mean? It's important for us to have clear knowledge of anatomy and having excellent surgical skill. Of course, with infiltration, the disease can advance and spread out, and getting to a more severe disease where the posterior compartment is completely obliterated with involvement of ovaries and possibly the bowel. Now, we say that, and this, I'm not going to dwell on this, is that imaging is the diagnosis and is a gatekeeper to therapy. Because if we can catch the disease early, the treatment might not be as aggressive, and it's easy for us to come up with a complete excision of the disease. Now, I really put this image because it's very important. Professor Tinneberg mentioned on his visit to Kenya a few years ago, He just was helping us with the surgery, and yes, we are operating, but he realized there's one thing that we are really deficient, and that was imaging. And for that, he actually connected me with a gentleman from Germany called Alan Constantine, where I traveled, and gaining the skill for doing imaging for ultrasound scan that completely changed the management for endometriosis. And why do we say that? We say that is because once we put in the scope, what we get to see is just the tip of the iceberg. It's just been mentioned that surgery for endometriosis requires excellent skill, as operating time can be quite high. So preoperative ultrasound scan mapping is important. So before you really understand how to unravel the anatomy, you need to have a clear mapping of the disease before you can commence the surgery. For instance, when you look at this imaging system, what do you make out of it? For example, here, can you really see the disease before you put in the scope? Well, it has been mentioned previously that laparoscopy is the gold standard for diagnosis of endometriosis. Do we still hold on the same teachings? Well, for instance, now, again, this is what we can make out of this. This is an endometrioma. We can see all the sign, defining sign for adenomyosis. We can see the posterior infiltration of adenomyosis. And on the last image here, even before we put in a scope, we can see there's bowel infiltration. The posterior compartment is obliterated, and there's involvement. So by the time you go in, even before you put in the scope, you need to have a mental map of exactly what you're going to find the moment you put in the scope. So the surgery does not happen once you put in the scope. The surgery will happen in your head the moment you start planning. And of course, we have the beautiful engine classification, which really maps out the disease. So you are able to communicate, you're able to plan. So for instance, you've mapped out and you know that there's involvement of the ureter, then you need to have the urologist to be on board. If you know that there's a possibility of segmental bowel resection, if you do not have the skill, then you need to involve multidisciplinary team, which might include the colorectal surgeon. You don't want to put in the scope, and that's that when you realize that you need the surgeon, and then you're calling him, he's on another surgery, and now you have to cancel the surgery, or you have to perform an incomplete excision of the disease. Professor Tinderberg has mentioned that the first surgery should always be the best and possibly the last surgery. Of course, this has mentioned that laparoscopy is no longer the diagnostic gold standard, and we know. Now, this is the reason. If you put in a scope and this is what you find, what do you make out of this video? So let's say, for instance, there was not imaging that was performed. This is a patient we had a few months ago. You can see the bowel is completely stuck. Here, you cannot make out if this is the bladder or is the uterus. We can see the right adnexa is completely obliterated. The ileocecal junction with the appendix is completely attached here. The question then you ask yourself, where do I start? The anatomy that we were taught in the good old days in anatomy classes here might not be very, very helpful. So the question is, how do you help this patient? If this patient comes to you and they require your assistance, of course, once you can see there's more extensive disease that is going to involve the diaphragmatic, and good planning should be made not during the sitting, but even before surgery. So for this particular surgery, we know what we are getting ourselves into. We had really planned. We had very heavy breakfast, and this surgery took us about 11 hours. With 3 great surgeons, which included myself, a colorectal surgeon, and a urologist. So now that we have spoken about ultrasound scan, now see exactly what you get to see once you start doing ultrasound scan. Immediately, within less than a minute of putting the probe in the vagina, you can see there's infiltration of the bowel. This is the Indian headdress sign, as it has been mentioned, and this clearly tells you that the bowel is involved here. It's the posterior compartment is obliterated, so the anatomy will be distorted by the time you ask. So if I have this image, what am I going to do? I am going to talk to my colorectal surgeon. I'm going to talk to my urologist if there's hydroureter or hydronephrosis, and the patient gets to benefit. Again, on the ultrasound scan, once we see these images here, this is a patient we had about 2 months ago. We knew clearly that this patient had extensive involvement of the bowel. And then we knew that this patient will definitely benefit from segmental bowel resection. So you perform this surgery just outside the operating room. So once you go in, the only thing that you need to do is to actualize the plan. Again, this is another patient here, and you can see, if I go back here a little bit, you can see this adenomyosis. This is a previous cesarean section. There's adenomyosis, but of importance here, you see that the uterovesical septum is completely infiltrated here. And now you can see the bladder up here. It's not very clear if this bladder infiltration or the bladder wall has been compressed. So one has been depressed, so the wall has thickened. But now with the feeling a little bit of the urine, now we can really see here, there's infiltration of the bowel. So you make a conclusion that when you go to perform this surgery, you'll find that that very nice cleavage that you get and the space between the bladder and the uterus or the cervix will be obliterated here. And for a fact, this is the ureteric orifice, and it's most likely this nodule is at the trigone. So this is the conversation that you start having with the patient early enough. What are going to be the possible complication of excising the trigone? And you need to have your urologist on board. Now, what are the risks of restoring anatomy now that we have seen how complex or how distorted anatomy can be? Now, we need to be aware that there could be possible surgical complication that you need to be aware already ready for and have a conversation with the patient. That can include injury to the bowel, ureter, and bladder, bleeding, or even injury to major vessels, as I'll share some of my videos on my next presentation later in the afternoon. Adhesion formation can reform even after a complete excision of the disease, which can lead to even more chronic pain after surgery. As much as surgery for endometriosis is geared towards improving fertility, we know in most cases, especially with severe disease, this might not be completely achieved, and sometimes it can even get worse. And we know that if you don't perform the excision, completely excision of the endometriosis, there's a likelihood of recurrence of endometriosis. And we've also seen complication of bowel and bladder dysfunction, especially when the nerves have been compromised during the excision, especially if you're going to get the hypogastric, the inferior hypogastric plexus. There's a likelihood of dysfunction of the bladder and the bowel. So clear anatomy and understanding of anatomy is very important prior to surgery. So now the question goes, if we have distorted anatomy, how do we unravel to restore anatomy? These are some of the steps that we use in my center, and I think most of my colleagues follow these steps in surgical procedure when you have deep endometriosis. And the first should be restoration of anatomy before you can attack the disease itself. How do we do this? We start by adhesiolysis and mobilizing the sigmoid colon and the rectum, because this gives us access to the pelvic wall at the level of the pelvic rim, whereby once we start to perform the ureterolysis, which is the third step, it makes it easy. We just don't go and attack the deep endometriosis. We need to safeguard structures. What are these structures that need to be safeguarded? These include the nerves, includes the ureter, and includes the bowel. And of course, the major vessels. Ovariolysis and temporary ophthalmopexy, it's very important suspension of the ovary, because this is going to help enhance the visual field during the surgery, especially if you are going to perform ureterolysis. And if there's going to be endometrioma, you can either decide to drain depending on the indication, or cystectomy depending on the patient's fertility desire. And this is really a long conversation if you're going to drain or do cystectomy, which might not fit in our today's presentation. What about the ureterolysis? Ureterolysis is very important. It's mandatory for all endometriosis surgery, mobilization of the rectum. And finally, you can actually see the last step that we do, it's excision of the nodule. Now, here as my last part, I'm just going to go through a video here and just go through this step. This is surgery that we performed just yesterday. And I had an opportunity to, edit this last night. And here you can see that this is the bowel here, and the bowel is pulled at the level of the torus uterinus. You can see the bilateral uterosacral ligament have been involved, but we don't exactly know the extent of the disease. What are some of the questions we don't know? Is the ureter involved? Where is the ureter? If we just go and excise this, how are we going to injure the ureter? So then what we need to do, we need to safeguard the ureter, as I mentioned, we need to safeguard the bowel, and then finally we can continually and excise the endometrial, the endometriosis. So again, as I mentioned, the first step that we start with is a visualization and mobilization of the sigmoid colon. And this is just basically, these are physiological adhesions. So this is not endometriosis. Don't confuse this endometriosis. But just by releasing and mobilizing this gives us a way and access to the pelvic brim around here, where if we need to perform ureterolysis, this will be the our point of commencement of ureterolysis. Remember that we need to start from normal. We don't start performing ureterolysis at the level of the disease. You start from the normal going to the abnormal. Now, this is another mobilization, not particularly for that surgery, where there was more adhesions at this level, and you can see extensive adhesiolysis and mobilization of the sigmoid colon. It's very, very important. Again, with this mobilization, we are able to appreciate the psoas muscle here. And once we see the psoas muscle, that acts as a landmark of where we are. So the risk of injuring major vessels becomes a little bit less. Again, here you see that the rectum is completely adherent to the pelvic wall. This is the fallopian tube. And with gentle maintaining meticulous excision, bit by bit, you are able to maintain the right plane. And once you maintain the right plane, then you can see the anatomy is restored. Now, again, once you have anatomy like this, now the surgery becomes very difficult. If you're performing a hysterectomy, or if you wanted to do preservation, then that becomes easy. What about suspension of the ovary? This is, again, as we mentioned, temporarily, and we learned this technique from Professor Tinderberg with this straight needles, where you drive the needle through the anterior abdominal wall, then take it or introduce it through the ovary, again, pull the needle, and then again, reintroduce it again through the anterior abdominal wall, and then you're now going to have temporary suspension. What other ways you can do? There's usually, you can actually, again, use a stitch and suspend it on the anterior abdominal wall. Now you can see with this suspension here, the pelvic wall is easily mobilized. Now, ureterolysis, again, this is every time you're performing surgery for endometriosis, you should be aware where this important structure are at every given point. So we meticulously going to follow the ureter by cutting millimeter by millimeter, extending the ureterolysis to the level of the uterine vessels. Again, here, we know that the uterine vessels are coming here, so we are only going to take the peritoneum thickness only so that we avoid injuring the uterine artery. Again, here we can now be clear that the ureter is completely out of our way. On the opposite side, similarly, we are going to mobilize the ureter again by exposing the ureter. And unfortunately, you see how we are struggling. And I really put this video here intentionally to see how we are struggling with the ovary, because we did not perform ovarian suspension. Again, at this point, you can see the diseases here. This tissue here, which are tagging or pulling the ureter towards the disease. With the grasper on my left hand, I am going to protect the ureter, and with Thunderbit, I'm going to excise the tissue. And once I excise the tissue, then the ureter will be again mobilized more laterally. Now I have enough space here to now completely excise the disease here without any concern of injuring the ureter. So at every given point, I'm able to visualize the ureter. What about the mobilization of the rectum? It's always very important if there's disease that is involving the rectum, or there's disease at the torus uterinus and need to be completely excised, there's also need to be mobilized. We are going to open the pararectal space, and with the pararectal space, we need to let the bowel go with its fat. Again, remember the old dictum that fat belongs to bladder and fat belongs to the rectum. But in case I was going to perform a segmental bowel resection, then I will denude the fat from the bowel here. Again, the same approach will be taken on the opposite side, and we are taking meticulous care. And once you get this the pararectal space, we just continue, and this can either be blood dissection or you can have sharp dissection, and then you have opening of both bilateral pararectal space. And once you've opened and you've mobilized the bowel medially, then the last step is going to open the rectovaginal space. The rectovaginal space needs a little bit of skill. You can either use a cold scissor. I would recommend using the cold scissor in the first days of attempt. And it's important to also start with normal anatomy. Again, now you can appreciate here the bowel has completely been mobilized. Of course, we know that there's a little bit of disease at the bowel. Now the question is, are we going to perform bowel excision or shaving? Again, the patient had not consented, so that was left. Now, again, I want you to see what you now have. You have restored the anatomy, and more than just restoring anatomy, you have safeguarded all the important structure. I know the ureter is here. I know the bowel is away. I know the ureter, and I know the nerves are on this band here. So if I have to excise, at this point, if I have to excise this disease, I know that all the important structures are not going to be involved. Either I am going to do excision, it's infertility preservation surgery, or it's going to be a radical surgical procedure. I know now it's very easy for me to attack the disease. So in this particular surgery, patient had consented for hysterectomy. So we proceeded with hysterectomy. Now, at this point, this is the point when we are going to start the steps, the 10th step of hysterectomy. Again, we evaluated the bowel and we saw there was infiltration of the bowel. Unfortunately, the patient had not consented for bowel surgical procedure. So this, of course, we are going to follow her up. And if you're going to have complication of bowel disease, then determination can be made either if you are going to perform discoid segmental, where we are going to again map the disease. And now that's where the last step comes, excision of deep endometriosis. And after surgery, this is exactly what we ended up with. So again, the only disease that we know has been not excised is the disease on the bowel. Coming back for this surgery, is it going to be a difficult? Possibly not a difficult procedure. So in conclusion, these are my take-home statements, is that deep understanding of pelvic anatomy, it's very important. If we have to restore anatomy, all perform surgical excision for endometriosis. Again, I've talked about preoperative assessment where imaging is very important. You get to make the decisions of how extensive the surgery will be even before you get to the operating theater. Surgical skill is very important because this surgery can be very, very complex. Some of these surgery might take you even up to 6 hours or even a little bit more than that. And of importance, you need to have the right team with you. Patient selection, it's important to have the patient well counseled, and the patient need to completely understand what are the pros and the cons for surgery. Does it mean that every time patient has endometriosis need to undergo surgery? The answer is actually no. So this should be a balance between the possible complication and the outcomes of surgery. Again, I wasn't sure that Professor Tinneberg had finished his presentation with the images, but on his trip back to Kenya. But again, this is where our journey started a few years ago. And it was such a great privilege for me to work next to Professor Tinneberg. And I would say this is possibly where my steep journey for endometriosis and more so deep endometriosis started. And I think that will be it for me. So mine is to, again, thank everybody for giving me this opportunity. And I hope that we'll have a few questions at the end of this session. Thank you so much, everyone.
Thank you very much, Joe. That was a very very good presentation. I think taking us through the journey. Thank you very much. So I'm going to move very swiftly to the next speaker so that we can conclude it and answer questions. The next speaker is Abhishek. Is he here? Is Dr. Abhishek Chandawaka here? Dr. Chandawaka?
His recording is available. Good evening to everyone. At the outset, I would like to thank Dr. Adebole Adebayo and the whole team of AGES to give me this opportunity.
I'm Dr. Abhishek Mohan Chandawakar. I'll be speaking on retroperitoneal approach in laparoscopic surgery. Now, it's the new kid on the block, or probably I can say that it was the new kid on the block because everybody seems to be doing it now. But this is what I'm presenting is for somebody who wants to start off doing retroperitoneal surgeries. Primarily should have a good vision, that is a good optics in terms of good camera and scope, great exposure, good assistance. So retroperitoneal or any surgery which is more difficult cannot be without good assistance and a good energy source. So the techniques of dissection, before I go to the video, is just to understand how you can go about it, and then we'll see the same in the video. So we have a good stretch on the infundibular pelvic ligament and lift the peritoneum in the triangle. The triangle is between the infundibular pelvic ligament, the round ligament, and the lateral pelvic wall. Make an incision parallel to the infundibular pelvic ligament on the peritoneum. Reach the pelvic wall laterally. Sharp dissection on transverse fibers. Identify the ureter as it crosses the iliacs, and identify the external iliac artery and the vein. A blunt dissection to be done between the ureter and the external iliac vein. And that is how you can identify the uterine artery, which is the first structure crossing from lateral to medial. This is more so because this would be the primary start of where you would do a retroperitoneal dissection, where you would identify the uterine artery. Once you can identify all the structures, automatically you can advance your retroperitoneal dissection to lymph node dissection and further down into the pelvis. The uterine artery identification is it's a tortuous vessel with a bluish hue. It origins from the internal iliac and as it continues as the obliterated hypogastric and crosses over the ureter. So just having a look at the video, like I said, the triangle between the round ligament, the pelvic side wall, and the infundibular pelvic ligament. Make an incision and then extend the incision parallel to the infundibular pelvic ligament. Extend it adequately so that on both sides, so that the dissection becomes easier and the exposure becomes easier. So the dissection techniques, you can use the ultrasonic energy, you can use a bipolar cutter, you can use bipolar with scissors. As long as you have a clear field, it doesn't matter what your energy sources you're using. Now, when you're taking the transverse fibers, don't do blunt dissection, as you'll end up with a small amount of bleeding there, which can be controlled. So a sharp dissection at the transverse fibers ensures that you have no bleeding when you're dissecting. The blood during this kind of dissection will completely obliterate the visual field and cause trouble for your further dissection. Then the next part is creating blunt dissection. The point where would be dissect directly medial to the external iliac vein rather than dissecting more on the medial side, because if you dissect more on the medial side, we'll create a window in the broad ligament. So that is the external iliac artery and the external iliac vein just below that. Keep on dissecting parallel to it, and once you dissect parallel to it, you can identify that is the obliterated hypogastric, which is the continuation of the internal iliac artery. Now, once that is identified, the ureter is easiest identified when it's crossing over from this is the obliterated hypogastric. That is one way of identifying the internal iliac. Once you hold the obliterated hypogastric and you pull on it, you can see it moving over here. And then you can go from anterior and go back towards the internal iliac and identify that. This is just for an understanding of the anatomy. The right common iliac separately bifurcates as the external and internal iliac, and the ureter crossing over here. Once you identify, the ureter is most easily identified at this level. So once this is identified, you need not always identify it without the dissection. It can be easily identified even at this point, just by dissecting further medial to the external iliac vein. There you can identify the ureter going in. And once you keep dissecting further in, you can see that you can identify the ureter. Once the ureter is identified, between the ureter and the external iliac vein, once you keep dissecting, the only structure which crosses, first structure which crosses lateral to medial is the uterine artery. Now, why we dissect the uterine artery? Because most of the time, this is what you would use in your initial stages of your retroperitoneal dissection. So that is the internal iliac artery, and that is the uterine artery, and that is the ureter over here. Now, this is just to show that there's another technique, the posterior approach for accessing the uterine artery. This is a medial to the infundibulopelvic pelvic ligament. A small window is created just between the isthmus and the infundibulopelvic pelvic ligament. And there, as you make it just above the level of the ureter, you can identify the ureter. And when you dissect the ureter, just lateral to the ureter, there you can identify that is the uterine artery. This is a little more advanced technique because you should know exactly where to dissect it. Otherwise, the lateral window technique is the easiest to access. Once you know your anatomy well, even the posterior window will help you identify the uterine by just minimal dissection. But this is not always easy when you're starting off. So the lateral window technique should also be known before you continue with your posterior window technique. So in case you have bleeding during your dissection, what can we do? First and foremost, just hold the vessel. Give a very small energy burst, ensuring that your ureter is nowhere close by. Because if you have your ureter close by, you should not have the lateral spread going to touch it. Then suction out all the blood that is there. Do not irrigate. The irrigation causes more flooding of the tissues, and it causes more decreases your vision further. Use of an RO gauze is something which is very good. You can keep a RO gauze in and use it immediately to wipe the area or just dab the area, and that itself will be. But the important part is to use it only a RO gauze, so that, and also to remove it, because that is the only thing which can be left back. And then the other technique is to dissect further. Whenever you have a blood-stained area, just dissect a little further deeper into the tissue and you will get a virgin plane again. And these are the small tricks. If you have too many of oozers on one side, just stop there, go to the opposite side, finish the opposite side, and then come back. By the time that bleeder would have coagulated, and then you can continue. And if you're starting off and you're finding it a little difficult, this is vasopressin. Obviously, you cannot use it primarily only for this thing. If you're using it for a myomectomy or something, you can use it and then go ahead with the dissection. Now, what is the need for doing retroperitoneal dissection other than using it for endometriosis or for major oncosurgery? Thing is, to start off, you can use it in cases where vasopressin is contraindicated, like in myomectomies. Now, in a large fibroid where vasopressin is contraindicated, it may help to use the uterine artery at source. Then the next need would be to do in multiple myomas. In this case, you can see that there are multiple myomas. It does help. You can do the surgery only by just doing a bit of vasopressin at each stage, and then removing myoma by myoma and suturing it. The advantage of doing the uterine artery at source in these cases is that you have a longer time period where you can do multiple myomas can be dissected at a single setting, and you can go ahead with removing, before you start suturing the beds, you may remove more myomas in a single sitting. So the technique remains the same. Here you can, what one can do is just ligate it, because if the patient is requiring fertility, just ligating it also can help. It's not necessary. Even they say that even if you do the shoelace technique is a good technique which you can do, and then you can go ahead with removal of the fibroids. Then the next thing would be an unusual location of the myoma. So you have a very cervical myoma which is present, and you have no access to it. In those cases, the uterine artery dissection and ligation or coagulation would bilaterally would be of use. And then you have large, very large myomas in which you can probably use it for the uterine artery can be used to be ligated and all. But that is all primarily to understand how your technique to dissect the retroperitoneum rather than doing it in cases where you would not be able to do it. Then the need is to think out of the box when you have to do a uterine artery. In this case, the patient was A negative or had negative blood group, and the blood which was available was just a single blood. Her hemoglobin was just 10. So just to make sure that to be on the safer side, we were going to use vasopressin, but an additional help so that the bleeding is further reduced. And that was done. The shoelace knot. And then the controversy, whether it's required in a TLH, retroperitoneal dissection. My personal opinion is you really don't require in a TLH to do retroperitoneal dissection, is because here what you can see is actually I'm not doing retroperitoneal dissection. I am just dissecting it near the isthmus, dissecting the uterine artery near the isthmus itself, and there you can see that the ureter is going just below the uterine artery. So in this case, you can actually see I've dissected the uterine artery even without dissecting the uterine retroperitoneum. So my personal opinion is doing retroperitoneal dissection in a uterine artery ligation in a TLH is absolutely very not required. Maybe very rare case you might really require it, but it's not routinely required. The advantages, like I already mentioned, is reduced blood loss and increases the operative time window. And the pitfalls, always love the slide where it says that there were some complications because it looked way easier on YouTube. So I hope it never happens to any one of us. And this is a video which I borrowed from Dr. Abhishek Mangeshikar. His friend lent it to him, and his friend is here doing, in a routine case of a TLH, doing a dissection, retroperitoneal dissection, and he's dissected what he believes is the uterine artery. And now what he does is nicely ligates the uterine artery there. And while he's ligating, can you see the peristalsis over there? He's effectively ligated the ureter. That was identified and it was taken care of. But in a case of TLH, basically an unindicated case, unnecessarily you landed up in a soup. So never ever do something which is unindicated. So genius sometimes consists of knowing when to stop, and that is the most important thing. So stay safe. Use skill associates. You should have skilled associates. Should have very good friends who can help you out, urologists, oncosurgeons, whoever, vascular surgeons to help you out in any point of time. And primum non nocere is always do no harm, because even the best of batsmen never go out unprotected. So thank you.
Okay, thank you so much, Dr. Abhishek. So I think I'm just going to thank all the speakers, Professor Hans, Joseph Nyagi, and Uche Menekaya. And so I'm going to open the floor for questions now. I think my second moderator is here as well. I don't know whether I'm going to ask the last question, but I'm just going to open the floor for question now. If you want to ask any question, I think the summary is that all our talk this morning has been about MDT, thinking about MDT, how to become a sound endometriosis surgeon, and also, how to create an MDT, or how to, if we look at most of us in Africa, or most of the surgeons in Africa are like Joseph, starting off with an endometriosis plan and then working your way out. So I think it's a prototype, and these things are doable. So I'm going to leave the floor open now for questions. If you have a question, please identify so that we can call you in and you can ask your questions. I want to believe that all our speakers are still here. Uche, are you still here?
Yep, I'm still here.
Okay, Prof. Hans, are you still here?
Yes.
And Joseph, you're still here as well.
Yes, I am here.
Okay, so do we have any question from the audience, please? If you have any question, I can't see any hands raised, but if you have one, please. Bolayode Ola, Dr. Ola is, you can ask your question, sir.
Thank you very much to all the speakers. I have really learned, Uche. I really enjoyed your talk on the Australian perspective and leadership in multidisciplinary approach to endometriosis. And you gave us a list of people who should be included in such a multidisciplinary team. But I looked very carefully. I didn't see fertility expert there. And I want to ask why. Now, the reason why I'm asking this is that in Sheffield, where I work, we fertility endometriosis surgeons are also excluded from their for their endometriosis center for a political reason in the case of the UK. But it duplicates patient's journey, because when you find a patient with deep infiltrating endometriosis who fertility is the main reason, they then send them back to me, which then takes 3-4 months to get back to me, when in fact, if I had been part of their team, I would have then talked about situations like, what do we do, what approach, like freezing before definitive surgery, fast tracking to funding for IVF before they reach the age of 40, and things like that, because this is what the patient wants to. In England, we are excluded. And in Australia, I see that fertility experts are also excluded. Why?
Thank you, Dr. Ola, for that. Very.
Do we? Sorry, Uche. Do you mind if we take a few more questions and then we can now answer all the questions together, if that's possible?
Okay. All right.
Just see whether we have other questions.
That works well.
Is anybody asking any question? Now, okay. So if nobody's asking any question, maybe I can ask. I think Dr. Joseph and Prof can answer this question. Okay, we can't see their hand. So who's it? I can't see it. Okay, just came up. Dr. Ajayi, please go ahead and ask your question. Okay, Dr. Ajayi, please go ahead and ask your question, please. And please direct your question to who you want to answer.
No, sorry, mine is a comment. So let the questions flow first, then I will make my comment.
Okay, I'll come back to you, Dr. Opomo.
All right, thank you very much for the presentation.
Please, sorry, Dr. Opomo, can you be very precise, please? If it's a question, please ask it and just be precise. Thank you.
All right. I think my question is what's usually in the mind of fertility special experts, usually when to operate, when not to operate in endometriosis, in deep endometriosis for patients who basically their symptom is just infertility and maybe do not have other features of pain, chronic pelvic pain, and dyschezia as maybe. But when to operate, when not to operate, when medical treatment is better indicated.
Okay, who are you directing that question to?
I think that would be for Professor Ansa and Dr. Menaka, I think.
Okay, all right. Thank you very much. Okay. So is anybody's hand still? I can't see any other hand. Okay. Dr. Ajayi, please, you can pass your comment now, sir.
Yes, okay, yeah. Thank you so much, the speakers, wonderful talk. But why I said the comment is that I think Joseph has benefited immensely from his interaction with Hans and co. And we are thinking of doing something like that in Nigeria as well, where Nigerian surgeons, also aspiring surgeons, can be developed to this kind of skill. And Hans has agreed to be able to champion that kind of course. And so I think that's why we asked him to share his 30 years experience in 30 minutes, which I think he has tried to do. So I think it's something that AGs should look forward to, how we can collaborate to have a training program with this kind of people who have a lot of experience in endometriosis surgery.
Okay, well, you're in the best position to do that as the head of the committee for endometriosis in ages. I think we look forward to you creating a program. So I'll go back to Uche with Dr. Ola's question. Please, Uche, the floor is yours, please.
Yes, Dr. Ola, and thank you for the question and for everybody that is here. This is a very, very political question. And I'm going to try and respond to it as much as I can. The first point to note here is that MDT for endometriosis is evolving still. I think that's important to remember. It is evolving. It's not yet as advanced the way MDT for cancers are. And in various jurisdictions, you could see that in that presentation that I gave on the case history from the NHS, you could see that the conversations around radiologists and gynecologists in the MDT meeting, there were no colorectal surgeons in that meeting. But it's all part of that evolution. There is no doubt that in any MDT for endometriosis, you need to look at the patient holistically. And that holistic approach includes the assessment, issues around pain and the different contributors to the pain, as well as obviously their fertility desires down the road. What the politics is, though, is that if you have a patient who has adenomyosis, deep endometriosis, endometrioma, going to an IVF specialist for fertility, they will not do surgery for that patient to debulk the disease. They'll go ahead and do IVF. If that same patient goes to a laparoscopic surgeon, the laparoscopic surgeon will not think about IVF, they will think about excision laparoscopy. And that is what we see also in Australia and in different parts of the Western world, in my view. So that if you like, difference is there, but there is no doubt that endometriosis, for MDT for endometriosis, it has to be more holistic than that. And I agree that ultimately, as it evolves, it might get to a point where you have both, fertility specialists and excision laparoscopic surgeons, coming together to work for the patient outcome. At the moment, it seems to be, people stay in their lane and doing the things that they want to do in their lane. In my experience in Australia, there are only very few fertility specialists, that collaborate with excision laparoscopic surgeons. Very few of them. Most of them will just do IVF. They fail 100 times, and the patient goes away. So that's what it is. There's a politics around that. It's around people playing their own lanes. But I think that as MDTs for endometriosis evolve over time, there's no doubt in my mind that there will be a confluence point between these two, perspectives to endometriosis care. Regarding the second question from Dr. Opomu, when do you treat and when you don't treat? Now, if you remember, when I was presenting during my presentation, my last case, the patient from China, who had come because she had laparoscopy first in 2019, when she was 19 years old. They removed some endometriosis cysts at the time. And then over that period of time, she was not on any hormonal therapy for management. When she came to us about 8-9 years later, she was having lots of symptoms. She had that MRI that I showed you that was non-specific in terms of the details of her disease. And then by the time she saw us, in the initial time of assessment, after assessing her, we commenced her on Dynogest, Vizan. So she came back 3 months later, and then her symptoms had improved in terms of pain. Now remember, she was 31 years old. She wanted to get pregnant later. She was not intending to get pregnant right away. But the reason why she came was because of heavy bleeding and worsening pain. And even though we saw all those, multifocal bowel disease, she had no bowel symptoms. And therefore, there is no need to take her to theater because she's responding very well to medical treatment. So if down the road she fails to respond to medical treatment, they can reassess what her objectives are at that time, whether it's supposed to be for fertility or whether it's supposed to be for pain, and they can manage that. Now, people talked about the issues around malignant transformation for endometriosis. It is still quite low, very, very low, those transformations. However, you can, monitor these patients over time. So patients like that, in my practice, I do yearly ultrasound scans for them to make sure that the features of the endometriosis that we saw have not changed in that period of time. If they've changed, then we can now intervene as appropriate. But you're right, every time you see endometriosis, you don't have to operate. You go to marry it with, what the patient is presenting with. And that is a big paradigm shift from what it has been before. Before, we used to go in blind. Laparoscopy was the gold standard. You go in blind to see what you can see diagnostically and then manage if you can. But now, with all the imaging modalities that we have available to us, we don't need to do that anymore. Ultrasound is equally as good, or better than laparoscopy, for those kind of patients. So you can now direct your counseling more appropriately. You can direct your treatment options more appropriately for these patients.
Okay, thank you, Uche. There's a question on the chat, which is, I know the key role of transvaginal scan in diagnosis of endometriosis and adenomyosis. I would like to know the diagnostic approach Dr. Menakaya will recommend in virgins who present with features suggestive of endometriosis, adenomyosis when TVS may not be done.
Right.
I want to believe, yeah.
That's very good question there, right? And I'll tell you what I go through, what I do in my practice. So now I see, because of increased awareness of endometriosis in Australia, I see patients that are 14, 15 years old. They are obviously male coitus. What I do in the first instance is that I start managing them for, first and foremost, to think about dysmenorrhea as a first line. But before I do that, I tend to go through, I take them on a tour of our, endometriosis ultrasound facility. So I show them what the probe looks like. I show them how they are going to lie on the bed, what the processes are for endometriosis ultrasound, how the options that they have, including, if they want to self-insert the probe themselves. So even though some patients are vago intacta, some of them use tampons, and then they can obviously self-insert the probe themselves. Second point is that those that are quite motivated, we can offer them a transrectal ultrasound scan in those individuals as well. So transrectal ultrasound scans, TV that is self-inserted, is also, those options there. I remember we went for a mission outreach in Philippines. Philippines is a Catholic country. So there's a lot of vago intactas there, even at 25, 30 years old. And they all had transrectal ultrasound scans. There was no problem at all doing that. You just need to know how to orient your probe when you're doing a transrectal ultrasound scan. But if you have a young girl, who is, 14, 15, 16, with severe symptoms of endometriosis or severe symptoms suggestive of endometriosis, you can have all those options for them. You can, start treating them empirically with hormonotherapy, assuming that dysmenorrhea is a key issue. And if they come back in 3 months and they're doing very well on hormonotherapy, you don't have to do a scan for them. you can just let them to continue treatment and then come back if the symptoms relapse. So that is my approach to those patients, and so far it's been working quite well.
Okay, well, thank you very much. So I think we have 2 more minutes. I'm just going to quickly, I want to thank all the speakers for their wonderful presentation, but I want to, on behalf of AGES, ask them a very pertinent question. The question is that we form a committee, which is the endometriosis committee, and we are looking at capacity building. I'll be delighted. I just want whether you will commit to us by helping us train our members to the level in which people like Joseph Nyagi is. I think primarily I'm directing that question to Professor Hans and Joseph Nyagi, which is our neighbor around here. Would you be happy enough to be a mentor or a preceptor on our endometriosis committee for ages? Please, I know I'm putting you in a spot, but I want to actually do that. So a lot of people can hear you say yes, and then I can use that against you in the future. Professor Hans.
Well, thank you very much for asking this question, but I think I just agreed to becoming a member of this committee to Dr. Ajayi. So
okay, thank you very much.
I hope very much that Dr. Joe Nyagi might also accept this kind offer of yours.
I think Joe will accept that totally. I think I'm accepting it on his behalf. Joe.
Absolutely. The vote has been moved, so I'm more than delighted to be able to be part of
I
this.
think the future is, I sincerely hope that we'll be able to come and enjoy some sessions in your centers, look at. So I think that will come from the fellowship point of view. If we can appoint a fellowship from our members and then probably ask them to come to your center and get a lot more training. Thank you very much. So I'm going to close the session now, and thank you very much. I think we really appreciate it from the association. Many thanks.
Thank you very much for the opportunity. Bye-bye.
Okay, thank you. And then I pass it on to the next moderator to take over. So do we have the next moderators to take over?
Yes, sir.
Yes. Okay.
Good afternoon, everyone. My name is Dr. Riji. I work as a gynecologist at the University of Port Harcourt Teaching Hospital. With me to moderate this session, this scientific session 4 are Akinyemi Olaliye and Dr. Sekinath Raji. So we have 3 presentations for this session. I will introduce the first speaker, and I will allow my other moderators, Olaliye and Raji, to do for the other 2 presentations. So the first presentation for scientific session 4 will be taken by Dr. Adele Serati. Dr. Serati will be speaking on cesarean section scar.
Hello, Prof.
Can you hear me? Hello?
Yes, Prof. Yes, Prof.
So
Professor Jamal Fikri will be coming on now, sir. Ahead of him.
It's not
yes.
our session. Excuse
Professor
me.
Jamal
We're
Fikri.
supposed to be on break.
Professor Jamal Fikri.
Okay, so this is not scientific session 6, sorry.
No, it is. But Professor Jamal Fikri will be coming on. There's
there's a
slight modification, yes.
And wait a minute.
Before Dr. Adel Serati.
Okay, what will Dr. Fitri, Professor Fitri be speaking on, sorry? On my program.
Hello, dear colleague.
I'm
Dr. Fikri, I'm here with you.
Yeah, you did make a presentation.
Yes, my presentation is about management of cell.
Okay.
So I'm happy to be with you.
Thank you, Professor.
Honored to be invited with my African colleagues, and congratulations for the very nice Congress. I've seen many lectures, and really it's nice to be with you. So my topic for today is about cell, trending problem, because all we know that
So, hello.
Yes, I'm sharing my screen.
Okay, you can share your screen.
Okay. While Professor Filkri is sharing his screen, I can introduce him. He's a distinguished professor of reproductive medicine and surgery at the Abu Dhabi University. He's an expert in endometriosis surgery and assisted reproductive technology. And he's currently the serving president of the Moroccan College of Gynaecological Endoscopy. He's a distinguished member of the faculty of many global fertility societies across the world. And he's very well published author and editor. Thank you so much, Professor Fitri.
Thank you, Dr. Bolarinde, for stepping in. So, Professor Fitri, you have the floor.
Thank you, dear colleague. So I'm going to talk about ISMOCEL, which is trending problem right now globally. I will go to talk about a little bit about epidemiology and some symptoms and the clinical impact. And at the end, we'll see how to manage this condition with the surgery to improve our patient's life. Okay. So the definition of ISMOCEL or niche, or I prefer cesarean scar defect, is it is an indentation in the myometrium in the size of the cesarean scar. And according to the task force, this indentation should have a depth at least of 2 millimeters, and it could be measured in transversal plan. And also we have to measure the myometrial thickness adjacent to the niche. And if the ratio between the niche depth and the myometrial thickness adjacent is over 50%, we are facing a severe case of ISMOCEL, and these cases are more symptomatic. When you see the statistics in the literature, there is a wide range of frequency of this condition. But when we use in patients with the past of cesarean section, with the saline infusion sonography, which is the best tool to assess this condition, we can find up to 64% of patients with this condition. MRI is only a good tool to do this assessment, and hysteroscopy is still the gold standard. This is very frequent condition. We can see it in various ways, but all niches, not all niches or ISMOCELs are symptomatic. More than half of them, roughly half of them, are not symptomatic, and we have to keep that in mind before any treatment. And when we do this assessment of niches, we have to do it with transvaginal ultrasound to measure the depth of the niche, also the length of the niche, and transversally we have to measure and also to search for branches, because these branches, if not treated, can lead to bad results after surgery, like shown in this picture. We can use saline, we can use 3D ultrasound, and sometimes we can find some pathology within the niche, like in this case, I have found a polyp to be addressed also within the surgery. The shape of the niche is very variable, but pay attention to not to confound a niche with some Nabothian cyst that could be included in this part of the uterus. As I say, not all ISMOCELs are symptomatic, so not all ISMOCELs should be operated. Clinical symptoms are variable, but mainly it's abnormal bleeding, postmenstrual spotting, prolonged menses, dysmenorrhea, pelvic chronic pain, dyspareunia, and sometimes you can have secondary infertility, and the larger the size, the more frequent are the symptoms. So I have said not all ISMO cells are symptomatic. And this group of experts recently tried to make it more reliable what we do to not overtreat these patients. And they have made a consensus regarding the symptoms to be taken into account to say that this ISMO cell is symptomatic. There are primary symptoms. These primary symptoms, which are the most important, are postmenopausal spotting and pain during uterine bleeding, technical issue during embryo transfer, and sometimes it is very difficult to overcome this difficulty, and secondary unexplained infertility. And here we have to highlight that this condition should be combined with intrauterine fluid persistence to be considered as primary symptom. If there is no fluid in the cavity, it is a secondary symptom and to take with some caution. It is also important to rule out any other pathology that could explain the abnormal bleeding, like cervical cancer or dysplasia, infection, and other intracavity pathology. The pain could be related to abnormal contraction. It could be also accumulation of blood within the niche and secondary bleeding and postmenstrual spotting, and also abnormal vascularization within the niche that could also play a role in this abnormal bleeding. Here we can see within the niche some neovascularization that could explain some heavy bleeding. And for the impact on infertility, the blood, when it is retained within the niche, can come back and return back to the cavity and make it less receptive to the embryos. And also there is an impact on sperm transportation, which is important for fertility. And when we have to do embryo transfer in this patient, particularly when there is retroflected uterus with deep niche, you can understand easily that the catheter could go into the niche and make this transfer difficult. And sometimes there is a mistake, an embryo or put into the niche, and is a very great danger to have a cesarean scar pregnancy. Also, fertility in patients with the ISMO cells is reduced. We know that patients that have a past of cesarean section have 10% reduction of likelihood to become pregnant after this cesarean. And when they are operated for the niche, the spontaneous pregnancy can occur in 35 to 90% in the literature. And in patients with the failed IVF with the unexplained infertility, with no other explanation than ISMO cell, when they have been operated for their ISMO cell, 52% of spontaneous pregnancy were obtained after laparoscopic repair. Also, there is infection within the niche, and this study reported up to 90% of patients with symptomatic ISMO cell that have some bacteria in the niche, mainly Pseudomonas. So we have to think about antibiotherapy in this patient. Now we are going to talk about the therapy of this condition. We can treat them with hormones like oral contraceptive pills that can reduce the duration of menstruation and improve the symptoms. But when compared with the hysteroscopic treatment, there is no the result with oral contraceptive or less good than with surgical treatment with hysteroscopy. But actually, the best treatment demonstrated in this randomized controlled trial is the levonorgestrel intrauterine system, because with this system you can have no menstruation or very few blood within the cycle. So there is no blood accumulation within the niche, and the improvement is very fantastic in patients not seeking pregnancy. You have contraception and also very good treatment for the symptoms related to the isthmus cell. So when patients do not need to be pregnant, please do not operate, because there is a niche. You can use this device. You have contraception and also very, very important improvement in all bad signs with this condition. And surgery should be reserved for patients that do not respond to these treatments, or for patients needing or seeking for pregnancy. And according to the Global Congress hysteroscopy, when the residual myometrial thickness, the endometrium at the top of the niche, that should be measured, mandatorily measured before any surgery. The hysteroscopic treatment could be done when there is residual myometrial thickness is 3 millimeters or more, and laparoscopic reconstruction should be considered when this residual myometrial thickness is less than 3 millimeters. Vaginal route could be considered if the isthmus cell is very low and the distance between the isthmus cell and the external cervical os should be less than 4 centimeters to make this approach possible and not complicated. So before, when we need to treat this patient, the principle of hysteroscopic treatment is to prevent blood accumulation within this isthmus cell. So we have to do some flattening of the niche, allowing the normal menstruation to go out from the uterus without any obstacle, and also to treat the top of the niche, because in this part we have sometimes abnormal vascularization. We have also abnormal endometrial lining that could explain the persistence of the bleeding or the abnormal bleeding. Here is an example of hysteroscopic treatment. We see here at the entry that there is blood coming from the cavity. No dilatation was done in this case. When we access to the cavity, we can see that there is also some blood within the cavity, and this blood could prevent embryo implantation in case of infertility or IVF. Turn the scope, and here we can see that there is very, very deep niche with a branch, with the abnormal endometrial lining, and also with a neovascularization. We start the surgery by the resection of the caudal part of the edge of the niche. And this resection will do all this part of the cervix, and to be as low as possible to make the flattening of this obstacle effective and facilitate the evacuation of menstrual blood. We have to continue until we have a good and clear view to the whole niche when we are into the cervix. Millimeter by millimeter. It's not easy to do sometimes because we are working in a very narrow space, and it's not always easy to move in this narrow space to be very precise. And this surgery is something that should be very precise. Now we are treating the same, the cephalate part of the niche, but the resection is less extensive than in the caudal part. And the final point is to treat the depth of the niche. And here we can see that we are very superficial. We can resect, and you can also use cautery. For me, I use the bipolar current section, not coagulation, because coagulation go very deep and can damage all the myometrium. When we do section, you create some vaporization of this lining without going very deep. If there is branches, they should be treated. And at the end, we can treat also the posterior part to make the so-called like channel surgery. When it comes to treat patients with residual myometrial thickness less than 3 millimeter, the approach is laparoscopic. Here we can see a simple case, but something I would like to make the point on is that those fibrotic tissues here, we have two bundles, lateral bundles that do not exist naturally in patients. Those bundles are fibrotic and exert some traction on the cesarean scar, and that could explain why this traction lead to this ismocele. But what is important is that bundles, fibrotic bundles, give you also the way to find the place of the niche. It is not always easy to find it. Here you have an indication that indicates the place where is the niche. And those bundles should be treated. Here we have to also make a good vision of uterine artery before starting the surgery. If any difficulty to dissect the bladder, please feel it and do lateral dissection. Here we start with those fibrotic bundles, and that gives us the way to dissect the bladder in the right position, and also we know where is the niche because we have these landmarks. Careful dissection. Sometimes the adhesions are very strong, but here it was really a simple case to perform. But it's not always as simple as that. Look at this other case. Here we have something we can encounter in patients with very bad surgery for their cesarean section, and that could explain the infertility. We can see here in this case that the uterus sticks to the abdominal wall, very bad. Also, adnexa or adherent to the lateral wall, and sometimes to the anterior wall. And when you do hysterosalpingography in these cases, you can see all is normal, and you don't understand what patients are infertile after a cesarean section. Here you have to remove all this adhesion and to make the tube in the right position, to detach the uterus from the abdominal wall, which is not always easy. And at the end, fill the bladder, do lateral dissection because it's dangerous to start at the center of the dissection, do lateral dissection, and when you have released the bladder, do the central dissection. Now we are resecting the niche. I am used to use monopolar needle. You can use what you want, ultrasound or scissors or what you want. Be very, very aware about the danger to touch the uterine arteries. Uterine arteries should be localized and dissected before starting to resect those abnormal tissue, fibrotic tissue of the ismocele. Once it's done, you can see here that there is a Karman catheter into the cervix. I use scissors to do excision of necrotic tissue, and also because I have used monopolar energy, I prefer to do like this to have a good healing of the scar when I suture it. For the suturing, I advise to remove any uterine tutor that makes you able to manipulate the uterus and to make it, to put it in the position that allows you to make safe suturing and ease suturing. It's not always easy to suture in this narrow space. So the lateral port, the lateral port should be inserted very low. And at the end of the surgery, you can see that the tubes are in place, uterus in place, and the cesarean scar repaired. About the result of this surgery, when we do this surgery hysteroscopically to improve the symptoms like abnormal bleeding, we can have an improvement in the days of post-menstrual bleeding and discomfort significantly better after hysteroscopic resection for patients with more than 3 millimeter of residual myometrial thickness. And this meta-analysis showed that there is also a clear improvement in patient with all these abnormal bleeding symptoms with 0 complication. If you respect the rule of the 3 millimeter, you do not have any complication. But when you do it by laparoscopy, as you have seen in this case, it's not always easy to deal with the bladder, and sometimes we have bladder injury, which is something not difficult to repair. You have just to see it and not to forget to treat it. The pregnancy rates for patients with reproductive failure also are interesting, but very wide range of good results with this surgery, ranging from 25% of spontaneous pregnancy to 100% in some series. I have a doubt about that, but you can obtain roughly 1 of 2 patients could be pregnant, and 1 of 3 or 4 could be pregnant after this surgery when done hysteroscopically or laparoscopically. Also, the reshaping of the isthmus cell has been studied, and the residual myometrial thickness improved after hysteroscopic surgery from 2.3 millimeter to 4.3 millimeter. It was interesting, and the volume also significantly decreased, abnormal uterine bleeding decreased, and there is a significant improvement of pelvic pain. And when done by laparoscopy, we can see that the improvement of this myometrial thickness is more important. And it seems that when the residual myometrial thickness is over 5 millimeters, it is a good prognosis factor for fertility. And the results reported after laparoscopic surgery could reach roughly 50% of good results with spontaneous pregnancy. But we have to keep in mind something important in this very large study with over 10,000 embryo transfer cycle. It was demonstrated that the impact of isthmus cell on IVF cycle and reproductive rates in IVF cycle, that the presence of isthmus cell do not impact the results, but the impact is seen only if there is a fluid within the uterine cavity with this isthmus cell. When there is no fluid, there is no impact. So at the end, we can say that the surgical management of isthmus cell is dependent of symptoms. If there is no symptoms, no treatment. If the patients are symptomatic, we have 2 kinds of patients: patient with reproductive desire and patient with no reproductive desire. When there is no reproductive desire, levonorgestrel intrauterine system is the best way to treat this patient with very good results, better of any surgery. If not, and according to residual myometrial thickness, we can deal with laparoscopy or with hysteroscopy. But I think that the patients that do not need to be pregnant could all treated by hysteroscopy. Few of them should be treated by laparoscopy. When there is a reproductive desire here, we can do according to residual myometrial thickness, hysteroscopy, or laparoscopic approach. And at the end, for patients with abnormal bleeding that do not respond to any treatment, hysterectomy could be considered. So when we deal with this condition, which is not very known, the impact or today is not very clear of this condition. Yes, we know that there are symptoms. I have highlighted the strengths of treating this pathology, but there is also some treats, and the major treat is to overdiagnose ISMO cell and overtreat ISMO cell, exposing our patient to complications, and they don't need surgery because there was no indication. And also all the studies are very poor quality now, and we don't have the good evidence to claim that that's what we are doing is really something evidence-based as we have to do today. But things are improving, and by doing with the good assessment, not operating all patients, good selection of patients, good surgery, we can improve and have good results for this condition. Thank you for your attention and for your invitation.
I want to thank Professor Fikri for his presentation on ISMOCIL. If you have your questions, we'll do the question and answer at the end of the session. So we will move on to the next presenter. The next presenter is Dr. Adel Sedrati, sorry. And I want to introduce him to the audience. He is a gynecologist and an obstetrician from the University of Constantine in Algeria. He is an experienced gynae endoscopic surgeon and heads a center in Constantine that performs over 1,000 office procedures annually. Dr. Sedrati is also a medical educator and has been involved in teaching doctors to acquire the African Diploma in Endoscopic Surgery. He is active in several international organizations, and his focus is in advancing hysteroscopy and establishing standards. May I invite Dr. Adel Sedrati to make his presentation on cesarean scar pregnancy, diagnosis, and surgical management.
So thank you very much for having me. I'd like to thank everyone from our colleagues here. And I'm really so happy to see everyone and to be here, and especially to talk after Professor Fikri, which is a real hard task. And I'm thankful to him because he did prepare the ground for me to talk about this problem, which is real, especially for us in Africa. So do you hear me? Are you seeing my screen?
Yes, we can hear you, and we can see your screen.
Perfect, thank you. So the real problem that we were talking about, which is cesarean scar pregnancy, and because Professor Fikri did talk about pretty well, and thanks to him about the cesarean scar defect, which is a defect right now, my talk will be about cesarean scar pregnancy. So I do not have a conflict of interest, just having a study about hysteroscopic management of cesarean scar pregnancy. And we are trying to introduce the word of uterine, the pregnant uterus sign, which we will talk about later. This is what I will try to talk about. It looks like a course, but I will try to have the most updated papers available regarding scientific value. Let's start about definition. What is cesarean scar pregnancy? It's all the pregnancies that implantation will be in or in close contact with the niche. So the key word here are implantations and in. So always there is like gestational, the trophoblast in contact with the scar. Then, if we try to look to what is published from PubMed, we will see that really there are lots of papers from year to year coming about these pathologies. Another fact, if we try to look to the incidence, it's rare pregnancy. But if you look to the literature, we will see that in 2001, only 19 cases were published. And by 2007, 161 cases had been reported. And now we are at the time of systematic reviews about different publications. Again, one very important question: is cesarean scar pregnancy an ectopic implantation or a normal implantation? We have to respond to this question. Why? Because to stop a pregnancy, ectopic pregnancy, we can't stop it because we know that it will harm the mother or the lady or the woman. But if it's a normal pregnancy, we are not able to stop this pregnancy. Let's see what the European says about this question. This is a terminology that describes the ectopic pregnancy and the recommendation for good practice from the HRE. They say that a pregnancy which is located within the uterine cavity should be described as a normal-sighted pregnancy. Look to the triangle. This triangle, all pregnancy that will be there is qualified as an ectopic pregnancy. Then they say that ectopic pregnancy should be classified as uterine and non-uterine pregnancy. That means that we can find ectopic pregnancies situated at the uterus. Example, ectopic cervical pregnancy, muscular pregnancy or myometrial pregnancy, cornual pregnancy. All those kinds of pregnancy are ectopic pregnancies, but situated at the uterus. And then at the end, they will say, all the experts, and you see the level of agreement that the classical classification about tubal and non-tubal pregnancy has to be abandoned. This is the European idea. Let's see what the American say. This is really a very recent paper published less than 1 month before. You see that the radiologists among the United States make statements and they say that look to all those new, let's say, words to talk the same language between experts, and you will see that cesarean scar pregnancy is really classified as an ectopic pregnancy. So the response to the question, cesarean scar pregnancy is an ectopic pregnancy. Then let's go to the diagnosis. We know that pregnancy means HCG beta positive, but the gold standard till now, it's the 2D with the 3D and the color Doppler. The MRI can be used, and we don't have till now real standardized guidelines on how to locate this kind of pregnancy. This is the ISMOCEL, but I don't have to think about it because Professor Fikri before me did great about this question. But these are also the different states that you have to find inside of your picture. But let's talk about differential diagnosis. So this is a paper published months ago and on how to perform standardized examination while cesarean scar pregnancy by the ISWOG, which the yearly congress is happening right now. So look, if you, by ultrasound, we have to confirm the diagnosis and to do the difference between ongoing miscarriage and cervical pregnancy. For example, cesarean scar pregnancy, you have to have a scar. You have to have the implantation just inside or across from the scar. And when you try to move by using your hand, which is the sliding test, it's like a negative. And you see in cervical pregnancy, the Doppler signal is situated at the opposite or at other side compared to the cesarean scar tissue. Here, it's a very nice statement because they say all the pregnancies that located on a well-healed cesarean scar are not qualified as cesarean scar pregnancy, which is a very important statement. Then, let's go on how to evaluate and measure this cesarean scar pregnancy. And please take this paper, print those 8 conditions and put it in front of your ultrasound machine before touching a cesarean scar pregnancy. Why? Because you need to locate the gestational sac, you need to see if there is an embryo and to check for the activity, the placenta, in relation to the scar, the Doppler, the residual myometrial thickness, the bulging inside or toward the serosa or the bladder, which is the crossover sign and a very important sign, the protrusion by the serosa line, and the presence of the sliding test. What about the classification? You will find in the literature too many classifications, but the most used is the classification of the ISWAG, and this is Professor van den Bosch. I had the chance to meet him in like a previous meeting, and it was like building bridges between hysteroscopy and ultrasound, and we were there and talked a lot about cesarean scar pregnancy. Look, when you do your hysteroscopy, your ultrasound image, try to draw 2 lines, and the first line, which is the uterine line, and the second one called the serosa line. Then you will check the pregnancy. If you see that the pregnancy is situated just close to the uterine line and the development inside of the cervical canal or the uterus, this is the type 1. Type 2, between the 2 lines, and type 3, show the pregnancy bulge and go up to the serosal line. Other thing, very important thing, which is we have to check the relationship, because some, as Professor Fikri stated before, some, and we have seen that by hysteroscopy, some cesarean scar, the development is made at the lateral sides. Here, you will see that and fistula with the uterine pedicles, which is really important to know before touching this kind of pregnancy. Here, on how to manage. To be brief, that we see that all the cesarean scar pregnancy, whatever the type is, the 3 between 4 cases will be referral to the expert clinics, because those who are not implanted in the scar, they are not cesarean scar pregnancy, and those who are implanted will come back even at 8 or 9 months with a high risk of placenta previa and placenta accreta spectrum, as everybody knows. Then, what to do? We have the diagnosis. Look to this study. This is the most recent and the biggest series about expectant management. And if you try to look closely to this paper, look what you will find. Only complications, fetal death, preterm delivery, placenta accreta spectrum, and half of patients had hysterectomy. And if you try to look more closer, you will see here that this article provides a good understanding. Why? Because high rates of prevalent morbidity. Again, let's see what they state. From this paper, it has been clearly shown that type 2, type 3 crossing over sign in the niche lower myometrial thickness could be related to the worst outcome from the expectant management. Another thing, look here, please, we have maternal death. So if we try to expect, we could have maternal death. This is a scientific paper. Look we publish papers about maternal death regarding cesarean scar pregnancy. Till now.
Hello.
This
Yeah,
is another. Here you will see that there are three or four kinds of treatment, which is medical, surgical, double balloon, and other treatments. But what I'm trying to show to you here that we have to diagnose and to treat this kind of pathology as earliest as possible, because it's clearly shown that the delay of diagnosis is directly related to the rates of complications. So if you try to wait till when the pregnancy will become more and more important, you will find more and more risk of having complication while you will treat this patient. So if you try to look up to the papers, you will find that D&C is cited between types of treatments. I always say why we have to go blindly if we have a tool which is perfect that allows us to see and to treat at the same time, which is our hysteroscope or at least our laparoscope. Okay. What about hysteroscopic management? So we can perform the resection of the cesarean scar. We can treat the pregnancy after a first-line treatment, which is the HIFU. After uterine artery embolization, for example, we have a high success rate. We always have a chance to have a complication, and it is proven that it's a safe and effective procedure. And I'm so happy, and I will use this opportunity to share with you this nice pattern, which is a hysteroscopic pattern of the endometrium called honeycomb pattern. We had the chance to be the one who find it for the first time and published it on the Gynaecological, and it has been published and put at the opening page of the review, and we got like really a good feedback from all the experts about regarding this field. Then here, this is a randomized clinical trial which shown clearly that hysteroscopy for the treatment of cesarean scar pregnancy gives better success rate comparing to dilation and curettage. This is my fights, and this is my way of treating cesarean scar pregnancy, which is the intracardiac KCl injection. And here, the ectopic embryo is injected by hysteroscopy under direct visualization. There is no ultrasound guidance. There is no blindness. And this is the second video is about the effect of methotrexate on the embryo, but we see that the heart is still beating. And also another one, and I'm using this technique, and it has been published as a case report before, and I did send a case series about 21 cases to the AGL this year, and it was accepted to be presented at the Congress in New Orleans this year. So the first time we try to stop the cardiac activity, and we will follow the patient by Doppler ultrasound till when the Doppler signal will be completely zero, and then we will go just to move the retention trophoblast tissue inside of cesarean scar pregnancy by hysteroscopy 2 times treatment. Local laparoscopy and robot, as Professor Fikri shown, here you have to have at least a level 3 of skills related to the mastering laparoscopy. And here I'm talking as second responsible of the accreditation committees inside of the ISGE. You have to master how to perform adhesiolizes, how to find to open the retroperitoneal space, find the uterine artery, make a ligation, the bladder dissection, and the excision of the uterine scar that contains ectopic pregnancy, and to repair the defect. Other treatments Here, for example, the uterine artery embolization, it comes from China. This is the best way to use, especially for us, for me, and for African. If you have cesarean scar pregnancy and it bleeds, please put a balloon inside the cervix and try to put the liquid inside. You will stop the bleeding. You can wait for the senior surgeon to come. You can ask for blood to transfuse your patient, and you can use it as a second level of treatment. HIFU also can be used to treat cesarean scar pregnancy as the first time treatment, followed by hysteroscopy and to take out the retention product. Look to this publication. It has been published, I guess, 2 or 3 months ago. And they try to put alcohol inside of the sac and then dilation and the curettage without direct visualization. Look also to this other publication, and here I see one of my best friends. They tried to inject methotrexate inside of the sac blindly, and then go by laparoscopy. This is fertility and sterility. And here I ask why, because you are mastering laparoscopy, I guess you will have hysteroscope, why you are not able to inject this methotrexate inside of the sac by using your hysteroscope and the direct visualization and avoiding vessels. Okay, laparotomy remains always a solution, at the last solution. So please, if you are really in a difficult situation, and we know that this is the most, when cesarean scar pregnancy bleed, it's like really an emergent situation, don't hesitate to perform laparotomy and go even for a radical treatment if the patient life is really between your hands. So let's talk about recurrence on cesarean scar pregnancies. This is my guess, the unique paper that you will find. But here you see that the rate of recurrence is really higher, and I'm dealing with at least 2 cases of cesarean scar pregnancies per week, and the rate of recurrence is really, really lower than it has been shown here. One other thing, this is the response to all those. I know if we talk about hysteroscopy for cesarean scar pregnancy, laparoscopists will say this will be the best and the most complete treatment for cesarean scar pregnancy. Yes, but what we know from the literature is that there is no obvious causal relationship or association between the type of treatment and the recurrence. Remember of that. If you treat your patient by laparoscopy, you will not decrease the risk of recurrence for this cesarean scar pregnancy, or at least we don't know this information. In conclusion, I have to see that you will find from the literature more than 30 kinds of treatments, but I will emphasize that there is a lack of consensus, and all the current recommendations are based on small series or case reports. And thank you for your attention. About complication, and thank you. Are you hearing me? Hello, hello.
Yes, we can still hear you.
Perfect. So
you've concluded, right?
Yeah, conclude everything. Yeah, I will be very happy to respond to your question. Thank you.
Thank you, Dr. Sedrati, for your presentation. I hope you will hold on after the other presentations for some question and answer session.
Yeah.
I want my other moderator, Dr. Akinyemi Olaleyi, to introduce our next speaker, am I on to Olale? Okay, if it's not here, Sekina Tragic, can you take on that?
Yeah, good morning, sir.
Okay. I
Yeah,
would like
good
to introduce the next speaker so that you can take on his presentation. I will do the last one after you.
Okay. So the next speaker is Dr. Kingsley Agolo. I don't know if he's with us, Dr. Kingsley. And he's going to take us on the use of ultrasound for evaluation of gynecological conditions before minimal access surgery. Dr. Kingsley Agolo is a consultant obstetrician and gynecologist at Central Hospital, Warri, Nigeria, and a former chief medical director. He has over 30 published research articles and extensive training in reproductive medicine and ultrasound. Dr. Agolo organizes an annual gynecological ultrasound course in Nigeria and is an executive council member of AGES. He is also the CEO of Postal Specialist Clinic in Warri. We welcome Dr. Kingsley Agolo. Thank you very much, sir.
Yes.
I'm grateful for the opportunity given to me today to talk about what is new in the use of ultrasound for the evaluation of gynecological conditions before minimal access. I'm a GE Healthcare key opinion leader in the West African sub-region, and I receive fees from GE to give lectures on gynae ultrasound. The aim of today's talk is to demonstrate to you the newer benefits of ultrasound in the preoperative evaluation of the gynecological patient. I will show you how ultrasound can make you a calmer surgeon and shed light on areas where it has made the impossible possible. Most people think that ultrasound is a diagnostic tool, which is true, but I have been trained to believe that ultrasound can be taken beyond its fundamental utility as a diagnostic tool to function as a clinical tool which can determine the management of various gynecological conditions. Regarding the topic of today, there are newer considerations across the various conditions displayed, from the GEAI tool for fibroid mapping to answers to questions on when to worry about sarcomas when considering fibroid surgery, to whether to measure or not to measure adenomyotic infiltration of the junctional zone, to considerations from the 2-year review of IOTA 5, IOTA 1 recommendations, endometriosis, and of course, the emerging role of the gynecologic surgeon sonologist. To be honest, it is impossible to discuss all of these within the allotted time of 30 minutes. So today, we will focus on the newer role of ultrasound in the management of endometriosis by looking at how to link ultrasound to surgery, keeping our focus on superficial peritoneal disease, deep endometriosis, and endometriomas. And then we will leave a word on the emerging role of the gynecologic surgeon sonologist, the knowledge of which we provide answers to areas that we could not talk about. The goals of endometriosis surgery is evident to all of us here, but a reminder might be necessary. It is to relieve pains and symptoms for our patients and to restore anatomy while preserving functions, particularly in terms of fertility rate, not to mention the need to prevent disease recurrence. But the primary aim, of course, is to improve the quality of life for our women from here to here. Many times when we talk about linking ultrasound to surgery, to the surgeon, it is deep endometriosis that we may be concerned about. Because of the 3 subtypes of endometriosis: peritoneal endometriosis, endometrioma, deep endometriosis, as described by Mitchell, Niso, and Jack Tones. It is deep endometriosis that requires the most advanced laparoscopic skill, and of course, the need for a multidisciplinary team, including the colorectal surgeon or the urologist in some cases. The whole point of ultrasound and linking it to surgery is that we do not want any surprises during our surgery. In this case, for example, as a surgeon, you suspect that there is a bowel nodule of endometriosis in this tethered area, a nodule of deep endometriosis in this tethered area, but you are afraid to exploit because you did not inform the colorectal surgeon and you are unsure of his whereabouts. Whereas ultrasound done before surgery would have shown you this image, and you would have seen the uterus, the torus uterinus, which is the back of the cervix where the uterosacral ligament attach, and you would have seen this deep endometriosis of the uterosacral ligament, and you have seen this bowel nodule of endometriosis, and you would have seen this bowel addition to the torus uterinus information, which if gotten before surgery would have helped with the planning of the surgery and ultimately improve the outcome. Let's talk about this later, because what is newer than that now is the increasing interest in the role of ultrasound in recognizing superficial peritoneal disease. Superficial peritoneal disease, why should we worry about it? Because of the three subtypes of endometriosis, it is the most common, accounting for about 80% of all patients with endometriosis. Surprising, isn't it? But that is the evidence. Again, the belief that it cannot be seen on ultrasound, nor can superficial peritoneal endometriosis be recognized using MRI, has led to a repeated number of unnecessary surgery, both for diagnosis and for treatment. And yes, surgical reintervention is common because of the high rate of disease recurrence, about 50% within 5 years. Repeated surgery, of course, equals increased risk of complications and adhesion formation. Therefore, superficial peritoneal endometriosis is an important disease for us to better understand. And these are the sort of lesions that we're talking about, clearly unrecognizable at open surgery. Look at this. You ask yourself, how can someone miss something this obvious? But we learn from Adamu et al. That it can easily be missed at laparoscopy through incomplete description of lesion or even failure to recognize lesions at laparoscopy. So at laparoscopy, look diligently at the uterovesical fold to see lesions like this, and you will see pustule stretching on the uterus itself. Again, look at the ovarian fossa, and you flip up the ovaries so that you can see the back of the ovary, and you see these strawberry lesions on the back of the ovary. And then you get to the patch of Douglas, and you see these pustular lesions there, and the patch of Douglas. And look at the pelvic side door, and you see these petechial hemorrhage-like lesions there. A lot of people believe that ultrasound will be normal in many instances like this. And for many years, we all believe that superficial peritoneal endometriosis cannot be seen on ultrasound, leaving diagnostic laparoscopy as the only tool for recognizing it. Not anymore. Because we learn from the Tom Holland group that the diagnosis of superficial peritoneal endometriosis in the patch of Douglas is possible using routine transvaginal ultrasound in the clinic. Previously, it was a research procedure. So this is a landmark achievement because it saves the patient from diagnostic laparoscopy and reduces the number of unnecessary surgeries. And this is how they appear on ultrasound. You see in image A, this hypoechoic lesion. You see the type of lesions you're going to see at the back of the vagina. And then in image B, you see it here encased within the subperitoneal fat, just beneath the peritoneum. And in the same image, the presence of this hypoechoic area peritoneal fluid in the pouch of Douglas makes it easy to delineate the tissues. So how do we find superficial disease using ultrasound? Your probe must be in the posterior fornix, not in the anterior fornix. And in that position, you'll be seeing this layer of peritoneum at the back of the vagina. The presence of fluid, as in this image, is super helpful. Let us begin from the beginning. What are the peritoneal landmarks that we expect to see on transvaginal ultrasound? In these two images, the probe is in the posterior fornix here. And then you see the vagina appearing as this hypoechoic area here. And then you see the subperitoneal fat hyperechogenic layer overlying it. Remember, there's always a layer of fat beneath the peritoneum, and the peritoneal surface appears as a thin black line over which surrounding structures slide once probe pressure is applied. That is a normal anatomy. But look at the images again, and you see that in image A, the presence of bowel here and the absence of fluid makes it difficult to actually distinguish the peritoneum from the bowel. But image B, the presence of this hypoechoic area, the peritoneal fluid, makes it easy to delineate, describe the structures as you see: subperitoneal fat, peritoneal surface, and then the vagina just below. But if you push on the probe, the bowel will slide freely over the peritoneal layer. That's why we're able to apply this serrated white line, which helps us to distinguish the peritoneal surface. Pushing on the probe in the absence of fluid helps you to quickly delineate the structures. So what are the type of lesions that we're expected to find when we scan? They appear as hypoechoic breaks in the peritoneum, and you see it here. This is about 3 millimeter deep, and this is about 1.6 millimeter deep. See, you remember your ultrasound anatomy, you see the subperitoneal fat here, and you see the vagina here. It's pretty obvious. Once you get used to seeing lesions like this, and then you see the peritoneal layer here. So they are exactly where you expect them to be, at the back of the vagina, hypoechoic structure. It's quite difficult to miss them once you get used to seeing them. How do we describe them? We describe them in relation to the peritoneal surface. Peritoneal only lesions are on the surface of the peritoneum. Subperitoneal beneath the peritoneum. And peritoneal bridge, they have infiltrated the deeper structures. How do we see these on ultrasound? Peritoneal only lesions are located on the surface of the peritoneum. And again, you see it here, hypoechoic lesion sitting on top of the peritoneum. Subperitoneal fat intact just below it, and the vaginal muscle just below. Again, you see it here, and then the presence of fluid here makes it so clear. It's visible at laparoscopy and can be easily examined. The subperitoneal lesions appear under an intact peritoneal surface. Here, you see this hypoechoic area of endometriotic tissue encased within the subperitoneal fat, as if the peritoneum has grown over it. It's not easy to see at laparoscopy. It can easily be missed. And then you see it here, this how
Thank you, Dr. Agolo, for the wonderful presentation. As a recap, it has talked about the role of ultrasound in gynecological and endoscopic surgery, and mostly with regards to management of endometriosis. The role of ultrasound linked to surgery is also useful in the case of fibroid and other gynecological conditions. It serves like a kind of an AI tool, and the role of ultrasound helps to ensure that there are no surprises at surgery. Hence, it helps with planning the surgery. We also talked about ultrasound recognition of superficial peritoneal endometriosis, which was hitherto impossible or thought to be impossible. But now it's been found out with certain landmarks, which he showed us extensively, that with the probe in the posterior fornix and knowing the different layers of the peritoneum, one can identify superficial endometriosis, and classifying them also helps plan surgery. And he went to town on these classifications. We also compared the use of transvaginal ultrasound with MRI in the diagnosis of endometriosis, and showed us a lot of studies that makes transvaginal ultrasound, and even in some studies appeared as the highest level of evidence with regards to diagnosing endometriosis as against the use of, in comparison with the use of MRI. So he concluded by saying that transvaginal ultrasound in conjunction with clinical history significantly reduces the need of diagnostic laparoscopy for diagnosing endometriosis. And as a final statement, he emphasized the need for the gynecological surgeon to be the gynecological surgeon sonologist, as the gynecological surgeon who scans the patient to take a better lead at surgery. We thank Dr. Kingsley Agolo for this wonderful presentation. The next presentation is a slight deviation from what's available on the brochure. So next we are going to take Professor Jude Okoye, who is going to take us through intrauterine adhesions, the art of safely navigating the uterine cavity. Is Dr. Jude Okoye available, please?
Yes, I'm here. Thank you very much.
Yes, so Dr. Jude Okoye is an obstetrician gynecologist. Professor Jude Okoye is a former vice president of AGES and represents West Africa on the Global Congress on Hysteroscopy Board. He was a board member of the AAGL Hysteroscopy Special Interest Group and is currently on the AAGL Professional Education Committee. Professor Okoye is the lead editor of Gynecological Endoscopic Surgery Basic Concepts, and he serves on several international journal editorial boards. We welcome Professor Jude Okoye for his presentation. Thank you, sir.
Yeah, thank you very much for that warm introduction. And my apologies, because as we all know, the ASCAF conference is clashing with our annual meeting, and I have some major roles to play there, including a presentation in the next 45 minutes or so. So without further ado, let me quickly go into my presentation. I've been asked to talk about intrauterine adhesions, the art of safely navigating the uterine cavity. I'm sure it's a talk that a lot of us would have heard from me in the past, so I will not spend too much time, but probably spend more time talking about practicality and the things you need to do when you're in theater. I have no financial interest to declare for the purpose of this presentation. For the learning objectives, let me get this out of the way. Yeah. So at the conclusion of this presentation, the participants should be able to at least apply tricks learned on how to navigate a difficult cavity in cases of moderate and severe Asherman syndrome. And of course, recognize uterine perforation when it does occur and employ steps in preventing a perforation. By way of introduction, we know that intrauterine adhesion defines the occurrence of scar tissues within the uterine cavity. And when these scar tissues give rise to symptoms like menstrual irregularities, such as hypomenorrhea, abdominal pains, recurrent pregnancy losses, or infertility, we say the individual now has Asherman syndrome. And it was first described by Heinrich Frisch in 1894, but later characterized by Joseph Asherman in 1948. It's good for us to have a little bit of understanding about, just a recap, about the anatomy of the uterus. You can see the uterus normally has a fundus, has a body, of course, has a cervix, and the endometrial lining, of course, the myometrium is also important. And the aim of hysteroscopy, as we all know, is to try and find our way, inside the uterine, it's a cervical canal, and straight into the uterine cavity. It's also important to note that we describe the uterus as being pear-shaped and weighs about 50 to 60 grams, with a length of 6 to 8.5 centimeters in nulliparous women and 8 to 10 centimeters in multipara women. Endometrial cavity volume is about 5 to 10 mils. That's very important because you know that after dysolysis, most times we try to aim to put in about 3 mils of fluid to keep the walls apart. Transfundal endometrial cavity width about 2.2 to 3.4 centimeters. There could be more in some multiparous women. We also, as a reminder, should remember that uterus can be anteverted when it's tilted forward, retroverted, tilted backwards, antiflexed when it's bent over on the cervix, and retroflexed when it's bent backwards on the cervix. Now, the landmarks that are very important during hysteroscopy will include the external os, which is the first thing we see when we enter the vaginal canal, the vagina, the endometrial canal, the internal os, the endometrial cavity, and of course, the tuber ostia will tell us that we are right inside the cavity and probably have reached the level of the fundus. Why do we need to perform hysteroscopy in the cases of Asherman syndrome? We aim to restore the capacity and shape of the uterine cavity. At the same time, we want to help the woman to restore proper menstruation, and if possible, and where possible, to restore fertility as well. There are various classification systems, which I'll not go into today, but a lot of people probably prefer to use the ASRM classification, which looks at the type or extent of cavity involvement of the adhesions, the type, whether it's filmy, dense, and then whether there's menstrual irregularity or not. Now, I think it's clear now to all and sundry that the standard of care when it comes to hysteroscopic adesolysis is with the use of cold scissors. All papers over the years have now confirmed all that cold scissors is preferred to the use of any energy device for reasons that I'm sure a lot of us already know. For the sake of time, I need to just move forward. Now, this paper that was published about, I think, 2020 or so, concluded that hysteroscopic cold scissors is more efficient in preventing intrauterine adhesion recurrence, increasing the menstrual flow, and also reducing intraoperative blood loss and shortening the operating time. Now, how do we access the endometrial cavity through the hysteroscope? Of course, you could use a 0-degree scope, or you could use a 12 degrees or 30 degrees scope, as the case may be. Now, in this case, I'm using a 25-degree telescope, 2.7 millimeters. And as you can see, it's placed in such a way that where the light source is attached to the telescope is at 6 o'clock. So for an anteverted uterus, for example, we want to keep that light source at 6 o'clock. And if where possible, keep the cervical canal also, the small hole that you're probably going to find your way, used to find your way to the cavity at 6 o'clock as well. So when you do that, it will be easy to go in, get to the uterine cavity, have a panoramic view, and then look for the tubal ostia. Now, when we encounter adhesions, straightforward adhesions, the rule of thumb is that we should try to separate the centrally placed adhesions or scar tissues first. The reason being that these adhesions are usually less dense and less vascularized. So when you get rid of them, it becomes easier to focus on the denser and more vascularized adhesions that might be on the lateral wall. So as a rule, that's what we aim to do most of the time whenever it is feasible. Just that sometimes it might be difficult to know in some very bad situations where is the centralized adhesion and where the lateral walls might be. So we went in, and of course, you turn with a 30-degree scope, you turn your light source to face where you want to operate upon. And of course, the rest just to get those adhesions out, and we are done. Now, of course, naturally, we expect that there should be a communication between the cervical canal and the endometrial cavity. Therefore, there should be a hole that you can pass through to find your way right in. So whenever you find a hole while trying to navigate, it makes sense to try to explore that area gently with the scissors again, just to be sure that there is a cavity behind that area. I should mention here that in some very severe cases, we tend to want to use concomitant abdominal ultrasound scan, which will help direct us right inside the cavity. Very important. Some people choose to use a laparoscopy, but of course, laparoscopy, as we know, might not really show you where you are within the uterus. But of course, it can help you push out the bowels and other vital organs so that if there's a perforation, you realize it and you not damage any of these vital organs. But it does not on its own prevent perforation during adhesolysis for moderate to severe intrauterine adhesions. So again, we've cut, you can see there's no bleeding because these are scar tissues, and we keep cutting, we keep finding our way gently, probing until gradually we find our way right inside the cavity. You can literally call this light at the end of a tunnel. Now, sometimes too, you have this worry whether it's actually the tubal ostium you're looking at or actually just a hole. I've seen some hysteroscopes that are graduated, and it makes sense because, like we said earlier on, about 6 to 8 centimeter depth for nulliparous women and 8 to 10 for the multiparous women. So if you go in just 4 cm and you think you are hitting the fundus, there's something wrong, except if maybe you had scanned her before then and maybe she has an infantile uterus for any reason, then it probably makes sense. So you go in 3-4 centimeters and you hit what appears like fundus, there's something wrong. But generally speaking, when you see tubal ostium, the anatomy includes a very well vascularized area, and sometimes it can open and close on its own, like undergoing some spasm during hysteroscopy. So that tells you that you're probably within the tubal ostium. Now, there are times, of course, we mentioned you can use ultrasound scan to guide you as you are inside the uterus. But again, ultrasound scan will not tell you what's happening right inside the uterus. So there are certain things that will probably guide you. For example, if you find dark areas, like we've said earlier on, are areas that do not transmit light, because naturally during hysteroscopy, there's light transmission towards you. So everywhere appears pinkish or probably whitish if fibro tissues are there. As you can see in this video, there was a dark area, and that meant that there was probably something behind that spot. And that's why we had to, in a way, try to explore that area until, I need to move this a bit for the sake of time too. So we kept on exploring and exploring until at the end of the day, we were able to find a nice looking frontal region just beyond this. And that is the tubal ostium right there. And adhesolysis continued until we were sure that all the adhesions had been taken care of. In some very difficult situations also, it might be difficult to tell where exactly you want to explore. Now, in this video, you see that sucking in of secretions. That tells us that there is something happening there. And again, like I said, this is unlikely to be the tubal ostium because it doesn't have blood supply around it. It's not increasing, undergoing some form of spasm. So that was a giveaway. Again, it was a hole. A hole does not appear like tubal ostium. And so, of course, it was, we got there within 4 5 centimeters of entry into the cavity or into the cervical canal. So we knew that obviously that was not the point. And this particular woman had amenorrhea. Now, another thing I want to highlight here is the issue of pink tissues. You can see the pinkish tissues towards the patient's left. That's towards my own right-hand side. Now, that's a guide because the normal cervical canal stroke endometrial cavity columnar epithelium is rather pinkish, or some describe it as being a bit reddish. So that was a giveaway as to where exactly we needed to explore. Now, as you are exploring, you must be very careful. These tissues you are seeing right in front of me are myometrial tissues. So you cannot afford to go towards my left. So if you move towards the right where you saw the pink tissues, then you'll probably be lucky to find the endometrial cavity. Now, there are times too we go in and maybe the woman has undergone a lot of uterine procedures like D&C or any form of instrumentation, and you see multiple holes, and you're not even sure exactly where to pass through to get into the endometrial cavity. Now, the same principle applies. If you can find a hole that seems to lead to other holes, then probably you should explore that particular one. If you find a hole like this one beneath the cavity and the posterior wall, where it ends in some sort of cul-de-sac, then obviously there's no point going that way. Now, if you find a hole, or if you don't find a hole, but you find dark areas, meaning that there's no transmission of light from those areas, it's worth exploring those areas. So here there's a hole, and the hole seems to lead somewhere. So again, some form of exploration. So we try to expand that a bit until the hysteroscope will be able to find its way through that narrow space. Now, when you do this, it's good to go close and watch from afar and just see what's happening in front of you. It's not advisable to just keep cutting and cutting, because you might keep cutting and cutting, and the next thing you are within the abdominal cavity. That means there's a perforation. So you just cut a bit, you go close, you watch and see if there's still further or areas you can pass through to explore. So we go close, and in this particular instance, we didn't need to cut any longer. Just navigating through that area, we'll be able to now find our way right inside the uterine cavity. And in this particular case, she actually had a submucous fibroid, which had to be removed thereafter. Now, this interesting case I've presented too many times. I talked about the use of ultrasound scan in guiding you, and the use of laparoscopy as well. But there's also the use of fluoroscopy, just like performing HSG. Mark Emmanuel and colleagues, as a routine, they do that during all cases of moderate to severe adistolysis, where they carry out concomitant HSG or fluoroscopy to guide you and tell you where tissues might be, a pocket of tissues, of endometrial tissues might be hiding, for you to explore those areas as well. We don't do that here as a routine, but what I do is, in some very severe cases, I ask for HSG as a guide. And as you can see in this instance, you can see 2 filling defects. Now, this woman had had a previous hysteroscopy abroad, and the report was that it was normal, everything was okay. But we performed an ultrasound scan, a 2D scan, which, as we know, might not be the best method of diagnosing intrauterine adhesions. Of course, if you can do 3D and the rest, therefore 2D sensitivity is very, very low. So we did this, and we suspected, based on the thickness of the endometrial lining and a bit of hyperechoic tissues, we knew there was probably something there. And so we decided to explore. Now, if you, that's hydrosalpinx that she had in addition. Now, if you look at this, the first impression is that this is a normal, healthy womb lining. Meanwhile, it's not. These are all adhesion tissues. You know, there are fibrous tissues that have been lined with some endometrial tissues. Now, another giveaway that will tell you that this is not likely the endometrial cavity, I mean, the fundus with the tuber ostia, is the alignment of what appears like tuber ostia. They are not that close normally, and normally they are on both sides, left and right, not vertically placed, you know. So of course, with the confidence we had with the previous HSG she had done, it assisted us in pushing forward to separate the tissues until finally, again, we're now able to find the normal cavity hiding right behind them. Again, another case of amenorrhea. So you can see the fluid, the menstruum that had been trapped in there, you know, being expressed during the procedure. So we got in, luckily, you can see the cervical canal. Remember the crypts and the papillae, they will also lead you into the uterine cavity, especially when the adhesions are not that severe. So in this instance, we kept separating. Under hole. Now, this was a multiparous woman with a very deep uterine cavity. So we had to go right in on several occasions to be able to find the uterine fundus and conclude that we had reached our final destination. So again, we kept cutting. Again, you can see the benefit of scissors, because if you do this with any energy device, and by chance you cause a perforation, definitely you have to open up, or you have to go for laparoscopy immediately to check for damage to intestines or bladder and what have you. So it's not these days encouraged that you try to perform severe or moderate adesolysis using any energy device. Now, that particular case I just presented had a second look hysteroscopy done the following month. Studies have shown that the earlier you perform second look hysteroscopy, the better for the patient, because the adhesions will not have had enough time to fully organize themselves and become so thick and difficult to separate. So in this very case, you can see just a month after, we went in, and yes, you can see a few tissues here and there, but not so bad, and they were easily taken out before she underwent IVF treatment. Now, we don't just break down adhesions and send the woman home. We tend to want to keep something in the cavity to keep the walls apart so they can heal properly. Now, a lot of people still use the T-shaped IUDs for this purpose. As you can see, the space occupied by the T-shaped IUD might be too small to properly separate the walls. So we did this study and reported it during the 2022 AGL meeting. So just visual inspection alone, visual analysis, shows you that if you instill 1 mil, add another 1 mil, make it 2 mils, and then finally 3 mils, it will probably occupy more space and probably separate the walls much more than what the IUD might do. Of course, there's a Cook balloon as well, which is triangular shaped, but far more expensive, which can also fit into this. Unfortunately, there are no randomized controlled trials to tell us how effective all these things really are. Some even choose to use gel as a way of separating the walls. Now, this video was sent to me 2 weeks ago by a friend, and he told me he did his hysteroscopic adesolysis. There were so many adhesions, and at the end of the day, he felt he was successful, but he was worried why the woman still did not see her menses. Now, if you watch this video, whenever you talk about spider web, what looks like spider web, just consider you're in the mammalian. Whenever you see things like this, just consider you're in the mammalian. This is obviously the mammalian. So when you spend time dragging these things, you're actually pulling out muscle fibers. So ideally, that's what we talk about. You see, those are spiral vessels now being pulled out as well. Somebody else sent me a video a month ago or so, and also was asking what those things were when he was trying to dig into the posterior wall of the cavity. They were spiral vessels Once you see them, you're in the malmetron. So this case was in the malmetron, but luckily it did not go all out and perforate into the abdominal cavity. Now, this is a case where there was actually a perforation. The normal cavity is superiorly placed there, but you can see they went in posteriorly. Now, this is why it's never a good thing to try to dilate before you go in. Try to sound and pass a sound right inside the cavity, because you might create a false passage. And if you're not careful, you might pass through that false passage, think you're in the cavity, further expand it, even leave a catheter with a balloon there and keep it as a permanent opening. So the difference is, as you can see, while entering the normal cavity, the walls alone will tell you that you're probably approaching the right place. So you can see tubal ostium and all there. Now, this is the nightmare of every hysteroscopist, to be working with an energy device and then you perforate. That's a perforation. And at this point, first of all, you notice sudden decrease in fluid pressure. You see some amount of bleeding. You see that you're losing so much fluid. At this point in time, you stop and go straight for a laparoscopy to find out where the damage has been done. Of course, during laparoscopy, you probably will not see any cuts or something, but any area that appears white on the bowel, that's a harbinger for something disastrous to happen in future if you don't take care of it as at that time. So it's important as much as possible to do all you can to avoid such a scenario from playing out. So like I mentioned before, ultrasound scan, laparoscopy, and fluoroscopy all have a role to play in severe cases, but there's limited data that they actually prevent perforation or improve outcome. In fact, Zikopoulos in 2005 still reported a 5% perforation rate despite using some of these concomitant methods. So in conclusion, the endometrial cavity is a small space. It's safer to explore moderate and severe adhesions with scissors. In severe cases, ultrasound scan guided adhesolysis might be recommended, and extreme care and relevant expertise is key. That's one of the references. Yeah, and I thank you for your attention.
Thank you, Professor Okoye, for the wonderful presentation. Professor Okoye has taken us through intrauterine adhesiolysis and was really practical in demonstrating through videos and also demonstrating some complications. And he also mentioned that cold scissors is now the gold standard for intrauterine adhesiolysis as against electrocautery. And he described a lot of how to navigate entry into the uterine cavity and also exploring holes that are seen during surgery. And also there's a role for concomitant fluoroscopy, or more easily accessible to us here, concomitant HSG. He also said that early second look hysteroscopy is better than a delayed one, and the use of uterine catheter is better at separating the uterine walls as against the use of T-shaped intrauterine device. And he taught us how to identify perforations, the spider web features and spiral arteries and all that. We thank you, Professor Jude Okoye, for this wonderful presentation. I'll hand over to Dr. Aji for moderation of the next session. Thank you very much.
Thank you.
Good afternoon. Dr. Rajiv, can you moderate and introduce the next speaker? Okay, I will take over from here. It appears he's not here. I want to crave your indulgence to listen to one more presentation before the question and answer session. We have one more speaker. It has been a very long session, but permit me to introduce Professor Lukman Abdul Rahim, a consultant pediatric surgeon and professor of surgery at the University of Ilorin and University of Ilorin Teaching Hospital. Is he with us?
Good day
Yes.
to you all.
So you are welcome, sir.
Welcome to this 8th
Let me complete the
International
introduction.
Scientific Conference and Annual.
Let me complete your introduction, sir. I just wanted to confirm you are with us. He is the Dean of the Clinical Sciences and the Vice Chairman of Surgical Skills and Simulation Committee of the West African College of Surgeons. He has extensive training in minimal access surgery, and he is a Global Health Simulator Fellow at McGill University. Professor Lukman leads pediatric laparoscopic surgery at his hospital and serves as a site principal investigator for multiple global studies. Welcome you, sir, to present your topic, Pediatric Gynecologic Laparoscopic Surgeries, Indications and Challenges in Diagnosis and Management. You're welcome, sir. Professor Lukman, sir.
Day to you all. Welcome to this 8th International Scientific Conference and Annual General Meeting of the Association of Gynaecological Endoscopy Surgeons. I am to talk to you on pediatric gynecological laparoscopic surgeries, indications and challenges in diagnosis and management. I wish to acknowledge the organizers of this conference and the members of the executive of the association for honoring me with this special privilege to make this presentation. I am not a gynecologist, but I've had cause to manage gynecological cases in children, either alone or in conjunction with gynecologists. I thank you for this invitation to give this stimulating talk. I have no conflict of interest in the materials that I will be using, and I have sought permission where required. Once again, my name is Lukman Olajide Abdurrahman, a professor of surgery and consultant pediatric surgeon at the University of Ilorin and University of Ilorin Teaching Hospital, Nigeria, the current Dean of the Faculty of Clinical Sciences of the University of Ilorin, and the lead minimal access and laparoscopy surgeon at the University of Ilorin Teaching Hospital. I'm a clinical skills simulation educator and current coordinator for the West African College of Surgeons Basic Surgical Skills and Laparoscopy course for the Ilorin Center. I'll be talking today on the role of laparoscopy in pediatric and adolescent gynecological surgery. And I'll be evaluating the usefulness and the effectiveness of laparoscopy in diagnosis and treatment of gynecological pathologies in pediatric and adolescents. I have added adolescent because for some people, the pediatric age boundary is 15 years. But pathologies around the development of children often start most of the time from their maturity, which ranges from about, or attainment of puberty, which ranges between about the age of from 10 years in current days to 15, 17 years. And this makes many of them to be falling into the adolescent age group. By way of definition, pediatric and adolescent gynecology is a field of medicine that deals with the diagnosis and treatment of gynecological diseases from the neonatal period to sexual maturity. These interventions warrant minimizing the degree of invasiveness to reduce the number of complications and the risk of infertility in these children. Currently, laparoscopy is considered the gold standard in the management of many gynecological conditions in the adult. And in the last decade, it has become a tool for surgical interventions in children and adolescents. Laparoscopy has this advantage because it does not only assist in diagnosis, but it also provides therapeutic interventions. However, there are many impediments to achieving this goal of low or no complications or reduced risk of infertility in children, because there are variations in the age group at the presentation of the patients with different pathologies appearing or presenting in this age group. There are also anatomical and physiological peculiarities in children, which varies between these different age groups as the children are growing. And many of the times, the complexity of the pathology may also impede achievement of this goal in these children. Many of the time also, there is a difficulty in differentiating the type of tumors as may be presenting in these children. And as we know, especially for us pediatric surgeons, congenital developmental defects might be the presentation in these children, which might mimic the primary disease or a secondary effect of the presence of this congenital developmental defect in the children. By way of some certain consideration in the anatomical features of the children, we should be aware right from the neonatal period, and we always warn as pediatric surgeons that children are not small adults. They have their structural peculiarities that we need to be aware of. We are aware that they are small in size, and this might also present to us some challenges in meeting the diagnostic and therapeutic requirements in these children. The abdominal wall often has small volume, with the liver taking a huge size in the abdominal compartment, and many of the times the bladder and some part of the pelvic structures are still within the abdominal cavity. The abdominal wall thickness is small, is thin, is not as fatty as you have in the adults. So we need to be aware of this. The umbilical vessels might still be patent, and it is dangerous and sometimes is disastrous if one goes into patent umbilical vessels. The aortic iliac axis is also very close, and one needs to be aware in the introduction of our instruments for many of these care in the children. The processus vaginalis, as we know, is often very patent, and many of them also have associated umbilical anomalies. The physiologic effect in these children is also what we need to consider when we handle them. There are various transitional periods right from delivery, transition through neonatal period, the developmental stages in the early childhood, late childhood, adolescence, makes and presents various challenges, various physiological status and variation in the homeostasis of these children, which warrants special attention when we deal with them. We should be aware of the drugs they are able to metabolize. And in the instance that we introduce laparoscopy and use energy devices within them, the combustion product might make us risk the occurrence of methemoglobinuria or methemoglobinemia in the blood of the student. There is also the high tendency and chance of the shift of the oxyhemoglobin curve to the left, making release of oxygen in circulation to be restricted. The anesthetic agent that we use may often predispose them to having transfer of this gas readily into the circulation because of hyperviability, and we risk the occurrence of air embolism in these children. In positioning the patient for our procedure, especially pelvic surgery, we need the Trendelenburg position, and this might warrant increment in intra-abdominal pressure and intracranial pressures in this patient, which may cause some osmotic and pressure differentials in these patients, and we need to be mindful because it can be catastrophic depending on the age group of the children. By and large, the equipment that we use in laparoscopy in gynecological procedures in children are often similar to what is being used in the adult. The specific difference is that the size and configuration of these instruments vary depending on the age of the children. The availability of the 2.5 and 3 mm mini instruments revolutionized laparoscopic gynecological procedure in many of these children. However, the optical resolution for the miniaturized instruments might make laparoscopic surgical intervention in these children to be difficult, and perhaps not having appropriate length or the diameter of the instrument can also mitigate adequate intervention in many of these children as we may have them. In laparoscopy, as we do for the adults, we need secondary counseling most of the time in handling situation in the patients, because we are speaking to the parents or the guardian of this patient. So we need to provide adequate information to them. Most of the time, they are worried about the future fertility of their children. So we need to actually be able to convince them, perhaps also providing educational resources to assist them in complying or accepting whatever we are offering to them as either diagnostic or interventional procedure. Antibiotic prophylaxis might be necessary in some of these children, perhaps in neonatal period when they still have some immaturity of the immune system, or perhaps because of the comorbidity that some of them may be having at the time when we are managing them. Though deep vein thrombosis is of lower risk in the children age group, but we need to take adequate precaution in many of these children. We should sufficiently manage the pains of the children so that they are not scared of or distressed from our intervention. Another thing that is of concern is positioning our patient at surgery. The table might be awkwardly too small or inappropriate for the size of the children, and we may need to make proper provision so that we have adequate access to the surgical intervention in these children. As I mentioned earlier, and with what is peculiar to laparoscopic services in either adult or children, what's tough is this situation that we need to learn and relearn handling pediatric gynecological cases in many of the patients. I have mentioned the physiological use and anesthetic impact on the children. And also, we should have some level of tissue perception relatively in the age group of the children as they mature, because these are not consistent as we have in the adults, and we need to be mindful when we handle these children, these cases in the children. We need to also be aware that incidences of adnexal masses vary in children, or most other pelvic masses or lesions in children vary according to the age group of these children. But most of the time, especially in the adolescent age group, adnexal masses are known to have higher incidence compared to the general population, with most of them being benign and cystic. Only 1% of girls less than 15 years often have the ovarian malignancy, either as mature teratoma or immature teratomas. Uterine pathologies many of the times are accompanied by renal or spinal abnormalities in these children, which we need to also be aware of. It is also of note that many of the adolescents have higher incidence of endometriosis as compared to the general population. And when these children present, we should be aware that most of the time their symptoms are vague and ambiguous, and perhaps many of the times misleading. So we need to pay adequate attention and use the special skills gifted to pediatricians in making some of these diagnoses, knowing that common things occur commonly. Sometimes it might be referred pain or chronic cyclical pelvic pain that these patients will present with. Some may have bowel or bladder symptoms that we need to take note of, which this might have resulted from irritative or mass effect or even endocrine or paracrine effect of the tumor that is present in these children. So, bearing in mind this vague presentation of the patient, we need to be aware of the various differentials that may come either from the adnexal masses, from the uterine masses, from the urinary bladder, from the abdomen, the intestine, and even the other structures that are related in the pelvis. Some of them might be presenting as organ-specific pathologies or they are the result of the secondary effect. Some are congenital or acquired along the line. We should also be conversant with congenital genital defects, which might present with disorders of sexual differentiation in these patients. And as we know, the adolescent age group are in the transitional period, and we need to also be aware of the occurrence of juvenile pregnancy, ectopic pregnancy, and uterine tumor that we can see in some of these children. We should be able to make adequate differential diagnosis in them so that whether we are thinking of the use of laparoscopy for diagnostic purpose or for therapeutic purpose, we are mindful of the situation and we are aware of the possible differential that these patients might be presenting. Endocrine pathologies might feature in some gynecological presentations in these patients, and we need to be aware. When we consider pelvic masses and pelvic tumors, we should not forget that the kidney might be at risk, and we need to do adequate exclusion of these pathologies in the children. There are evidences to state the role of laparoscopy in the management of pediatric gynecological cases. And I would want to compare notes with other available diagnostic facilities in many of these children. We are aware of the use and the precision of the imaging methods, be it ultrasound, CT scan, or magnetic resonance imaging, and several panels of tumor markers that are useful in the diagnosis of pelvic tumors in children and adults. Many of them, most of the time, are reliable for endometriosis, as we have in the CA125, CA19.1, ICAM1, and then IL-6, interleukin-6, together with other markers that we use. Not many of these are readily available in our environment. Most are expensive, and many will witness delay in getting results from the use of this facility. Laparoscopy provides the only way to confirm diagnosis by inspecting the abdomen, organs, and taking biopsy to assist us at quick diagnosis. In the instance of imaging, for instance, the ultrasonography, whereas we might be seeing images that at times might be confusing. Even when we introduce contrast in urogenital sinogram, especially when we consider the disorder of sexual differentiation, we might not completely be convinced of the pathology that we deal with. So laparoscopy could assist us in confirming this evidence because the use of ultrasound in ovarian masses is more preferred, as we know, and it's the sensitivity and specificity are not completely um, magnetic resonance imaging can also improve our diagnostic findings by also making easy our decision in either conservative treatment, which laparoscopy could assist us to achieve in many of these patients. Laparoscopy could be very useful in the disorder of sexual differentiation by clearing doubt of the imaging technique, reduces trauma of many laparotomy, and can afford us single or multiple intervention in many of these patients. But as you can see here, the external genitalia of the patient is looking very ambiguous, and internally you can see within the patient the intra-abdominal gonad, which most likely looks like an ovary. And from another angle of view, you can see in this patient an minute thrush. Perhaps the patient has an ovotestis, which could be readily biopsy, and histology could confirm this, and a completion surgery could be done in the patient at some other times. Gland ovarian tumor could also be addressed through the compression of the tumor and either by transdermal cyst drainage under ultrasound control, aspiration of the cyst content under laparoscopic control, or cyst decompression by mini laparotomy. But we know preferably it would be better done aspiration under laparoscopy and perhaps eventual complete excision. There could be laparoscopic assisted resection of the tumor, which could be delivered through financing incision or extension of the ports. In summary, laparoscopy play a great role either for direct diagnostic aid, or we could use it in augmentation of available biochemical and imaging tools, which will assist us in conserving the therapeutic approach in the patient. It could be very useful in very sick patients who we may want to stage tumor in them. And many of the times, laparoscopy could be used multiple times in aiding diagnosis and even the eventual treatment of the patient with little trauma. I must say, by conclusion, laparoscopic diagnosis and treatment of administered pathology is safe in children and adolescents due to the low percentage of perioperative complications. It has a high sensitivity in the diagnosis of pathology of the ovary and the fallopian tubes and other abdominal and pelvic defects or diseases. It is important for pediatric surgeons to collaborate as a team with adolescent gynecologists, pediatric urologists, and endocrinologists for the diagnosis and management of complex gynecologic problems from infancy to late adolescence. Thank you.
Thank you, sir, for your erudite presentation on pediatric gynecological laparoscopic surgeries, indications and challenges in diagnosis and management. Well, this session has been a little bit prolonged, and we have had 5 presentations from Professor Jamal Fikri, who presented on treatment of isthmosil, hysteroscopic and laparoscopic approaches, followed by Dr. Adel Serati, who gave us a presentation on cesarean scar pregnancy, the challenge and the triumph. Dr. Kingsley Aholo presented the use of ultrasound for evaluation of gynecological conditions before minimal access surgery. What is new? Professor Okowe Jude also gave a presentation on intrauterine adhesions, the art of safely navigating the uterine cavity. And finally, we had the presentation of Professor Lukman Abdurrahman on pediatric gynecological laparoscopic surgeries, indications and challenges in diagnosis and management. And now is the time for question and answer. And we have a very short time to do so. So we would like those who have questions to indicate by raising their hands. I hope the presenters are available to answer questions. We will take just 10 minutes, except the organizers permit time more than that. So do we have any questions? I'm yet to get someone indicating to speak, or comments. If you don't have questions, we can take comments. All right. I have Dr.
Someone's.
Yes, Dr. Abdul Sedrati. He has his hand up. I think he wants to make a comment or a question. Please, go on.
Yeah. Thank you very much for all those presentations and for the presenters, and also for you for moderating these sessions. So I have like reflection, and I hope that Dr. Okuhu is here, because I know that both of us, we are at the, we met in many places, and also Professor Fikri. So I'm going to talk about synechia, adhesions, and intrauterine adhesions. So, and everybody knows that we have 7 classifications, and people don't use the same language. So for that, when we perform research, we don't have the same results. So it's not a scientific like conclusions. It's a lot of heterogeneity. And I would like to talk to all those who are having like a high place in different societies, to use all our knowledge and all our like power to have one universal classification, using ultrasound, using hysteroscopy, using everything, just to talk the same language and to have like the same and homogeneous results, and to go on to treat or not to treat different kinds of these pathologies. And thank you.
Thank you, sir. Comment noted. Another hand by Haruna Idris. Please, you want to ask a question?
Yes, sir. Before, Mr. Moderator, sir.
Go on.
Yes, sir. Before Haruna Idris will come in, sorry, I need to tender this apology. Dr. Adel Sedrati, Professor Okowe just stepped out. He has another presentation somewhere, so he has to quickly. He had to quickly move there for that presentation. I quite agree with you. There are a lot of classifications concerning intrauterine adhesions and match classification, so many of them. And it is good that we should look towards increasing research so that we can look at a meeting point of all of these classifications to produce a universal classification to allow us to compare results across the divide. So that would be wonderful if we can have something like that. Thank you very much for that reflection. Thank you.
Thank you, sir. Well, meanwhile, we have Dr. Haruna Idris waiting to make his comment or give a question. I don't know. Go on, sir.
Thank you very much. I want to thank the presenters for their very lucid presentation. My question is directed to Dr. Adel Sarati, who talked about the cesarean section pregnancy, the challenges and triumphs. He talked about the conservative management of this cesarean scar pregnancy. Are there indications for conservative management? Because the way he spoke about the conservative management is a risky one. So are there indications for it? That is my question to Dr. Sarati. Thank you.
So thank you very much. I guess that I had the problem. I didn't hear pretty well the question. Could you please repeat it?
His question is, what are the indications for conservative management of cesarean scar pregnancy?
This is like a perfect question. We discussed this question with the Netherlands team, which are the most advanced team in, let's say, in this kind of pathologies. And they agreed that there is one unique condition where maybe we try to accept the pregnancy to go on, which is type 1 cesarean scar pregnancy, ISWO classification. This is most type 1. And 2, the patient has to agree that she will have complication at the end of the pregnancy. And we have seen that she will have up to 15% to have a program. I am trying to say that scheduled cesarean section, because from one case up to 2, she will have a hysterectomy because of placenta accreta spectrum, which we need in Netherlands. It's not the situation as in Africa. In Netherlands, they know that this is a cesarean scar type 1. We have placenta accreta. We try to prepare the operating room. We have the different team to treat the patient. But for us, we don't know the diagnosis. The patient will be at 4 o'clock a.m. The team there, they are not trained to manage such problem. And here we will have problems. So we need to state that there are conditions to accept some cesarean scar pregnancies and with a higher rate of morbidity for the patient. Thank you.
Thank you for your answer. Any other hands up? We are over 69 listening to this session, and I can't see any hands trying to ask a question or make any comments. So I wish on behalf of my fellow moderators to ask that we terminate this session and bring the session to a close. Thank you everyone for participating, and see you at the next session. Thank you. Bye.
Somebody is raising his hand up. Michael Agbaji.
Okay.
Michael
Sorry,
Agbaji, you can unmute yourself. Michael Agbaji.
It was
Michael
an applause,
Agbaji.
not hand raise, sir. I was
Oh,
applauding
okay,
the
all right.
conversation.
It's okay.
Yeah.
It's okay. It's all right.
Thank you very much.
So, good afternoon, everyone.
Good afternoon.
Good afternoon, Professor Barago.
So, we want to thank the moderator and the presenters. We are moving to like a commercial break now. So, we want to invite our corporate sponsors to take the floor now and give us in 5 minutes each, give us what they have prepared for us regarding this conference. So first of all, I want to call Equipment Solutions Limited to take the floor. I hope they are around. Biomedic Equipment Solutions Limited, please. I hand over the mic to you. The floor is to you. You can start your presentation.
Okay, good afternoon, everybody. Good afternoon. My name is, can you hear me, please?
Good afternoon.
Yeah,
we
can hear you loud and clear.
Okay, okay. Okay, my name is Mr. Emeka Victor. Just a moment, let me just share my screen, please. Okay. Okay, my name is Mr. Emeka Victor Kechuku. I represent Biomedic and Equipment Solutions Limited. I'm still trying to share my screen, sorry. To discuss at this point, because obviously this is just happening at this point, it's very recent and there's no understanding of what exactly has happened at this point. So they're trying to make sure that they're okay. So we are indigenous company. We are a professional biomedical engineering company. We have offices in Port Harcourt and in Lagos as well. So we have various ranges of equipment, but our interest today is on endoscopy. So like I said before, we are a professional biomedical engineering company. We are committed to bringing global technology and cutting-edge innovation to the world of medicine in Nigeria and Africa at large. We offer full range of endoscopy equipment, from the full stack, where you have the monitors, where you have the cameras, the light source, where you have the irrigation pump, insufflator, the various range of endoscopy equipment, including your musculator, receptoscope, also some of the disposables like your 5 French scissors and grasper, which is always available. So over the years, we have developed our products to be very, very stable and very, very reliable when it comes to this endoscopy equipment. We've had several good feedbacks, and as it stands today, we have a very good market shares market shares when comparing with other bigger competitors. So I'll quickly run down on most of these equipments because of time. Recently, last year, we launched our 4K endoscopy camera, 4K endoscopy camera with resolution of about 3,849 megapixel. If you're into laparoscopy, I think it will be okay if you can leverage on 4K cameras, because 4K cameras offers you a wider view of it offers you a very wide view, and also the resolution ensures that you appreciate everything under the camera. So we have the 4K camera, and this camera also have a light source and a recorder as well. So you don't have need for external recording device. That's for our 4K camera. We also have our full HD camera. Full HD camera is also very, very good, and resolution is also okay. Resolution is about 1,800 megapixel, very, very okay. And also has a recording device, so you don't need an external equipment. You don't need an external equipment to record your procedures. You can as well take pictures while your procedures are going on. You can take pictures with these cameras, because there's a button on the camera head where you can easily save your videos and take pictures while your procedure is going on. Okay, we also have this portable all-in-one endoscopy. We call it View Mini. If you have a small budget and you don't want to go for a full stack endoscopy equipment, you go for this, because the resolution is also very good. It's all in one, so it has the light source, it has the camera, it has a recorder system, and 17 inches monitor. The only disadvantage here is the small screen. It has a small screen, that is 17 inches monitor. But it also have some external ports like VGA ports, HDMI ports, that you can connect to bigger screen in case you're doing laparoscopy, because you would need a bigger screen if you're doing a laparoscopy with this. This is our View Mini. It's a portable one. It has a suitcase. It can always be carried. It can always be carried along. If you have, you can also be used in the consulting room, and it can also be carried along if you have to do some cases outside your facility and whatsoever. So it's very portable. It has a suitcase. You can always carry it along, and it offers you everything the big one also offers you. So it's a very good one, and is very high in demand. So we also have our all-in-one endogenous. This is like a screen. It's like a screen, a big monitor, about 27 inches monitor. But in the screen, it has light source in it. It has CO2 insufflator in it. It has a recorder in it. So it's all in one screen. It's very big and very, very compact as well. So in this endogenous, we have it in full HD, and we also have it in 4K. In 4K.
Hello, Mr. Emeka. Please begin to round up.
Yes, I can hear you, sir.
Begin to round up.
Okay.
We are way behind schedule.
Okay, so other equipment and musculator. We have a very good musculator system that cuts and sunshine as well. We have bipolar plasma receptoscope. We have other components that is compatible with other brand. Maybe you have a full stack as well, and maybe some of the components like irrigation pump, insufflator, you need to change. You can call us, because all of our equipment are almost compatible with other equipment. So we have, most importantly, these are 5 French scissors. We have a very good and rugged 5 French scissors, and very, very competitive and affordable. And for the purpose of this conference, we are offering it at 20% discount, because we want everybody to try it and see how rugged it is. Some people who bought this particular scissors at last conference in Port Harcourt, most of them we've had a very good feedback, and most of them are still using those sets they bought. So we are having a 20% discount for our 5 French scissors and grasper, and it's available for pickup at the conference in Abuja here. So if you have chance, please, we want you to also pay us a visit if you have chance and you're visiting the AFRH conference. Please do well to visit our booths and have a look at most of these equipment, because they will be displayed. So I want to thank the organizers for this opportunity to sell our brand to the Aegis member. On the screen, you can see the phone number there. The first phone number is my personal number. You can send me WhatsApp message or call me for any inquiry. I'm always there 24/7 to reply. And finally, before I end, I also want to assure you that our equipment is we offer 2 years warranty on our equipment, and our after sales services are top notch. So please, we would want to hear from you. Kindly get the number from the screen and call me, and I will be there to answer all your inquiries. Thank you very much.
So thank you very much, Mr. Emeka. We want to invite Life International Endoscopy Center, ORCA, to take the floor and make their own presentation. I hope the representative from Life is here.
Yes, good afternoon, everyone. Hello, am I audible, please?
Good afternoon, you're audible.
Okay, thank you very much.
All right, good afternoon, everyone. My name is Wilson Chukwudi. Okay, and I'm here to represent Always Life Global Campus, the training arm of Life International Hospital. So I'm going to share my screen as I play a video. Okay, just give me one moment.
So please be informed that we have just 5 minutes, and
yes, sir. Is my screen visible? Is my screen visible, sir?
Yes.
Hello, am I audible? All right. Okay.
yes, it's visible. We can see it. Yes. Yes, you are audible.
Medical and health education is electronic learning. It is effective, efficient, affordable, and it is a global reality. At Always Life Institute Global Campus, we use the power of e-learning to provide high-quality professional trainings and development for medical healthcare professionals in Africa and beyond. Our dedicated and experienced facilitators deliver effective trainings with rich multimedia contents on a global scale. Trainees can learn from any location in the world and at their own pace. We are the remote training arm of Always Life Group, which owns and operates first-class multi-specialist hospitals in Africa. For over 10 years, Always Life has trained over 300 doctors in minimal access surgery. We provide certificate courses in endoscopy, fertility, health and wellness, healthcare management, etc. For practical sessions, trainees can join our team of experts in our state-of-the-art hospitals and operating rooms, including a negative pressure modular OR. Our goals are excellence, impact, and resilience. Learn more about us. Visit our website today at alwayslife-globalcampus.com.
All right, thank you very much. I believe you're able to understand the video introducing our global campus. So in summary, we are the training arm of Life International Hospital. So using e-learning, we run trainings in endoscopy, healthcare management, and so many other courses. So we have a wide range of facilitators that are renowned all across the country. Basically, I think some of the leaders of ages are also one of our is part of our facilitators, like people like Dr. Adewale, Prof. Ike Chebolo, Dr. Akintobi, and the rest of them. They are part of the facilitators for our training. So in order not to waste our time, I'm going to drop a link on the comment section where you can click, and also drop a number where you can call to know more. Then basically we have a training that is currently going to happen in this September, mass training, minimal access surgery, the basic course. It will start on the 25th of September through the 28th. So as many of us that are interested, I'll drop the flyer on the comment section, and then the link as well as the numbers to call. Thank you very much, everyone. I wouldn't want to waste our time. Thank you, and God bless you.
Thank you very much, Mr. Wilson. Professor Imaralu is the one we're waiting for at this point. While we're waiting for Professor Imaralu, do we have any other person for presentation?
Thank you very much. We do not have
that's
I will move to the next one now. Hand over to Mr. Ola. Good afternoon, ladies and gentlemen.
Afternoon, sir.
We are now entering the second to the last aspect of the program for today, and that is the oral presentations. I am the chair of this session, and ably supported by Professor John Imaralu, who has stepped in for Mr. Johnson Amu, who is unavoidably not able to participate this afternoon. I am told that we have 9 presenters. It looks as if some of them are junior doctors, trainees, and some are listed as consultants who are presenting. We are very grateful that we have such a high caliber of presenters. However, for obvious reasons, it would not be fair to award the best prize or runners-up prize in a competition where there are senior consultants, some of them editors of very eminent journals, where there are also trainees presenting. And it is the tradition of ages and many organizations that these prizes are supposed to encourage our trainees to attend conferences. And by deciding not to award prizes to consultants, it is an incentive that next time you consultants should encourage your trainees to come and present, not keep them back in the hospital and come and present to us. We are very grateful that you have motivated them, but let them come and present to us. So I would advise that each presenter should clearly introduce himself or herself and the role he has played in the paper, that is, whether or not they are registrars or consultants. There will be a prize of 100,000 naira for the best presentation with a certificate. And there will be 2 runners-up, the second prize of 50,000 and a third of 25,000. Each presenter, each winning presenter will have a certificate from AGT. But I want to make it clear that no consultants will be awarded a prize. The only Can we please switch off? Can we please switch off any distraction? So it is my pleasure to invite the first speaker. I'm going to tell you in a minute. Get my phone working. I think the first presenter, the first oral presentation is post-menopausal bleeding, a new triage pathway to improve service delivery. I want to say that you have 6 minutes. 6. I have a timekeeper that would cut in at 5 minutes to tell you that you have 1 more minute. After that, you have to round up because we have many others who are going to present. And let me say that it is better to allow time for questions and answers because they will also go through the part of the scoring. Take all your time and don't allow us to ask you questions. You may be doing yourself sophisticated. So the first presenter, we're going to be talking about post-menopausal bleeding, a new triage pathway to improve service delivery. Thank you. Dr. Olufemi Badmus. Okay, all right. We have to come back to you. It's Dr. K. Tubarayuju here.
Hello, I'm here.
Okay.
May I present?
Yeah, the second presenter is going to talk to us about the subject of are we doing too many hysteroscopies for PMB? You are welcome to take the podium. Thank you.
Hello.
Hello, we can hear you.
Hi.
Go ahead.
Is my presentation visible, please?
Yes.
We can see the screen.
Right. Hi. Good afternoon, everyone. My name is.
We cannot see your presentation. We cannot see your presentation.
Right. I'm just sharing my presentation. Just a second, please. Is it visible now?
Yes, we can see the, yes, that's it.
Right. Hi. Good afternoon, everyone. I am Kavya Subbaraidu. I'm one of the SP3 registrars working at the Blackpool Victoria Hospital. Apologies for not using the template as I'm on vacation and I have the access. I would also like to say many thanks for accepting my abstract. Today, I will be discussing a crucial topic. Are we doing too many endoscopies for postmenopausal bleeding? This study, my supervisors were Ms. Randa Omer and Mr. Johnson Ammu. And the main aim of this study was to focus on postmenopausal women experiencing bleeding who were on hormone replacement therapy. With increasing number of women opting to use HRT to manage menopausal symptoms, we are observing a corresponding rise in the number of women experiencing unscheduled bleeding. The British Menopause Society highlights this as a significant concern. While all irregular bleeding is distressing, it's important to evaluate and strategize the investigation so that we can prioritize those who are at increased risk of developing endometrial cancer. This retrospective study took place between 1st March and 30th April. During this period, 185 women presented with postmenopausal bleeding to the gynecology OPD. Majority of them were aged between 51 to 55 years, closely followed by the age group of 56 to 60 years. This is a graphical representation of the same. And of these 185 women who presented to our postmenopausal bleed clinic, 65 of them, or 35.1% of them, were on hormone replacement therapy. And most of them were again aged between 51 to 55 years. We analyzed the duration and type of HRT used, and while it is common to experience bleeding within the first 6 months of use of HRT, 62 of these women were using HRT for more than 6 months. Among these women, 54% of these women were using continuous combined HRT, and 9 of these women were using a sequential type of HRT. Following the RCOG and TRUST guidelines, all the women who present with postmenopausal bleeding should undergo an ultrasonography to determine the endometrial thickness. So these women underwent an ultrasound to determine the endometrial thickness. We found that 64.1% of these women had an endometrial thickness of more than 4 millimeters, while 23 of these women had an endometrial thickness of less than 4 millimeters. According to the current management pathway, all the women with endometrial thickness of more than 4 millimeters should undergo further diagnostic evaluations such as hysteroscopy and biopsy. This does not take into consideration women who are on HRT. In our study, 33 women underwent outpatient hysteroscopy and endometrial biopsy. This is done using an alpha scope and an endometrial sampler or a pipette biopsy. 6 women had an inpatient hysteroscopy under general anesthesia due to various reasons like finding the procedure too painful or they were very anxious. In 2 women who underwent the inpatient hysteroscopy, the process could not be completed because the dilation was not possible due to a stenosed os. Post the hysteroscopy and endometrial biopsy, the histological analysis showed that most of the women had a benign endometrium, and none of the women were diagnosed with endometrial cancer. This study underscores the importance of adopting the new guidelines proposed by the British Menopause Society to increase the endometrial thickness while evaluating a woman with postmenopausal bleeding who's also taking HRT. It would optimize our use of resources. It would also bring out the best possible outcome for the patient and reduce the financial drain on the system as well. So that was the conclusion of our study. Thank you. Any questions?
Yeah. Thank you very much for a very brief, succinct presentation. Are there any questions? She has 1 to 2 minutes to answer questions, please. Any questions? Okay. Thank you so much. I cannot see any hands raised.
Sorry?
No, I'm just looking. I cannot see any hands up. So We do not have any questions for you. Thank you so much.
Thank you. Thank you for allowing me to participate.
Thank you.
Have a nice day.
Thank you. The next speaker is going to talk about hysteroscopic retrieval of intrauterine retained fetal bones causing infertility in a tertiary teaching hospital, a case series. And that I've got the name of Dr. Adebayo Adewole, who is presenting on his behalf, or is he going to do the presentation himself?
No, it's presenting. So the presenter should introduce himself, give us his name.
Can the presenter please introduce himself or herself, please? Dr. Adewole, are you here?
Yes, I'm here, sir.
Who is
Well,
presenting?
my resident will do that. They will introduce themselves. They will go ahead now.
Okay. All right.
Yeah.
Okay. Can you please introduce yourself? While you are getting your slide up, you can talk.
Yeah. Good afternoon, sirs. I want to observe the existing protocol. I'll be My name is Dr. Onyoluwatobi Stephen, a senior registrar at Federal Teaching Hospital, Lokoja. I'll be presenting a stereoscopic retrieval of intrauterine retained fetal bones causing infertility in a tertiary teaching hospital. It is a case series.
Can you enlarge your presentation?
I will use it similarly. Dr. Onyoluwatobi Stephen, a senior registrar in the Department of Federal Teaching Hospital, Lokoja.
Yeah.
And I'll be presenting hysteroscopic removal of fetal retained, hysteroscopic retrieval of intrauterine retained fetal bones causing infertility in a tertiary teaching hospital. It's a case series. I'm going to be using this outline for my presentation. And by way of introduction, retained fetal bone is a rare complication of unsafe abortion, causing infertility by acting as similarly as an intrauterine device. Unsafe abortion causes about 12% of maternal mortality in Nigeria, as we know, and clinical and radiological evaluation may be inconclusive, but hysteroscopic evaluation is the gold standard for diagnostic and therapeutic procedures associated with fertility restoration. 6 cases of retained fetal bones were found out of 300 hysteroscopies that was done in our center over the period of 7 years from September 2015 to 21st of September 2022, which were analyzed and discussed. And the results showed that there's an incidence of 2.2%, and the age range was between 26 and 44 years. 5 out of these 6 were nulliparous women, and all the women had previous history of unsafe abortion. The gestational age at the previous abortion ranged from 12 to 24 weeks. And it's actually surprising and well noted that the fetal bones were completely removed in all cases. And 2 out of these 6 cases, which accounts for about 3.3%, had favorable outcomes with spontaneous conception and live births, respectively. There's going to be a breakdown of the cases that have been managed and the clinical evaluation of those cases. For the clinical presentation of those cases, case number 1 is actually a 26-year-old woman, and the age range that I've said earlier is between 26 and age 44. And the apparatus, as what is stated on the slide, one of them is para 1 + 4. And the previous pregnancy that was desired before the evacuation was done, then the gestational age at the previous uterine evacuation, it ranged between 12 to 24 weeks. And the marital status when the uterine evacuation was done that shows that half of them were married and the other ones, the other half were actually single. And the positive history of unsafe abortion was found out in all the 6 cases that were managed. Then the interval between the uterine evacuation and presentation ranged between 4 to 15 years before they presented to us. And the duration of fertility in these 6 cases that were managed spanned between 2 to 12 years. The previous history of uterine evacuation was present in all of them, which was common to all the patients that presented for that. Then the history of pelvic pain after the uterine evacuation was present in all the patients. Then history of abnormal vaginal discharge was also present in all of those patients. Then now I move to the clinical and reproductive outcomes.
Dr. Oni, you have 1 minute
the complete
left.
hysteroscopic was found. Okay, sir. Was found in all the patients, and the fetal bones were completely removed. And the number of fetal bones ranged from 1 to about 12 in numbers. And then the fetal bone parts were that of the jawbone, the skull bones, and the flat skull bones. We also found out lip bones they were removed. And for the pregnancy outcome, which was seen in the earlier presentation, 2 of them achieved spontaneous conception, while about 3 of them were referred for in vitro fertilization, and 1 is still presently on follow-up. This slide is showing the fetal bones that were actually removed and their sizes. And then this was when the procedure was done, how the fetal bones were located and how it was also removed. And the subject for discussion is that the true incidence of retained fetal bone is unknown, but the incidence in this study is 2.0, which is higher than the 0.5 Marquis et al., similar to 2.6 to 2.8 by the Okoye and the Awowole et al. That was found. The bony fragment acts like IUCD to cause infertility. The interval between the abortion process and presentation ranges between 9 years. Most cases are due to long-term complication of unsafe abortion. Endometrial osseous metaplasia have also been reported. So hysteroscopy is not considered as a routine investigative procedure for infertility. The inconsistency of clinical and radiological diagnosis could be a reason to suggest routine hysteroscopic evaluation for all women with infertility and previous history of abortion beyond 10 weeks of gestation. That's when the fetal bone would have been formed by the fetus. In this series, spontaneous pregnancy was and live death were occurred in 2 out of 6, which accounts for about 33.3%, and 1 of them is still on follow-up. In conclusion, returned fetal bone is a rare cause of infertility associated with diagnostic dilemmas to the gynecologist, especially in those settings like ours. Removal of this fetal bone by hysteroscopy can actually return fertility to our patients. These are my references, and thank you so much for your time, sir.
Thank you so much. We'll now entertain questions. Do we have any questions? Any questions for the presenter? Can we have a show of hands, please, if there are any? Okay, I cannot see any show of hands. Thank you so much, Dr. Oluwatobi. We will now move on to the first presenter, who is going to be talking on the subject listed, which is factors associated with occurrence of intrauterine adhesion among women undergoing hysteroscopy in Lagos State, Nigeria. I have listed here Dr. Lateef Akinola as the lead. I would like the person who is presenting, hopefully one of his trainees, to please identify himself or herself by introduction. Is a professional here, doctor, nurse, whoever is presenting, please, can you identify yourself?
I have to move to the next.
Lateef Akinola, are you here? Okay.
We can move on to the next one, sir.
Yeah, we can move on, surely. The next on my list is also by Wole's group. We have a diagnosis and management of female genital tuberculosis among women with infertility in a tertiary teaching hospital in northern Nigeria, and actually not central Nigeria. A case series, it's another case series from the group led by Dr. Adewale. Can the presenter please identify himself or herself by introduction, brief introduction? Thank you. Adewale, can you please let us know whether the person is here or not?
Yes, the person is here, sir.
Yeah. Can the person unmute himself or herself?
So, Obadino Oluwole, Senior Registrar, Federal Teaching Hospital, Lokoja.
Sorry, I didn't get that name.
Obadino Oluwole, sir.
Oluwole. Thank you.
I'm trying to share my slides.
Good. Are you registrar or consultant?
I'm a senior registrar, sir. Senior registrar of obstetrics and gynecology. I'll be presenting diagnosis and management of female genital tuberculosis among women managed for infertility in Federal Teaching Hospital, Lokoja, North Central Nigeria. It's a case series. I'll be following the this outline, sir. Female genital tuberculosis contributes significantly to female infertility, particularly those with unknown cause, contributing about 10%. The incidence varies worldwide. In developed countries like United States, the incidence is about less than 1%, while the highest incidence is in, among the Asian countries, where the incidence is about 20%. The prevalence varies in northern Nigeria, while the in northern Nigeria is about 16.7%. Considering the fact that this is one of the rare causes of infertility and is one of the least suspicious causes of infertility in our environment, we proceed ahead to study we had about 4 cases over the duration of about 9 years, from September 2015 to about September 2016 significantly. About 316 infertility cases were studied, and we were able to pick about 4 cases of genital tuberculosis among women who had minimal access surgery. From our studies, the incidence of female genital tuberculosis was about 1.1%, and the average age range being 32 to 66 years, while the average age is 34. Most of these women are nulliparous women. Some had previous termination of pregnancy, and some had not even had any pregnancy at all. In our study, we noticed about 50% of these women had about hysteroscopy, while the other 50% had both combination of hysteroscopic and laparoscopic evaluations with features suggestive of female genital tuberculosis. Our significant findings include widespread adhesions in the uterus, the pelvic adhesions, and also the pelvic walls. The pelvic walls and also the adnesias and the tubes and the ovary were all had in additions. There were also present of microbial tubercles within the endometrial cavity during hysteroscopy, and some of these women has vowel string, fibrinous string noticed during the laparoscopy. There were also additions involving the pelvis and also the omentum, with us having about casosapines also were also noticed. Mycobacterium culture were done because diagnosis genital tuberculosis inquire using of various means of diagnosis, which include culture, doing gene experts, and also doing serum quantiferous tests, or also measures used in diagnosing these patients, including the histopathology confirmations of Langerhans cells from biopsies that were taken from both pelvic adhesion and also taken from biopsy taken from intrauterine from the endometrial biopsies. And we noticed that in all our patients, the microbial culture specimen were positive, and gene expert tests taken from samples were also positive, and quantiferous tests were also positive for this patient. And we went ahead to confirm during the histopathological confirmation, and we know that presence of Langerhans cells within the tissues biopsy. After making the diagnosis, we proceed ahead to treat them with anti-TB medication as recommended by the WHO for a duration of 9 months. We noticed after the treatment that while resolution of symptoms, particularly among women who had no issue with menses, that is, those who had no amenorrhea, some of them had their menses had scanty menses, some had amenorrhea, and we noticed that the outcome were better among those who had scanty menses prior to the treatment compared to those who had amenorrhea. And we noticed that despite the resolution of symptoms, the fertility outcome was generally poor. So we went ahead in managing some of this fertility outcome. We went ahead, about 2 of our patients were recommended for surrogacy, and even some have in vitro fertilization with poor outcome, and we later also send them for gestational surrogacy. Now, this is a table showing our results. We had about 4 cases, and we noticed that 2 of our patients had secondary amenorrhea, 2 have primary amenorrhea. And we noticed that our findings, we tried ruling out other causes of infertility, as I said earlier, and we noticed that they were all negatives. And we went ahead with clinicals. After we went for a laparoscopy, we saw features suggestive of endometrial tuberculosis.
Dr. Badeno, you have just 1 minute left. Begin to round up.
These are findings, some of the findings. The last image D, represent features of mild cervical and intrauterine irregularity and tuber blockage, even after having our procedures. Now, these are images, representations of exudate within the cervical canal, tubercles and caseous nodules noticed in the endometrial cavity. And all this, in addition, shows that genital tuberculosis is a chronic disease. Early diagnosis is suspicion during infertility evaluation is of paramount in the managing of patients, especially those with unexplained infertility. Now, in conclusion, sir, evaluation of women for infertility using minimal access surgery has enhanced added enhanced diagnosis and also improvement in terms of management of care with patients with genital tuberculosis. Often have at the back of their mind that most of them are asymptomatic, being it a chronic disease. So minimal access surgery, laparoscopy, or hysteroscopy is of clinical significance in managing this patient. Timely diagnosis is also very important, especially in preventing damage to tubes, which is the common site of damage for patients who have female genital tract tuberculosis in order for them to have a better outcome. Thank you, sir.
Thank you. Thank you very much.
Thank you so much. We will now entertain questions for Dr. Oluwole. Can I see a show of hands for any questions? Any show of hands? Okay, we're going to be moving to the next presenter now. And the next presenter, thank you so much. The next presenter.
Sir, there's a hand. A hand is up, sir.
Oh, okay. Yes. Samuel Ezekwele. Thank you.
Thank you, sir. I want to ask the presenter, based on his studies, will he recommend routine TB tests for every woman with secondary amenorrhea and infertility?
Thank you, sir, for the question, sir. From the outcome from our study, we noticed that female genital tuberculosis contributes significantly, especially among those patients who have unexplained infertility. I would recommend that high index of clinical suspicion whose other factors contributing to fertility has been excluded. One can go ahead and evaluate them for genital tuberculosis. In addition to findings at hysteroscopy or laparoscopy findings in some of these patients. I will recommend that, sir.
Okay. Thank you for your comment. Thank you very much. Any other hands, please? All right. So we have to move on. I'm just trying to get my phone. Is Dr. Akinola's presentation ready? No. Okay. We're going to go to the 6th presentation by Samira Raja.
Yes,
Azar.
I'm here. Can you hear me?
Okay, thank you. You are going to be talking to us about the application of change model principles in implementing minimal access surgery in a district hospital.
Yes.
Dr. Azar, thank you so much for taking the floor. Share your slides. Please introduce yourself and your position.
Are you able to see my slide? No?
Not yet. Not yet.
Okay, 1 second. No?
Yeah.
Yes?
Yes, we can see now. Are you a consultant or registrar?
No, I am ST7, so I've got 1 more year left. So my name is Dr. Azar. I'm one of the Ops and Gynae registrar working in Blackpool Hospital, and I work with Mr. Amu Johnson. He's one of the consultants here. So our this is just a small quality. Sorry, I'm just trying to log in the camera. Yeah. So this was just a small quality improvement project we did in our unit. So it was basically to see implementing change from the abdominal hysterectomy going to the laparoscopic hysterectomy. So the initial one is the implementing change model principle and gynae principle. So it's a bit of introduction. Sorry, just 1 second. So the change management in healthcare is the approach or process you undertake to ensure smooth transition through the implementing of the new technology, changes in workflow, and adoption of the new healthcare protocol. And if these are not managed properly, they can cause confusion, error, or decrease staff morale, and also it can affect the patient care. So therefore, the change model, the aim was to identify barriers and needed changes in implementation and outcome effort. We used the PDSA cycle, which is basically plan, do, study, and act. In our quality improvement project, it was a retrospective analysis of all the hysterectomies performed over 5-year period from 2015 to 2020. We collected data from the hospital system, and also we analyzed the route of the surgery performed, whether it was laparoscopic, vaginal, or abdominal hysterectomies, and whether it was performed for benign or malignant cases. Then the plan in 2015, we introduced the laparoscopic hysterectomies for benign condition. We recognized the NICE guideline, local CCG agreement. We collected data from the hospital system, and then it was analyzed. What we did is in the department, we did is educate people, train the doctors. We introduced the mentoring and body system, careful selection of the cases, and any incident, it was reported to see the outcome. Over the 5-year trend report, the study was, we collected the data and analyzed it, and results were, during the 5-year observation period, there were consistent decrease in overall number of the abdominal hysterectomies. There were 4-fold increase in the laparoscopic hysterectomies for benign conditions, especially, which raised from 10% to 46%. In 2015, only 2 out of the 8 consultants performed laparoscopic procedure. By 2020, all of them except 1 consultant, they were performing laparoscopic hysterectomies. With laparoscopic, the patient who underwent laparoscopic hysterectomies, they experienced short stay in the hospital and also lower incidence of readmission within 30 days of surgery, which at 6.6% compared to 12 and 14% for abdominal and vaginal approach respectively. Sorry. So this is just a graph presentation to show the change from in over the 5-year, the increase in the laparoscopic hysterectomies. So the plan was next 5-year plan, increase percentage of laparoscopic hysterectomy for benign disease, and to show this, we're planning to audit in next year, and we collect the data and we'll analyze it. So this is just the same graphical presentation of the same thing. So conclusion, any gynecological unit can effectively apply change model principle to enhance the adaptation and performance of laparoscopic hysterectomies for treating benign gynecological condition. The approach allows patients to benefit from the well-established advantages of minimal invasive surgical procedure. Thank you.
Thank you very much, Dr. Raja Hazza.
Samira.
Thank you.
Thank you.
Do we have any hands raised? Any hands up? Any questions? No questions. All right. Thank you very much.
Thank you so much.
Thank you. Now, we will go to the 7th presentation, and that is on thoracic endometriosis syndrome case series, a 2-nation catalog of frustration. And the presenter is from the group led by Dr. Segun Badejoko.
Okay. Good afternoon, everyone. Can you hear me okay?
Yeah, yes.
Thank you. And just to confirm that you can see my slides, please.
Yes, you make it presentation. That's it. Excellent. We can see.
Okay. Thank you. So my name is Shagunbade Joko. I'll be presenting thoracic endometriosis syndrome as outlined, a two-nation catalog of frustration, which is really a case series of thoracic endometriosis, which is quite rare. And my profile is as shown here. I will be presenting this work on behalf of this group, which is including myself, Akaninyene Ubom, who is currently a senior registrar in Obs and Gynae in Ile-Ife, Nigeria. Megan Curley was my F2 in Scarborough, but is currently an ST1 in Obs and Gynae. Ibrahim Awowale is based in Ile-Ife, a consultant as well. And Tefo Mokate is also based in Scarborough, as well as Louis Hayes. Tefo Mokate also has his background medical training in Nigeria, in Ibadan. So the institutions, our affiliations are as shown. So I'll start by disclosing that none of the co-authors has any relevant conflict of interest to declare related to this presentation. I must also say that this abstract has also been accepted for presentation at the forthcoming RCOG Congress in Oman, where we intend to present it as well. So this just chronicles my own experience with managing this rare presentation in gynecology in the form of thoracic endometriosis syndrome. Thoracic endometriosis syndrome is a rare disorder characterized by the presence of functioning endometrial tissue located in the pleura or the lung parenchyma or on the diaphragm. And it comprises mainly 4 clinical entities in terms of the way it presents. And these are either catamenial pneumothorax, which is air within the pleural space occurring during the menstrual period, catamenial hemothorax, which is blood accumulating in that space during periods, catamenial hemoptysis, which is coughing up of blood during periods, and finally pulmonary nodule, which is presence of endometriotic nodule either within the lungs or on the pleural surface of the lungs. The fourth of this is the rarest of all the modes of presentation. The true incidence of thoracic endometriosis syndrome remains unclear. As I said, it is a rare manifestation. Since its first description, there have been just above 250 cases reported in the medical literature till date. In recent published series, up to 1/3 of women hospitalized with diagnosed spontaneous pneumothorax had catamenial pneumothorax, which was due to thoracic endometriosis. It's something that presents later in patients with endometriosis with the ages ranging from 15 to 54 years. And pelvic endometriosis tends to precede thoracic endometriosis symptoms by 5 to 7 years. So where thoracic endometriosis appears in patients who have pre-existing pelvic endometriosis, it tends to occur 5 to 7 years after the onset of pelvic endometriosis. It is, however, also known that thoracic endometriosis can and does sometimes occur in the absence of any pelvic endometriosis at all. So it then makes it interesting how we can explain the pathophysiology of that. Most lesions are solitary, with the right hemithorax being the predominant location for obvious reasons anatomically. While you've got 5% on the left side and only 3% have bilateral involvement. Catamenial pneumothorax is the most frequent clinical presentation. And so we should go away from this presentation with that aphorism that until proven otherwise, any patients that we see with unexplained catamenial pneumothorax or hemopneumothorax or hemothorax, until proven otherwise, has thoracic endometriosis syndrome. That would help us increase our index of suspicion and improve the rate of diagnosis. Now to the case series itself, this presents a total of 4 cases, one currently being managed in Scarborough Hospital here in the UK, and 3 from that the team had been involved in managing while still in Ile-Ife, Nigeria. And we drew comparisons with the whole experience for these 2 series of patients. So the first case, which is the UK case currently being managed, is a 28-year-old nulligravida who, very interestingly also, is of Nigerian descent, actually. And I say this because in the department where I work, where we have got 14 consultants, when this patient presented, I happen to be the only person who has any experience or ever seen or managed thoracic endometriosis syndrome before. And these were patients that I had managed in Nigeria, which are the 3 cases that are included in this series. And this patient, incidentally, also happened to be Nigerian. So it then made us start contemplating the possibility of some genetic factors at play here, predisposing people of Nigerian descent or even African descent to thoracic endometriosis syndrome. Because like I said, none of the consultants who have been practicing here in the UK for many, many years, of the 14 consultants in the unit, had ever seen thoracic endometriosis as at the time we saw this patient. She was still feeling, this lady presented with acute coronary syndrome kind of chest pain. So she was referred by the GP for a chest x-ray, which the radiologist had initially classified as normal, but because she continued representing, the x-ray was later reviewed and found to have shown some pneumothorax actually. And this lady had chest tube drainage and subsequently was referred to the cardiothoracic surgeons, which is again a very common modality of presentation. Almost always, thoracic endometriosis syndrome patients present to the cardiothoracic surgeons first. So that was the case in this patient as well. And the cardiothoracic surgeons went ahead and did a video-assisted thoracoscopic surgery for this lady, resecting the lesions on the diaphragm and doing a diaphragmatic repair. And it was during this VAT surgery that they began to suspect the diagnosis of endometriosis, which was then confirmed on the histology of the specimen that they excised. Unfortunately, the gynecologist had not been involved in the management of this lady, and subsequently she was discharged and did not have the histologic diagnosis early. So she had repeated episodes of catamenial pneumothorax. This here shows some of her chest x-rays. On the left, you will find catamenial pneumothorax on the left hemithorax, and on the right, here she had catamenial hemopneumothorax. You can see the air fluid level on the image on the right. Then she went on to summarize. This lady went on to have multiple recurrent episodes of catamenial pneumothorax with chest drains. She had 7 episodes in 7 months before she was eventually seen by the gynecologist. That was our team in Scarborough. And we then immediately started her on the pituitary down, well, Zoladex, that's the GnRH analog with add-back tibolone, and also monitoring of DEXA with DEXA scans. Unfortunately for this patient, she couldn't, even after starting GnRH, she was still having episodes of pneumothorax and periods. And investigating this further, we discovered that she actually was not getting the Zoladex properly, because Zoladex, if you've ever administered it, is a very specialized kind of injection, which requires a special technique of administration, for which we then discovered that our nurses on gynae ward had not been trained. So we then did a quality improvement project to train everybody in the unit on how to administer Zoladex, and subsequently the patients began to respond. The second case is just one of the cases we managed in Nigeria to draw, to be able to compare with the UK experience that I've just described. So this Nigerian patient presented similarly to the cardiothoracic surgeons with pneumothorax, and she eventually had chest drainage, just like the UK patient. And this lady went on to have recurrent episodes of these chest tube insertions and went on to have open thoracotomy and attempts at surgical pleurodesis, which failed. And she later had chemical pleurodesis as well. She had multiple surgical interventions and ended up with bilateral thoracotomies. Subsequently, because she also had fertility challenges, she was also being evaluated and managed for infertility. And at some point, while we had started her on GnRH analogs to stop her periods, because of the fertility desire, she decided to attend a private hospital to have her myomectomy done, because she also had coexisting fibroids. And we had continued to delay her myomectomy until when we had got on top of the thoracic endometriosis syndrome. But she then went ahead to a private hospital, had her myomectomy done, and relapsed with pneumothorax and hemothorax.
You have 1 more minute. You have one more minute.
So what we will see from this, so we've got the 3 cases. I would say that the Nigerian cases had similar presentations. And it's clear that one thing that's common to all of them is delay in the diagnosis, presentation first to the cardiothoracic surgeon. And when they eventually do present to us in gynae, they have suffered a lot of morbidity, and their management ultimately becomes quite challenging. In discussing this, I would say that a high index of suspicion, therefore, based on the history and examination, knowing that the features can be quite pathognomonic, will help us to make this diagnosis early, even though this diagnosis is rare. Imaging can be very useful: CT, MRI, chest X-rays, bronchoscopy, and cytobrush can also be useful. Video-assisted thoracoscopic surgery for diagnosis and for treatment as well as laparoscopy. But ultimately, whatever treatment we're giving these patients should ideally be based on the recommendation and centered around an MDT, which unfortunately, our case in the UK made us discover was still not in existence. The UK still did not have an existing thoracic endometriosis MDT. Although we have a lot of endometriosis MDTs, thoracic endometriosis in particular requires a dedicated MDT and a regional center, which is still not in existence in the UK, as evidenced by the BSGE and RCOG joint statement on this, which was issued a few years back, to say that both organizations were working together to establish a thoracic endometriosis treatment pathway in conjunction with NHS England. And following the presentation of this patient to us, I have actually written to both the RCOG and the BSGE, as well as NHS England, and I have confirmed that with all of them that we are yet to have the thoracic endometriosis MDT in the UK set up. So while there was MDT involvement in the care of the Nigerian case, albeit on an informal basis, MDT involvement is still not present in the UK patients that we are managing. Just to conclude, the future research and QIP emanating from this series that we have looked at include exploring the underlying ethnic or genetic factors in thoracic endometriosis syndrome as possibly indicated by the Nigerian ethnicity of the UK patients and the fact that practicing in Nigeria, we have actually seen quite a number of these cases. The creation of a dedicated regional center will be strongly recommended. And like I said, from my experience in the UK, we did a local Zoladex injection QIP, and that has made a big difference in the outcome of treatment for these patients. Thank you very much. These are my references. I'm happy to take any questions.
Thank you. Do we have questions for Dr. Badejoko? Can we show by, can you stop sharing slides so we can see?
Okay, thank you.